So good afternoon, everybody. And this is the beginning of the Advanced Pediatric Endocrine Symposium, the formal beginning. And just to have a few words as to what exactly is the Advanced Pediatric Endocrinology Symposium and how we have been progressing and how we want to go forward, we'll just have a quick share on that, and then we'll start from there in that perspective from this session actually. So the first Advanced Pediatric Endocrinology Symposium was organized around 5 years ago. Before that, we had a lot of practical pediatric endocrinology courses, and Dr. Subrato has been involved right from 10 years, right from the inception. For the first course, he was there. But in 2017, we had the Advanced Pediatric Endocrine Symposium. And subsequent to that, we had second one in this venue 3 years ago. Then in COVID, we had online sessions. We couldn't have these sessions available. And as discussed, we have been evolving in terms of practical courses, social media platform, and then we started with a fellowship program, Medi-classes as a learning portal, and then finally about the textbook and mobile applications were developed. Our e-learning portals have got a lot of videos which are available, and these will also be shared subsequently on our website, and they will be available from that perspective. There are online courses which are available, which many of you are accessing already. And then subsequently, there would be the other courses which are there. There are other modules which we run every week. We have one session either for postgraduates or for fellows, which is there on streaming. Books are available, applications are available in that regards. And what we are trying to bridge, and this is what I was discussing with Dr. Subrato, is that there is a felt need of a bridge between patients and pediatric endocrinologists in the country. So there are around, at the max, 100 people whom we can count as pediatric endocrinologists. The load is huge. Now, how do we bridge between these pediatricians and pediatricians with special interest in pediatric endocrinology and then carry forward in that arm? So there is a seamless connectivity at all levels is what we are aiming at. And in that direction, we're going to come up with this personalized intelligent EMR, which is MediClinics, which actually uses an intelligent platform based upon the inputs which are provided by the physicians and gives immediate guidance with regards to diagnosis, evaluation, management. So specific conditions, you just put your inputs, you will get the information from there. And then based upon that, there would be outputs which are available with regards to the growth interpretation, puberty interpretation, with regards to other aspects, and you will get a formal sort of output which will happen in terms of what to do, how to do. And this is going to act as a bridge between the pediatricians as well as the pediatric endocrinologists. So this is something which is going to come up soon in the near future. We'll keep you posted on that in that setting, in that regard. So just to showcase what you will get based upon that would be a lot of things. So we just concluded our on-site course yesterday. This was a 3-day course. Many of you were part of that program as well. So this was the third course we did. And then we had a lot of interaction with cases and discussions which happened in that regards. So today's APES will be starting right with, we already done the diabetes workshop. We'll be starting with regards to the case conundrums. And we all know that pediatric endocrinology is often considered a mystical branch. So we are trying to get some mystical cases here. And who best to bring them out than Dr. Subrato? So we are really honored to have Dr. Subrato, who is the doyen of pediatric endocrinology in the country. He has been, in a way, friend, philosopher, and guide over the last 15 years or so since I'm in the country. And Dr. Subrato will be presenting two very, very fascinating cases of pediatric endocrinology. He needs no introduction. There's no, I think everybody would be knowing that. There's no confusion about just check the, so he basically needs no introduction in that regards. And the cases with Dr. Subrato we will be presenting today are really intriguing. I think one of the cases you discussed with me also, and then there were a lot of confusions which were there, and the final outcome was very interesting. So I think without really having anything in between you, the audience, and Dr. Subrato, I think I'll invite Dr. Subrato to kindly come up and present this very fascinating case, which is really going to be mind-boggling. We are going to have 6 very interesting cases. We will have around 10 minutes overall for the cases, and if any discussion comes up, we'll discuss on that. And so we'll start off first. Dr. Subrato is a well-known pediatric endocrinologist across the region. He is from Apollo Gleneagles, Kolkata. He did training in the US and has been working as a pillar of pediatric endocrinology in that region. Dr. Subrato, please come up and start. And I'll invite Dr. Aisha Ahmed and Dr. Vikrant to kindly come up on the stage as chairpersons for the session.
First of all, thank you, Anurag, for that glowing introduction. We have been associated for the past 15 years. Both of us came back to the country around similar time. And he is no stranger to the East. He has been coming and enlightening all the pediatricians, the students for the last 15 years. Now, I have been associated with this program and I've seen how this program has grown. And I would want all of you to give a round of ovation for Dr. Anurag. He's clearly now the current mover and shaker in pediatric endocrinology in the country. So now I think
this is the forward.
Now I think we will go on to the meat and potatoes. I'll start on a lighter note. Those of you who have seen Jolly LLB 2, when the movie concludes, almost ending, the judge says, "Kabhi aisa case aata hai, jo hame lagta hai ki is courtroom mein humko aana chahiye." Case. So today I'm going to share two cases, one at the front, one at the rear end, of kabhi jab bore ho jate ho with short stature and obesity, which is what is the 90% of our, of our general pediatric endocrinology bread and butter. So we will move from there to this fascinating case. Do not judge a book by its cover. So this was an 8-month-old female child presented to ER with history of vomiting for 3 days, was born of a non-consanguineous marriage and failure to thrive, repeated episodes of vomiting, gradual darkening of skin was noted for past 3 months, poor neck control at 8 months of age. Now this was the photo at presentation to the emergency room. What is striking in this photo is this child is really dark. Whereas 3 months ago, this was a fair child. Suddenly, Sudama has become Krishna. Now was admitted to another hospital 15 days ago with similar complaints, and where she was conservatively treated and was discharged on resolution of symptoms and was referred to our pediatric unit, which I have been running in Apollo Hospital for the last 15 years. Now look at these numbers. Sodium 111, potassium 5.3, not severely raised, bicarbonate low. So there is dyselectrolytemia with acidosis. So they managed this child somewhat such that the baby was ready for discharge in about 7 days, 6-7 days. They managed with IV fluids, K-bind sachet, and no doses. As you know, that is sodium bicarbonate. In view of failure to thrive, along with developmental delay, whole exome sequencing was sent. Now, this is what we noted on general exam: heart rate 157, respiratory rate 55. Child was really unwell, severely dehydrated, and noted generalized darkening of skin was noted. Now, what is interesting, on physical exam, and our residents are trained, because I run a very, very prolific DNB pediatric program running for the last 15 years, and we have 6 candidates per year, and we have had a lot of successes. And since I lead the unit, they're all pretty much into endocrine, and so when they come out, they are able to actually recognize. And one of the messages is, in any patient, whether it is a baby, whether it's a child or an adolescent, examination of the genitalia is, without that, the examination is incomplete. So essentially, the resident noted there was normal female genitalia. So blood reports were done on an OPD basis on the day of admission, showed hypokalemia, hyponatremia, and hypercalcemia. Actually, the way it happened, this baby was brought in the morning, As the baby came in, I noted this dark pigmentation. That's what struck me. And then I went to the reports of the other thing. I said, okay, we'll do some tests now. But within 12 hours, when we got the numbers, the baby had already started getting dehydrated. And I told them, you come now, because our labs were as follows. You know, the potassium was 7.9, sodium 123, and there was acidosis, and there was hypocalcemia. And baby was admitted, treated with normal saline bolus and hyperkalemia management. I'm sure all of you are comfortable doing it, but just to reiterate, the first thing we do is we put a 12 lead and found whether any ECG changes or not. But there were none for hyperkalemia. So hence we went ahead and used calcium gluconate. Oh, sorry, there were no ECG changes, and because there was hypercalcemia, we did not use calcium gluconate. But insulin glucose drip was started, 0.1 unit per kilo of regular insulin and 5 ml per kg of 10% dextrose over 1 hour. Soda bicarb was given, and at admission, I don't know, it's very faint, but I've made a circle around. The pH at that point was 7.27, and look at the potassium, 7.98. 12 hours later, the potassium was controlled, it was 4.24. Very aggressive management of hyperkalemia. So the OPD report we had done a couple of days ago showed low cortisol level, increased ACTH, low aldo levels. So what was it? It was Addisonian crisis due to hypoadrenalism. Injection hydrocortisone was started at 100 mg per meter square in 3 divided doses, which was then gradually tapered to 50 mg per meter square by 24 hours and was transitioned to oral by 36 to 48 hours. Tab fludro was added after oral feeding was established and continued. Extra salt supplementation was started once IV fluid was tapered off. So look at this. In a course of 72 hours, we have a sodium from 124 to 138, potassium 9 to 4.5, bicarbonate 15 to 18, and calcium 11.5 to 9.1. Now, at the time when we were planning to discharge, I examined the patient more thoroughly, because when you see normal female genitalia, that's what I'm seeing, how many layers there are of clinical exam. So I did it, there was something odd. There was 2 little bulges in the inguinal area, and I saw 2 small masses in the inguinal region. Immediately got an ultrasound, which showed no uterus or ovarian structure, but 2 small masses in the inguinal region, possibly testicular. We did the MRI of pelvis, which confirmed there's a gonadal structure at bilateral inguinal canal region with absence of uterus and ovaries. Karyotyping was sent. I was discharged on day 4 of admission. Absolutely well, full oral feeds, all imbalances were corrected. Serial weight gain was recorded for 48 hours prior to discharge. And this is how the baby looked at the time of discharge. The karyotype came back as 46XY. So we have a normal looking female with Addisonian crisis, which was missed, but the karyotype of 46XY. Something is going on. So a CAH suddenly becomes a disorder of sexual differentiation with a 46XY karyotype. So what's going on? Any guesses? Sorry? XYDHD. Any other thoughts? Huh? Very good. Excellent. So we have fantastic. So that is called registration, recall, and recognition. There are 3 R's. So that means your course attendance and the course material both were good. So congratulate Dr. Bajpai. So we proved this by doing this whole exome sequence, and it showed that the gene in the star protein coding was abnormal. and it was lipoid congenital adrenal hyperplasia. And in the steroidogenesis pathway, as you know, if the cholesterol cannot get converted to pregnenolone, all three layers, I'll come to that, all three layers, the GFR, glomerulosa, fasciculator, and reticularis, all three of them are knocked out. So that's why initially in the other lab, other hospital, they saw low 17 OHP, low cortisol, and mineralocorticoid deficiency, and this salt wasting crisis. So it is the most fatal form of CAH, and most cases are caused by recessive mutations in the gene coding for star protein. And star protein regulates the rate-limiting step in steroidogenesis, the transport of cholesterol from the outer to the inner mitochondrial membrane, and affects patients typically present with severe signs of adrenal failure in early infancy. And 46XY genetic males are phenotypic females due to disrupted testicular androgen secretion. And this is, they are salt wasting, and they're extremely rare. So this is what all three layers are knocked out. This is the baby at 16 months of age. Note the skin color is now fair, developing well, progressing well. And the plan is to rear this as a female and remove the gonads at 2 to 3 years of age. And this is how she looked just today's Thursday, just 2 days ago when they came to the OP. So take home message, ultimately it's thorough physical exam and good history. That baby who was fair becomes dark, always should strike somewhere there may be an ACTH excess. And metabolic acidosis presenting with hyponatremia and hyperkalemia. The commonest is renal failure, but right after that is adrenal. Addisonian crisis is a life-threatening condition which requires prompt treatment. Like we brought the father said, can't you wait for tomorrow? I said, no, you got to come now. And the intervention should be definite. So greetings from Kolkata, and I don't think I should take any more time. We will move on to the next case. Thank you for the opportunity.
Excellent case, Dada, for this wonderful discussion. Any inputs from Dr. Vikrant and Dr. Aisha?
Sir, we really laud you for a prompt diagnosis and saving the life of the child. Sir, I have a query. Sir, this child presented in the first week of life?
No, at 8 months of life.
Sir, actually, this is the beauty of star deficiency.
Yes.
I think it is because of the double hit hypothesis. This is what sir wants to with the message. The presentation is a little later than the typical congenital adrenal hyperplasia because the fetal zone involutes, and as a result, because of the double hit, it takes time to manifest. I think, sir.
So from 6 months of age, this was manifesting. It was missed. This recurrent vomiting, this developmental regression. And then when it was full blown, it went to the other hospital, and there was being managed by a nephrologist who was intelligent enough to say that I think it's outside my thing. He tried to bring the acidosis correction and the hyperkalemia correction and promptly send them to me. But unfortunately, it took them an extra week to get. So that's why I presented in the crisis. So the important thing is that endocrinology, pediatric endocrinology, a lot of things people think it is mystery, but it's not. And since about 5-6 of you immediately said star protein, that means it is, we are further demystifying it. So it is basically taking a good history, logically thinking, and what were the two turning points? That, you know, conversion of Sudama to Krishna. You know, that's called the translocation. I'm sorry to use, godly news, but this is a striking message. A fair kid becomes dark, and then 6 months later regains their skin color. That was one, and complete exam. We saw those two little, otherwise we would have missed that.
Thanks a lot, Dada, for this wonderful discussion, and kudos for this wonderful diagnosis. So we'll now move forward to the next session. And the next session basically would be, next talk is going to be another very interesting adrenal case. And it's going to come from Dr. Pradeep Kumar, who is as an associate professor at AIIMS Patna. And this case is extremely interesting. and rare, but again, we're talking about rare cases because this is case conundrum. So I think there was some problem in terms of streaming of slides, but now I think it should not be there. Hopefully, let's see if there's any issue. We'll try to sort it out also in that regard. So Dr. Pradeep, who has been really dynamic in setting up the pediatric endocrine unit in his department. Please go ahead.
Thank you very much, sir. Good afternoon, everyone. So we had seen a case who was diagnosed as CAH and converted into DSD and finally star defect. This is just I'm presenting this case because how you approach a Cushing syndrome and how many facets of it and how it can lead to a certain diagnosis. So this was a 12-year-old boy who actually presented for considerable weight gain for last 3 months. There was a little bit change in pigmentation, and the facial appearances also changed. And the mother noticed also a bit polyphagia and polydipsia. And there was no history of taking any medication or any herbal medications, supplements. So this is the typical faces of the child, typical Cushingoid habitus with moon faces, buffalo hump, proximal thinness, centripetal obesity, and a bit pigmentation. When we examined the child, there was also hypertension. But there was no signs of virilization. There was no, this child was not hairy. So initially we made the diagnosis of Cushing syndrome. And as we all know, the first step is to rule out, even you don't have history of medication or anything, herbal supplements, but you have to rule out exogenous Cushing's. And for that, you have to get 8 m cortisol. Although in excess state, you don't need to do it, but to rule out exogenous 8 m cortisol was done, and it was found to be 50, which is way higher than the normal range. And we ruled out exogenous Cushing syndrome. So we got midnight cortisol done when the child was sleeping, and we put indwelling catheter, and then we got it was 37. So we decided to confirm the diagnosis, and we did low dose dexamethasone suppression test, which was also high. So we made the diagnosis of ACTH. So we made the diagnosis of Cushing syndrome. All right, the exogenous Cushing we ruled out. Now the next question is whether it is ACTH dependent or ACTH independent. For that, you have to get ACTH done in the morning, which came out to be 10 picogram per ml. It was neither less than 5 nor more than 15. It was between that, but it was a bit towards higher side. We thought of extra-adrenal source of the cause of Cushing's. So next step was to find out the cause in pituitary. For that, we got MRI hypothalamic pituitary region done, and that came out to be normal. Then we had to do to find out extra pituitary cause. We did high dose dexamethasone suppression test, and it could not suppress the cortisol. Then the cortisol came out to be 49.26. So there was some, either we are missing something in the brain, or it is outside the brain. For that, the next step we did the CT chest, neck, and abdomen, but unfortunately the radiologist did not get anything in the chest while doing CT. So we were a bit, in dilemma what to do next. But there was something ectopic which was producing ACTH. Now the dilemma was whether we should do IPSS or we should try to find out some another way to look for the ectopic mass. So you must be doing IPSS is not that much easy to do, and not many centers are doing. We have one intervention neuroradiologist at our center who did DM and AIMS Delhi. He said that I'll do it. But the attendant, since it is invasive procedure, they did not allow it to do. So we decided to get PET-CT done. So finally, although it's not available at our center, but there are two centers those who are doing in Patna. So Paras Hospital has done it, and the final report has come as well circumscribed soft tissue lesion, which was in maximum dimension 55 mm. So around 5 centimeter was missed in normal CT scan. That was very actually surprised me how it was missed. So next, the same radiologist, when we shown this report, they themselves got this CT guided biopsy, and ultimately the report which came out to be was the tumors arranged in nest and sheet, and it was reported to be monomorphic round nucleus with fine chromatin and moderate amount of eosinophilic cytoplasm with no marked atypia or increased mitosis, and they put immunohistochemistry again in second stage, and it was came out to be positive for synaptophysin and ACTH, and ultimately the histological diagnosis was ectopic ACTH producing adenoma in interior mediastinum anterior to this superior vena cava. This child, but when we planned for surgical operation, you know, every child has to go for PSC, and anything comes here and there, surgeon will not do it. So eosinophil count came out to 4,000, absolute eosinophil count. Now we were searching what is the cause, but most commonly what do you do? Although there was no chest symptoms, X-ray was showing nothing, but and there was no worm or nothing. So although we tried giving DEC to this child, we had given one course, repeated after 2 weeks, it came out to be 3,000. We repeated one more dose, and it came out to be 1,000. Even then 1,000 is more for PSC clearance. But then we talked to the HOD anesthesia, and he told under risk cover, we can operate this child. So we called this child. There is a bit change in this child. When you saw this is the last picture of the child. I discussed this child to Anurag sir also. Now the typical appearance is going. The child the face is now laying, all the Cushing-wide features are not there. But what has happened? It is still dilemma for me. But anyway, the tumor has to be operated and has to be taken out. Right now, the child is put on ketoconazole, and for hypertension, in ketoconazole for androgen suppression, and enalapril for hypertension, and the child is awaiting operation. Maybe next couple of days we will admit the child and get it operated. So how do we approach a child who has got Cushing syndrome? So whenever you have a child, first rule out exogenous Cushing, then you have to rule out whether it is ACTH dependent or independent. For that, you have to get morning ACTH done. If it is less than 5, so straightforward go for CT abdomen and look for adrenal problems. If it is negative, or if it is more than 15, first step is to get MRI head done, and there are lots of diffusion weighted, flare, and etc. etc. So that will give you whether it is microadenoma or not. All right. And then if it comes out to be normal, do next step is for high dose dexamethasone suppression test to find out ectopic ACTH production. All right. Sometimes in between you can do IPSS also to know the lateralization and to know the ectopic cause. If it is negative, all right, then the next step is to do chest CT, next CT abdomen. Next step you can do, which I did. I got PET CT done, and I fortunately found out the cause. So thank you very much, sir. I'm done.
Thanks, Dr. And a very rare diagnosis. Now we were discussing as to why the ACTH was not very high and why there is a fluctuating course. So there may be an episodic secretion which is happening there. So ultimately he will require surgical excision. I think that's pretty much clear from what we were discussing. Dr. Ayesha?
Yes, we did biopsy.
Biopsy was done. Yeah,
yes,
it showed that there was a. Yeah, you've shown already. Yeah.
This is ectopic ACTH producing adenoma. They put specific stain.
So there was synaptophysin and ACTH. So actually it's a biopsy proven. So it's like a very clear case. So even if he is now gone into a sort of a shell, he'll ultimately come back. So best would be to do ultimately you will need a removal will be required. So let's not, and ketoconazole is also going on.
Yes.
So that's a drug also which will
That
suppress
might be
steroidogenesis. So that is another factor.
Eosinophilia, I don't know. I did not get, maybe because I have not proven. When you get this tropical pulmonary eosinophilia criteria, so you have to be in endemic zone. The child is in endemic zone. There has to be some respiratory symptom, which was actually not there. X-ray was not suggestive. All right, but eosinophil count was way beyond 2000. It was initially for.
Yeah.
Yes, and it gradually started coming down.
This eosinophilia has become much of a trouble for us also. So the region in which I am practicing, sir, every third patient is coming from the surgical side for reference of eosinophilia, and the anesthetists saying we are postponing the surgeries because of that, and we couldn't have a plausible reason for.
So mostly it will be that TP sort of a thing will be the problem.
Something because the zone is endemic.
Yes, that is the most thing.
So I think this case emphasizes the importance of negative feedback inhibition, what we usually teach. We normally would have been suppressed, quite suppressed, but even if it is normal, then it means there is something the source of secretion of ACTs is there.
So if your cortisol is high, ACTH should ideally be less than 5. 5 to 15 also usually is ACTH dependent. 15 and above, 80 is huge. It is for 80 actually something like hundreds because you already your cortisol is high also. So wonderful case, I think. Congratulations.
Thank you, sir.
From there. And we'll carry forward this session. We'll see if there are any questions on that. So I think now the slides must be visible. There was some initial hits, so that was the issue initially, but now it should be working. So now we'll move forward to the third case, and the third case is also very interesting. Dr. Nitya will be presenting the case. Dr. Nitya is in Ernakulam currently. Doctor, you're in Thrissur now or in Ernakulam now? So she is presenting this interesting case of hypocalcemia. Now we all see hypocalcemia as a common finding, and often hypocalcemia is basically seen more in terms of a phenomena of vitamin D deficiency, but sometimes, of course, pediatricians and endocrinologists will encounter certain other scenarios which we need to be cautious about. So welcome, Dr. Nitya, all the way from Ernakulam in Kerala, and this interesting case is there. So please, you can take from there. Yeah, please.
Thank you, sir. So a very good afternoon to one and all, respected teachers, seniors, and my colleagues. Let me thank Anurag sir for this wonderful opportunity here. Though it's a simple, straightforward case, I think maybe one of them which we may all see in our ped-endo career. So, but still, I would like to present this just to emphasize the importance of clinical examination. As we all know, we start with good history and clinical examination, half work is done. And moving on to the case, we have a girl with carpopedal spasm. Miss C, she presented to us at 4 years of age. She presented with spasm of hands and feet since 3 days, which were actually painful spasms. No history of seizures or hyperventilation, no history of vomiting, headache or drug intake, no bony deformity or fractures, no steatoria, GI symptoms, polyuria or weight loss. She was admitted at outside hospital for a similar thing and was given IV medication, was referred here. Past history, there was a significant history of excessive weight gain noticed by mother. She had taken to the doctor at 11 months of age, along with which mild developmental delay was also noticed. And she was detected to have hyperthyroidism. We got only a TSH value of 18.4. There was no free T4 value. And this TSH 18.4, for which she was started on Endocrine with 50 microgram daily. She was regularly followed up after that for 1 year. It's continued on Endocrine. And antenatal postnatal history, she was born as a full-term normal delivery. It's birth weight of 2.8 kg. There was a history of hypoglycemic seizure on day 2 of life. There was history of respiratory distress for which she was ventilated and was had some sort of sepsis kind of thing, for which she was on antibiotics and was discharged home after 2 weeks. After which she was feeling well. Developmental history, as I mentioned, there was a gross motor delay noticed. Other milestones of development were normal. And family history, she was born as a second child with third-degree consanguineous parents. And first child was 9 years, male normal child. The second was IOD actually at 8 months, male baby. The father, sister had hypothyroidism. Regarding the history of, there was no history of any short stature or any other endocrine problems in the mother history. General physical examination. Here actually physical examination was important. The child had a stocky build, the head size was normal, face was rounded with no obvious dysmorphism. Teeth, she had dental caries but no oral candidiasis noticed. Extremities, she had short hands and feet, short stubby fingers, brachydactyly. And left knee, there was actually a hyperpigmented rough plaque with wrinkled surface. Now it's on the right hand, which was a site of IV candidate, and probably calcium was given through that. Precocious and Precocious signs were negative in the normal, and she had a normal external genitalia. Coming to the anthropometric measurements, her height was less than third centile. She was short for the age, and weight was around between 10 to 25th centile, with a BMI of 16.5 at that point. Examination of systems was apparently normal. So to summarize, we have a 4-year-old girl here, born of third-degree consanguineous marriage, with hypothyroidism noticed at 11 months with excessive weight gain there, and now at 4 years presented with carpopedal spasm. On examination, she had a stocky build, as we mentioned, with some amount of subcutaneous calcification also, with systems normal. So probable diagnosis at this point would be from the system examination and the general examination could be an AHO phenotype with spasms due to hypocalcemia. It would be a picture of pseudohypoparathyroidism, as we all know. Coming to the lab investigations, I'll just read up highlight the abnormal values. Calcium was low, 5.8. Ionized calcium was 2.59, and phosphorus was 9.3. Serum magnesium was normal, and ALP was 141. Renal functions, creatinine was normal, electrolytes were normal, and blood gas was finally normal, no much acidosis. Vitamin D level was 25.7, and intact PTH was 484, it was high. Coming to urine calcium creatinine ratio was actually normal, there was no probably hypercalciuria. TSH 3.48 and 3T4 was 1.23. Just did an X-ray of the part with calcification, which proved our diagnosis of subcutaneous calcification. The ultrasound abdomen was normal. So looking at the algorithm here, we have a child with hypocalcemia. So it's basic of approach to hypocalcemia, as we know. The next step we will look at the serum phosphorus. When serum phosphorus is high, first thing to rule out is renal function. Look at the renal function test. When it's deranged, it's renal failure. Here we have a normal creatinine. So we move on to PTH, where we move on to the impaired PTH group, where the PTH production is actually there. PTH was high, and we could conclude to a diagnosis of pseudohypoparathyroidism. So this child, we have a diagnosis of pseudohypoparathyroidism. 1A, because we all know that this child has HO phenotype with probable TSH resistance, which was manifested at 11 months. So as sir yesterday said, any child with obesity and increased TSH in the first 1 year of life always think of TSH resistance, as well as of which PHP is one of the significant causes. So apart from TSH, we all know that PHP1A is because of GNAS alpha subunit of G stimulatory protein mutation, where other hormones like thyroid hormone, TSH, then GnRH and calcitonin acts. So treatment part is simple. Just to conclude what we did for the child, we have given her IV calcium gluconate infusion of 8 ml per kg with daily maintenance of vitamin D and calcitriol was started. There was a 50% of reduction of the dose on by day 2, 33% by day 3, and slowly by day 8, her calcium and phosphorus profile were better. She was discharged on day 10 with oral calcium of 2 gram per day, vitamin D and calcitriol, and final diagnosis was PHP1A, while a genetic analysis was not feasible in our hospital. The first follow-up she came, she was doing well, no cramps or spasms noted, and her serum calcium was 9.2, it was pretty good with a phosphorus of 6, and she's continued on supplements. Thank you so much. Happy to take questions.
Okay, that's it. So it was a wonderful presentation. I think the key message was that if you have a calcium, the most important is phosphorus. If your phosphorus is high, think of a PTH cost. But yesterday we discussed that if you have persistent vitamin D deficiency, you may have secondary PTH resistance. So that will also happen. So your vitamin D was normal, which was a very good point, which excluded that. Third message was infantile obesity, do a TSH and PTH. If TSH is high, PTH is high, this is PHP. You will not have hypocalcemia in the first year, but you will have subclinical hypothyroidism that will be labeled on that. Comments from Dada and the panelists?
I think it was an excellent case. Just remind me, what was the phenotype like? What all did you see in that?
It was a kind of typical age of phenotype only. She had round faces, stocky build, she was short.
Do you want to just project that? Because
Sure.
that is another take-home message, that it's a spotter. When you have short stature,
Yes.
and they have this, brachymetacardia.
This child didn't have a brachymetacardia.
And
Even clinically.
there was a calcification there. Yes, that is a calcification in the thigh was there, which was wonderfully picked up on the X-ray also.
Yes.
I think you can show the X-ray also. So if you see the X-ray, you will find this nice subcutaneous calcification which is there. So this was a classical one, but again, important that phosphorus is the most important investigation in calcium disorders. That's what the big message.
And the other thing, just what I mentioned in the first case, is that whenever we see, first of all, I'm sure nobody in this room will just do calcium because they've gone through your course. They will do calcium and phosphorus and alkaline water. This is a given, and then next level PTH and whatnot. But this constellation of hypocalcemia and hyperphosphatemia, you can see in renal failure. So always check the creatinine in these patients. Just like when you have hyponatremia and hyperkalemia, much commoner is renal failure. So don't miss that. So that is one. Anyway, you have done that.
Yes, yes.
Just emphasize that. Very well done.
Thank
you,
you.
sir.
Thanks a lot, Dr. Nitya. Wonderful presentation. We now move forward. We've discussed about 2 cases of adrenals, 1 on calcium. So now we'll move forward to another very interesting case, conundrum actually, more of a confusing scenario. And that will be presented by Dr. Vibha, who is a fellow in pediatric endocrinology in our department, Regency Center for Diabetes, Endocrinology and Research. And this was a case which is a work in progress. And as we'll see how things move on in terms of that, and there are a couple of things which are left, but it is very interesting from a conundrum perspective. So that's why we will be discussing here. So this was a case which Dr. Vibha will talk about, and how, again, as Dr. Subrato said, cases can change their diagnosis and label over time. So this is a classical example of that scenario.
Thank you, sir. Good afternoon, everyone. So a 17-year-old female born of consensual marriage came to us with a complaint of no breast development and no menstrual bleeding. And there was no history of delayed menarche in the mother and delayed shaving in father. There was no history of any chronic illness or poor appetite just for anorexia nervosa, and no history of any headache, vomiting, or difficulty in vision or seizures. No history of anosmia or any hearing problem. There was no history of vitiligo, alopecia, and no history of any recurrent illness, lethargy, weakness, or any recurrent hospital admission. And she didn't give any history of weight gain, constipation, and cold intolerance. It's not moving forward. stuck. Now on examination, her vitals were stable and all the peripheral pulses were palpable. And BP was, she was normotensive. And in the anthropometry, her height was a little bit taller than the normal girl's height. It was 1.05 SDS plus 1.05 SDS. And in the general examination, there was no Turner stigmata, there was no brachymetacarpia, and there was no syndromic facies. And her tenor staging was B1, P1, and A1. She had female genitalia, and her systemic examination were within normal limits. Now the investigation we did was a USG pelvis. Actually, I have written it first, it was done later. And there was a uterus, yes, and the length was 5.1 centimeter. And she had a right ovary with a 1 into 3 centimeter, and the left ovary was not visualized. This is the picture where you can see the uterus is here in the second picture, and in the third one, the little one in this left hand corner is the right ovary. And in the biochemical investigations, what we found, the FSH is in the higher range. It is 105.6. And the estrogen, it is not visible, it is less than 5. And the testosterone is also very, very low. So, we have a female who has developed no secondary sexual characters. She had primary amenorrhea, and her FSH is high, and she had low estrogen and testosterone. Now, what would be our differentials? So, first differential that come into our mind is the high FSH, primary amenorrhea, no secondary, is the Turner's. But I have emphasized her height was not in this taller range. We can say she had 165 centimeter height. So I would say she is not Turner's. So second differentials, it could be steroidogenesis defect, it could be star, this side chain cleavage, 17-hydroxylase deficiency, or aromatase. But in the star or this side chain cleavage, there has to be some salt wasting, but she presented with no salt wasting. Her BP was in the normal range. So this 17-hydroxylase, I would definitely rule out. And in the aromatase, we will get a history of maternal virilization and some this female ambiguous genitalia, but she had completely normal genitalia. And 17 beta HSD, yes, it could be. So next, autoimmune, but there was no history of any stalled puberty. She never, her breast development, she never had the breast development. So this, I couldn't keep it in my differentials. Another differential could be the gonadal dysgenesis. This could be a possibility. So let's see what happened. We send the karyotype. And when the karyotype report came to us, the whole spectrum changes. It came to be 46XY. So now we have a girl with 46XY karyotype. She has a uterus, and there were no palpable gonads, and she had a female external genitalia. So if we see just the karyotype and female external genitalia, what could be the possibility? One, the first possibility came to my mind was AIS, androgen insensitivity syndrome. But in that, breast has to be there. But she had no breast development. Second, if we take the 46XY with the uterus, there could be AMS deficiency or the resistance, but there was no palpable gonads, there was no testis. Sorry, I came. But if we take both, everything combinedly, 46XY with the uterus, with the non-palpable gonads, and with the female external genitalia, if we combine everything, then what could we get? It could be the 46XY with the gonadal dysgenesis. Now, how does this gonadal dysgenesis happen? Let me take you into the embryology part. The urogenital ridge. Adrenals also form from the urogenital ridge under the influence of NR5A1 gene, and kidney also develop from the urogenital ridge under the influence of WT1 and GATA4. Around 4 to 6 weeks from the same urogenital ridge, the bipotential gonad develop under the influence of S1, that is the steroidogenic factor 1, NR5-1, EMX2, WT1 and CBX2. And this gonad has the potential, it could be developed either into the testis or the ovary, but this depends on the presence of SRY gene. In the XY karyotype, the presence of SRY gene will upregulate the SOX expression, and this SOX along with the FGF9 will lead to the development of Sertoli cells, and further these Sertoli cells will produce AMH, and later they will cause the regression of the Mullerian structures, and ultimately the testis formation occurs. Now, if you see on the other hand side, in the XX chromosome, there is the absence of SRY gene. So in the absence of SRY gene and the presence of DAX1, WNT4, RSPO1 and FOXL2, the development of ovary takes place. So when there is a defect in the NR5A1 or defect in the WT1 or GATA4 or in the EMX1 or CPX2, or there is an absence of SRY gene, FGF9 or SOX9, or there is a duplication of DAX1 on FOXL2, this will lead to the defects in the testis formation. So what this lead to the gonadal dysgenesis in the 40XY this individual. Now, if I summarize genetic defects in the XY gonadal dysgenesis, how the phenotype will appear. So in the WT1 defect, it will involve the renal kidney. So tumor risks and the renal failure will be there. In the NR5A1 defect, the salt wasting will be there. In the SRY gene, which is the most common type, it causes the complete reversal of the sex. DAX-A1 will involve pituitary and the adrenal, and SOX9 will cause camptomelic dysplasias. So if we go into the algorithm, how should we approach a case of XY DSD? So it will be either due to the defect in the gonadal development, which will cause due to the defect in the genes, that is SR5, SRY and NR5A1, DAX1 for WT1, or due to Amenorrhea, or due to defect in the gonadal action. Either there would be defect in the androgen production or androgen action. If there is a defect in the androgen action, so either the 5-alpha reductase is absent or there is a resistance to the androgen receptors. If there is a defect in a problem in the androgen production, there will be only problem in the testosterone production if there is deficiency of 17 beta HSG or LHSCG receptor, or there will be adrenal will also be involved if there is a involvement in the star SCC and 3 beta HSG. And 17 hydroxylase if there is a hypertension. So thank you.
This is case in progress, and what we are seeing here is a young girl who has no breast, no pubic hair, and has got uterus. So basically, testis is not producing any testosterone. There is no estrogen being produced. There is no AMH being produced. So it goes clearly in the favor of gonadal dysgenesis. Everything is gone in that perspective. And as we were discussing with Dada, SRY, NRA51, so we will be sending the genetic panel now once we've got this thing. The key message is tall girl with primary amenorrhea is not Turner's, think of a possibility of a XY DSD. I've got 4 tall girls in which we already find XY. Second, if you have XY, you may have to think for gonadectomy. Now here the testis doesn't seem to be anywhere. It might have vanished or whatever. So we will have a look at it, but there is 0 AMH, there is 0 testo, so it is unlikely that the testis is there. But again, tall girl with primary amenorrhea, think of gonadectomy.
Only 8 point there, only one exception to that is if you have, as you know, the X chromosome has 2 parts, the P and the Q.
Yes.
If the P deletion, they have short stacks.
Yes.
If you have Q deletion, then you have later or no puberty.
Yes.
So there's one instance of Turner that you have a Q deletion.
Yeah.
You can, but you know, there's a picture before.
Yeah, so they won't be tall. So I'm talking about like 170, 65, 170. I've seen 170 also. They look like absolute male, but by default because that shocks is there which is pushing them up, but then they're not coming down. True, exactly. We had the same case yesterday of a distal deletion in XQ who was not short. So not short, so short, not short, tall. Tall is a, so 164, she was much taller than the family. That was there. Dr. Vikram?
Usually those cases present with premature ovarian insufficiency like picture where FMR1
Yes.
the Q deletion only 8%.
Yeah, so they present only as POI.
And sir, it looks like a typical case of Stewart syndrome, na? This one.
Yes, exactly. It's a pure gonad. There is nothing. Testis is producing nothing. No testo, no AMH. It's basically gone. By cellular defects, Sertoli, Leydig cell, everything is gone. So there's probably no testis there. And thanks a lot, Dr. Vibha, for such a nice summary that you've done. We'll move forward and
She presented very well, like a professor. That is good.
so the next presentation is by Dr. Sayan Banerjee. Dr. Sayan is a fellow in pediatric endocrinology and he is quite bright, and overall hopefully he will make even more impression in terms of presentation the way he presents. So this is going to be a very interesting case again. And this again, we are in a dilemma as to what really it is. And ultimately, we were able to manage and get response. But we have to look into it that how exactly this goes forward from that perspective and what exactly is the scenario there. So this case, again, a common presentation. So we've been talking about hypocalcemia, we've been talking about salt wasting, we've been talking about amenorrhea. These are common presentations with uncommon manifestations. So again, what he's presenting is a common presentation of hyperandrogenism and how we can have an uncommon cause, or maybe when we say the cause, it is really a confusing scenario here, but an interesting workup it really takes up in terms of the approach pathway that is there in terms of how do we proceed from there. So Dr. Sain.
Thank you, sir. So the topic of my presentation will be a polycystic ovarian syndrome. But after the presentation, I think most of you will be sure that all polycystic ovarian syndrome is not the classical definition of unexplained ovarian hyperandrogenism, which is only persistent for more than 2 years. So we had a 17-year-old female presenting to us with irregular menstrual cycles for the last 4 years. She also had excess hair growth over the chin, lips, chest, and back. So classical clinical hyperandrogenism features with irregular menstrual cycles. Now the history is classical. She was apparently well 4 years back when she started to have delay in her cycles, which was first in the form of delay in her expected cycle dates. Gradually started to have amenorrhea. Thereafter, classical only estrogenic bleeds, that is anovulatory bleeds of spontaneous, painless, and heavy bleeding episodes. Thereafter, around 1.5 years after she had these menstrual complaints, she started to develop gradual progressive hair growth, which started over her face, chin, chest, thighs. Now, what happens regularly is that any female with ovarian problems, that is menstrual problems, are started on a OCP by any physician seeing the girl. So similarly, without any investigation, she was started on medications and her cycles regularized. But what did not become normal is that her hyperandrogenism features that started to progress. So in spite of having relief in her menstrual cycles, as she didn't develop any clinical improvement in her hair growth, she stopped the therapy after around 1 year. Thereafter, because she didn't have any menses thereafter, she was on and off medications, and her last menstrual cycle when she presented to us was around 4 months back. She was also having weight gain for the last couple of years. Now, to exclude any known causes of illness which may cause a PCOS-like picture, we excluded regular drug intake. There was no systemic illness, no symptoms suggestive of hyperthyroidism, no breast discharge, no symptoms suggestive of virilization. And there was no weakness during walking upstairs or combing hair. That is a classical history of Cushing syndrome. We have excluded clinically. Now, on birth history, she was not an SGA child. Coming to the personal history, she had menarche around 11.5 years of age, after which she had regular menstrual cycles for only 1.5 years. Family history, there was no history of similar complaints in the family and no family history of diabetes. On examination, her BP was normal, BMI was high. So BMI in this case is 29.8. There was no acanthosis, FGS was 16. So FGS is suggestive of severe hyperandrogenism. Again, no signs of virilization like muscularity, receding hairline. And on genital examination also, we didn't find any clitoromegaly. On systemic examination, again, we didn't find any abnormality. And thereafter, with the clinical features of anovulation, hyperandrogenism without any obvious cause, we labeled the child as PCOS. Thereafter, we started to move in with the investigations that we normally do to exclude the known causes of PCOS. Next slide. So we ruled out the systemic causes, her liver function, kidney function, and her metabolic profile all were normal. Her thyroid function was normal, prolactin was normal. Now what came out was that 17 OHP was borderline. It was only 2.1 nanogram per ml. LHFSH was not suggestive of anything. So thereafter, we move on to the main investigations, and testosterone was over 100. Along with that, DHEAS, because the girl was having persistent hyperandrogenism, which was increasing, we also went in for a DHEAS, which was 762. Now, classically, as we have already discussed yesterday with the child, the child which came, any child having a DHEAS of more than 700 or more than 800, classically, we have to rule out one thing, and that is an adrenal tumor. And that is what we went forward with the next step. We did a CT scan of the abdomen that excluded an adrenal tumor because there was no evidence of any tumor found. Now we proceeded to the management as there was no obvious cause found. So we retained the diagnosis of PCOS, that is unexplained hyperandrogenism, and now went in with definitive therapy of EP along with spironolactone in this case. She was lost to follow-up during the early phases of the pandemic, but when she came back after around 1.5 years, she told us that she did not miss her therapy even once. So for 1.5 years, she was on EP plus spironolactone, but hirsutism still did not decrease. So this is where we started to think, was there any other cause of the same which was driving his hyperandrogenism? Investigations revealed testosterone of 140. So again, going to the virile range. So herein we started to think of what are the causes which can lead to adrenal hyperandrogenism. So I have taken this slide from Sperling. So it mentions that DHEAS more than 700, we always have to think of a virilizing tumor. Now we have excluded a virilizing tumor in this case. The second cause is of a rare type of CAH, which is 3-beta-HSD defect. Now the previous line before the portion I have highlighted is that DHEAS can also be elevated in a case of FAH. So what is FAH? It is a functional adrenal hyperandrogenism. So two possibilities here, a non-classical CAH, more likely a 3-beta-HSD or a functional adrenal hyperandrogenism. So how did we manage this case from here on? We stopped therapy because as these two drugs, even for 1.5 years, what was not making the person free from hyperandrogenism or hypertrichosis, we stopped this therapy for the while. Started on metformin to decrease the insulin resistance for the time being, and then went in for a genetic analysis for a non-classical CAH or a 3-beta-HSD to be more specific in this case. Now she came back after 3 months. She was still amenorrheic. We did not give her any therapy for periods likewise, but she was still amenorrheic, and this is what the investigations next time showed us after 3 months. Testosterone of 122, DHEAS of more than 1000. Now this caused us real concern. Even if we had ruled out an adrenal tumor in the first case, we repeated a CT scan again. And meanwhile, the genetic panel for non-classical CAH also came to us. There was no pathogenic mutation detected. So neither an adrenal tumor nor a 3 beta HSD defect causing this. So what is it cause? So what is the actual defect causing this rise in DHEAS? So we made a functional diagnosis of a functional adrenal hyperandrogenism, and in this case, and so what is the management of functional adrenal hyperandrogenism? What is actually functional adrenal hyperandrogenism is that the adrenals are more sensitive. So a normal ACTH push drives up a huge production of gonads, and thereafter the DHEAS rises. There is no pathology, there is no block in enzymes. It is just that the adrenal is functioning more. Management of CAH and functional adrenal hyperandrogenism remains the same. The child was started on hydrocortisone, and after so long a duration, the child had menses after 33 days of initiating therapy. Now look at the testosterone and DHEAS level. Testosterone came down to 73, DHEAS to 462. So a working diagnosis at this point of time remains a functional adrenal hyperandrogenism. But there is a question which most of you will ask. If the management is same, can we differentiate these two biochemically? Because most of the books still say that after the ACTH stimulation test, if we do a 17 pregnenolone by androstenedione ratio, then we can make a diagnosis of 3 beta HSD. Now this is what I show again from Sperling, is that after a ACTH stimulation test, if the ACTH rises to more than 10 standard deviation, then it is non-classical CAH. But again, Sperling in the same page mentions that even a rise of more than 10 standard deviation is only suggestive, not confirmatory. The next line, the primary functional adrenal hyperandrogenism also shows a rise of 17 OHP. So a biochemical diagnosis of 3 beta HSD versus functional adrenal hyperandrogenism cannot be made. Second, this is the paper which came out in the Journal of Clinical Endocrinology in the year 2004. This is what they did. All the patients who had a biochemical diagnosis of 3 beta HSD2 deficiency, they collected all the cases and went in for a genotype. Now, what did they find? They found that even who had no defects in 3 beta HSD, they had a ACTH stimulated 17 OHP of more than 12 standard deviation. So again, this is the point I want to highlight, that you cannot confirm a diagnosis of 3 beta HSD versus functional adrenal hyperandrogenism on a biochemical picture. You have to go forward for genetics, and as we freely have genetics available, so this might be the way forward. Now, one more thing, why we should do genetics in this case? Because although the management is same in the two cases, you have to give hydrocortisone, but one, CAH will require lifelong therapy. This may not require lifelong therapy. If the patient has decrease in his weight and this child has a persistent stress, because his mother passed away a couple of days back and she has been transferred to a place where she is having language problems. So maybe stress is driving this excess adrenal production. We believe this will come down, but as soon as we try to decrease his hydrocortisone dose, the child again goes into amenorrhea and we again have to increase this. How long will we go forward? I have no idea. But we hope this is not a permanent problem and we can taper the dose and clear. Thank you.
First question is that clinically,
Yes, sir.
were you suspecting non-classic CAH?
So not clinically. When the reports came, we had to.
Okay, now what genetic test did you send?
So we sent a panel for non-classical CAH.
I see. Which lab does
So
that?
MedGenome.
Okay, because I'll tell you, similar presentation. The 17 OHP wasn't raised out.
So
Yeah.
2.1.
So we were
Huh.
actually not thinking of 21 hydroxyl deficiency, we were thinking of 3 beta HSD.
But we can't do prednisolone out here.
Yes, so that's what we are trying. Finally concluded that even if we do biochemical, that is not going to be a final answer, because a lot of these patients with SAH will actually have a much higher level of 17-hydroxypregnenolone as compared to 3 beta HSD individuals. So you can't say the biochemical test is not going to tell
What
you.
was the ratio between the
So we did not.
DHEAS and androstenedione?
We
That would have thrown some light.
Yeah. So we have looked at DHEAS pretty much at that point. So DHEAS was more than 1,000, which was very much warning. We got CT twice. And once that has been done, we decided, okay, if I want to look for 3 beta HSD, I'll go for genetics rather than any more biochemical parameters.
So the point I'm bringing is nowadays, because this is how I stumbled on, I just want to share this with you, that as you know, for 21 hydroxylase, MLPA standard is good enough. So they look for duplication, and it is a cheap test compared to the clinical exome of the whole, whole exome sequencing, CES. So what happened is there was this child who, for a long time, was being considered as a CAH, but this was negative. What was it? The MLPA was negative. Still, I kept treating. With this patient had come with severe salt wasting crisis, and it was a girl. There was some fertilization. So then when I said, well, now the child is 2.5 years old, I started weaning off the hyperandrogenism and this protocol. And then the father, who was really sharp, I said, anything happens, let me know. In 36 hours, that baby decompensated. That was not a baby, it was a child. I mean, it was a toddler. Decompensated. Restarted the medication. And I said, look, so I sent a clinical exome sequence, and it came back as 3 beta HSV. So what I'm trying to say is that if you do a clinical exome sequencing, because nowadays we have a geneticist on board in Calcutta, and I've been in APES, so I've been talking a lot. So clinical exome sequencing, because now ultimately what has happened is you have a patient or a child or an adolescent with functional, where even a little bit of ACTH is making him run, is like basically a cocaine snort, I mean, start moving. Versus traditional or non-traditional CAH, where the treatment is the same. So my question now, because I noted that you gave 10 milligrams per meter square, which is actually suboptimal for a CAH, and that is working. So maybe that is what
this FAH. Yeah.
But the paper you showed were 3 beta HSV, coming with PCOS, but then you should have been able to prove the 3 beta HSV.
Yeah. So that's what
that was
that's
the
what
biochemical diagnosis of 3 beta HSD via the standard ratios of 17-hydroxypregnanolone, androstenedione, and urine steroids. They did multiple studies, and then they went in for a genetic diagnosis of that entire cohort.
That's what. But in your case, the genetics is negative.
So this is not this is not 3 beta HSD. We are saying this is FAH.
Exactly.
This is FAH. This is not 3 beta HSD. This is our final diagnosis.
That's right.
And the message, the other big message is that all this testo DHT ratio for 5 alpha reductase, this 3 beta HSD androstenedione ratio, these are just suggestive. They are not the final indicator. You have to go for genetics these days.
But even then, this diagnosis by exclusion.
Yes, so we have excluded everything.
That's right. It's a diagnosis exclusion.
Yeah.
And the second thing out here is that the fact that low doses are helping.
Yeah.
But is there no, what was the trigger? I mean, why was this THA galloping like that?
So FAH, some people are hypersensitive to the same level of ACTH. That's what FAH is.
No, but it was progressive. Why was it progressive?
No, initially also it was more than 700, 800. It came down in between on some other medications, I think, and then on steroids they came down. So we are only able to control it when we are giving a physiological, sub-physiological sort of a dose of steroids. So it looks FAH clearly in that case. So the message is that if you have significant hyperandrogenism, do testo. Testo, if it is more than 100, 150, go for imaging, number one. Number two, look for DHEAs. If DHEAs is very high, look for adrenal cause. If you have ruled out adrenal cause, think of FAH versus 3 beta HSD. So this was a confusing case, but final our diagnosis is FAH.
I just want one thing, that is science, your job tomorrow or whenever, is to call Medgeno and see whatever test you have done, the panels. Because panels sometimes.
No, this is exome sequencing, whole exome, clinical exome. Clinical exome. We did not ask for 3 beta, it was clinical exome sequence.
Right. In the clinical.
Yes.
Then if they are not found it, they are not.
It is clinical exome. Okay.
Sir, I'd like to differ a little.
Yeah.
Sir, what is the harm in doing the post-introduction test and after that a urinary profile or something? So that
Because see, ultimately what has finally come out, like this paper is what is telling us that whatever ratios you use, patients who have a genetic defect and those who do not have are the same level.
Yeah.
So it is not going to be of any consequence in terms of making the diagnosis. See, ultimately, haath kangan ko RC kaha, like you have to go basically for the final diagnosis. Genetic, yes, no, because then again you will spend much more money. 17-hydroxypregnanolone will cost thousands of rupees. So same money, they'll send a US quest will take 10,000, 20,000 rupees. By the time you get the genetic diagnosis, it's done. So it's changing. I think we have to adapt to that also, that things are changing now. Dada's case, SLO, the lipoid hyperplasia was diagnosed just based on genetics, because they hadn't done that much profile, steroid profile, and genetics got it. So we have to be ready for that. There are caveats in genetics, which I'll discuss in detail today. But we have to assume that genetics will play a more important role in making diagnosis.
And in fact, one of the messages should be, if doctors start sending these tests, the
Cost will come down.
But do it not as like a throw a lab master at a dysmorphic child, but do it in a very systematic and scientific manner.
So I think because of lack of time, we will like to proceed for the final case. Dada is coming back again with another interesting case scenario. I'll see if there are any questions in particular. So I request the chairperson also to use the mic, because it is sometimes not audible to the audience because it's been streamed also. So, so now we have the last case in the conundrum session. And this again is a very, very interesting case scenario.
So now that we are warming up a little bit, I just wanted to say in the introduction, which I held back, is Bade Miyan, Chote Miyan. Bade Miyan to Bade Miyan, Chota Miyan, Subhanallah.
So now we have this pocket Hercules. So what is this?
I might just exceed by a couple of minutes because this case is just amazing. So this is a 2-year, 9-month-old boy who walked in to my OPD with a mustache. And this is how you pick up, the clinical eye, as they say, clinical acumen. You're sitting there, looking at the parents, the child walks in, and you see peripheral vision, he's got a mustache. And then detailed questioning, onset of pubic hair since 12 months of age, upper lip hair, prominent phallus, hoarse voice, history of penile erections. This is how it looks. Look at this mustache. So what does it suggest to you as soon as you look at something like this? Maybe look at this acne. Look at that. This is a 2-year, 9-month-old. And the mother in Bengali said, Iktu Ishi. It's slightly more. So bilateral testes, enlarged testicular volume 5 to 6 cc, stretched penile 9 centimeters, pubic hair stage 4, and height age 6 years, weight age 7 years. Weight age 6 years, height age, it is obscured there. No, height age was 4.9 years, something like that. So, what is your first impression when you look at this? Precocious puberty. Yes, rapidly progressive precocious puberty, although the child was healthy and in many ways, and I'll use that word a little later on, indolent. The rest of the history was like this. Blood pressure was raised, 110/70. And also, there was another angle to this. Recurrent pain on the left side of abdomen for the last 4 months. Swelling, and on examination, swelling in the left hypochondrium and lumbar region of the abdomen, and oblongated 7 centimeters, 8 centimeters mass. So, as they say, the plot thickens. So, 2-year, 9-month-old boy, precocious puberty, abdominal mass, hypertension. What do you think of? Yes. So, one of the things is peripheral precocious puberty due to adrenal tumor. Ekdom. The other possibility, adrenal hyperplasia, 11 beta, although hypertension appears a little later, and an incidental abdominal mass. He looked so well, so healthy. Germ cell tumor and congenital adrenal hyperplasia leading to GIPP with secondary CPP. Why? Because in GIPP, your testicular size will be less than 4 cc. There was 5 to 6 cc. If you remove that,
mass business. That's something you have to think of, or, testotoxicosis, where also you have severe virilization with small testes, with testes about 5 to 6 cc's, and they don't respond to GnRH analogs. And look at this bone age. Bone age is 13. This is on the right side what a 3-year-old bone age should be from Grulich file. And in the middle is, again, Grulich file at 13. And this was the, the one, sorry, how do you go back? The one on the left panel was the X-ray of this child. So these are the numbers. FSH 0.1, LH suppressed, testosterone 4 nanogram per ml, which means 400 nanogram per deciliter. And DHES, we are talking about 700, etc., 5,000 DHES. And DHES is done in-house. So I got a call, sir, about 8 o'clock in the night. Child got admitted by 4 p.m. We sent the blood. 8 p.m. I get a call. Sir, I get a DHES more than 1,000. Should I quantify it? Of course. I've never seen such a high DHES. So, gonadotrophin independent precocious puberty with likely adrenal pathology. Serum aldosterone was raised, cortisol was normal, ACTH was suppressed, 17-OHP was normal, serum electrolytes were normal. So CAH is ruled out. Tumor markers, beta HCG, serum AFP. So germ cell tumors were ruled out. The blood pressure was raised. We did give it a lot of attention. This was a 2-year 9-month by 100 by 70, 110 by 70. So we started Lipitor, keep raising the dose. And then we looked at end organ dysfunction, but 2D echo was normal, renal function was normal, fundoscopy was normal. And the response to Lipitor was somewhat muted. But because we got the aldo level, we started spironolactone. Blood pressure started improving. But this is what we did on the night of the patient getting admitted. We got a CCT done. No, the next morning, early morning. And that's what it shows this, paravertebral region, a huge mass of necrosis or calcification. Now look at this. This was the section. And look, I mean, the pointer is not working, but you see how this is the इसी से होता है अच्छा अच्छा ठीक you see this anyway, just see the left adrenal is that mass out there and how it is distinct from the abdominal mass. So the CT showed there was a mass which was distinct from the tumor. So then we kept thinking maybe it is germ cell or it is rest, adrenal rest in the retroperitoneum. And so all these thoughts were there. But we did a biopsy. The synaptophysin was positive. So clearly, ACTH was around. And this we did, the calretinine, which is an immunohistochemistry marker in which 95%, if it is positive, 95% sensitive for adrenal cortex. And chromogranin A is, if it is positive, it is significant for adrenal medulla. And it's very important to make the distinction, pre-op, in case there are some medullary, aspects when you're really handling it and doing this and that, we might have a hypertensive crisis. But when we proved that this is entirely an adrenal cortical origin, we went ahead and did the surgery. It was huge, 8 centimeters plus, and a tip of the adrenal. The adrenal was actually attached to the rest, so it was rising from the adrenal. And this is how it looks. It really looks gross. Now, this is the beauty, this slide. Normal adrenal tissue and how it goes on to the tumor cells. And so this indeed was an adrenal tumor. Now, this is a magnified view, and I'm not going to go into all the criteria, but just to share with you the Weiss criteria, which decides whether it is a carcinoma or an adenoma. Now, one thing to remember, whenever we read pediatric endocrinology books or listen to lectures, any small child with adrenal tumor is cancer unless proved otherwise. It's adrenal carcinoma in this young age group. But this baby, this child had an intact, they had an intact cortex, and there was no other spreads anywhere. CT chest was normal. And so this is what happened post-op. As soon as the thing was resected in entirety, the DHEAS fell to 5.4, testosterone went down, ACTH came up. Now, there was a cortisol went down. So, there was some, there was some suppression of the, fasciculator, because it was the reticularis which was working overtime and producing the huge amounts of DHEA, which was getting converted to testosterone. So we did the ACTH stimulation test, and we found that the reserves were not good enough. It was less than the stimulated levels were less than 20. So we, so this is the final diagnosis: adrenal adenoma leading to gonadotropin, GIPP, and hypertension, excision of tumor and left adrenalectomy, and post-operative cortisol deficiency. So what are the conundrums? 8+ centimeter adrenal tumor with intact capsule, with benign cytology and Weiss criteria. Is that possible? Literature differs. Anything beyond 4 centimeters is malignancy unless proven otherwise. So what are we going to do? They are going to publish this because it's the largest tumor ever known to man or beast in a 2-year, 9-month-old. What was the cause of the hypertension? I mean, we're talking on one hand, the pure gonadotropin, gonadotropin independent, precocious puberty. And then where does the hypertension come from? And actually the blood pressure levels came down before discharge. And then when we saw for follow-up and we reduce the antihypertensive, the blood pressures come up again. So it is another conundrum we haven't solved, but we will get to it when he comes back again. So why were the aldo levels elevated, which fell after the tumor resections? How should he be monitored clinically and biochemically? So our plan right now is going by conventional wisdom. Don't outright declare he's the first avatar of a 9 centimeter normal, adenomatous adrenal, but follow up every 3 months, do a USG and a DHEAS and see if that starts going up, then we will think of doing a PET scan or other things. And what will be his final height? He is 104 centimeters, bone age of 13. I think he's going to be pocket Hercules. That's why the name. So thank you for your patience.
I have a doubt, sir. So shouldn't the biopsy be repeated again, sir, at some other centers, sir? So because there are certain odd points which are against, as you told, size is one of the factors.
No, Baki, if you see the Weiss criteria, I didn't want, in interest of time, go into all the details. This is the Weiss criteria, in which 3 or more have to be positive for adrenal cortical carcinoma. And here, none of them except necrosis was positive. So the pathologist actually thumped on the table and said, no.
I think that's a very, very interesting case, but I would be very wary because it doesn't look like a single monoclonal tumor. It looks like it is also producing some aldosterone, it is also producing some cortisol. And that is why his bone age is so much and his height is also not that much. It basically means that cortisol is pulling him down and androgen and estrogen is pushing him up.
But his cortisol was only 7.
But why did he develop post? So there was some subclinical hypercortisolism.
There must have been because his ACTH was suppressed.
Yes.
So once we removed it,
but it went up. So there is probably this at least 2 lines you are saying aldosterone was also on the higher side. So it doesn't look like a monoclonal one. it looks like biclonal or polyclonal, which means it is not a benign one. It may be more towards malignancy. So I will vary. I'm not saying that we have to do anything. We have, as you
You're
always said.
absolutely right. That's why I put those conundrums at the
Yes.
end. I
That's
mean,
very-
this is truly the conundrum that on one hand, we have this, and also this bone age, it has gone. I mean, so even though the parents said "Ektu bereche," this has been going on from 6 months of age or something like that,
Yeah.
which is absolutely in the carcinoma,
Yes.
category. But the high levels of DHEAS has pushed this bone age from a 3-year-old to 13 years, 10 years in 2 years' time. And the point is, with so much aggression in the growth of the tumor, by now you would have expected the capsule to have ruptured,
Yeah.
mets.
So very, very, very interesting. And the big message probably is that if you have short, like his bone age is advanced and he's not that tall. He's only 4 years as far as height age is concerned. So there's something cortisol is also doing.
That is exactly the point, because when we have a genuine patient with, adrenal carcinoma, it was beautiful. It was completely hairy. It was a girl, and beard, mustache, all that, and was Cushingoid. When we removed the tumor, which was carcinoma, everything fell off, and there the bone age was a 10-month-old with a bone age of 9 months, because it had balanced beautifully.
Yeah.
But the cortisol values were not that high.
I think, but that's a very, very wonderful case. I think round of applause for Dada for these two wonderful cases. And I think that will bring us to the end of the session. I now request Dr. Neha to kindly.
Sir, I have one question.
Yeah.
I would like to have your comment on where these patients were unilateral here.
Yeah.
Carcinoma or adrenal adenoma is there.
Yeah.
So other adrenal is suppressed or down regulating the receptor. How we should proceed to how it comes up?
So definitely in the initial phase, you have to cover with perioperative steroid cover, stress dosage, start with a physiological replacement, and then gradually try to build up. Because there will be suppression. If it's a unilateral adenoma, 100%, if it's a cortisol producing adenoma, you will suppress the other axis. So you will have to give low dose. So initially stress, complete 100 milligram per meter square, and then try to build up and then gradually go from
Which
it.
is what we did.
Yeah.
This baby was, this child was actually sent home. That's why we did the ACTH stimulation test, because we were worried about that. And we started the replacement, and with the proviso that if there is sickness, you triple the dose, because as you rightly said, the other gland is suppressed. And once we remove this, and Dr. Bajpayee at that point, the one gland is producing more cortisol, ACTH is suppressed, so obviously the other gland is also suppressed. But having said that, that was the only contention, is the cortisol levels were not as high as we would have expected. But having said that, ultimately it is a biochemical test. And what was beautiful is when we repeated it, it fell. So I agree, there is some aspect of overproduction. So maybe that's why. Yes, and the blood pressure is high, but the endo is also high.
So there's a polyclonal.
But just to clarify the point which Dr. Rag has said, that if there was some, there was some confrontation between testosterone and cortisol as far as the bone age is advanced so much, it's like the DHEAS, the cortisol को एक ग्राम दबा दिया. In the sense that producing some bone age delay has been completely.
But height has not increased that. Height has not increased that. So you should have grown height.
No, but bone age will come in.
Thank you, sir, for such a nice case. Just two issues still we have to, because this is really a conundrum case, and I really appreciate that small Hercules. That testicular volume, 6 ml, still we have to.
Sir. You see, what happens is that these children, when they bone age goes beyond 11 or 12, they go into secondary CPP.
Yes.
And that's when the testes can increase in size. But here we have no way of knowing, because the DHEAS has trashed the FSH.
Yes.
So I'm giving it time now to see if the FSH start drifting up, and maybe 3 months down the line, I do a GnRH stimulation test, because that might again continue to increase the bone age and make the child even shorter.
And one more make note for trainees that if this type of case is there and before even biopsy, we can ask some more details about radiologists that what is the strength of HOE, that Hounsfield unit. So if Hounsfield unit is very pretty much high, it 3 digits, probability of say malignancy is very high, and that child should be definitely done for biopsy. So that is my additional point.
So the classical differentiating feature on radiology are 5 more than 4 centimeters, heterogeneous, enhancement which is retained, and you have a Hounsfield unit more than +20. So these will be benign versus malignant. So more than 4 centimeters, adults they say it is malignant.
Yes.
So we don't stop thinking about that.
And then adult endocrinology you say that I don't believe. You wait for this 6 months until you publish this case as the first case of giant adenoma. But one of the points, this is again for the trainees, normally in pediatrics you do 5 millimeter cuts for anything else, but in adrenal, remember you do 3 millimeter cuts. Yes, and ultra thin slices 1 millimeter cuts, which is also some people like HRC, that's nothing but 1 millimeter. So here, because we did not do 5 millimeter cuts, the adrenal and the mass were conjoined, it didn't appear. In fact, the picture showed they were separate because of 5 millimeter cuts. Anyway, this was a very learning case for us. I hope we have all learned something.
Thanks, Dr. Subroto, for this wonderful discussion. We got very good 6 cases. I now request Dr. Neha to hand over the memento of appreciation of Dr. Subroto.
Neha is now my neighbor in Kolkata.
Yeah. Yeah.
I request Dr. Vijay to give a memento to Dr. Ayesha. Close neighbors, Meerut and Aligarh, very close.
Actually, pediatric endocrinology again a very closely related society, so we can't define those.
I request Dr. Mahesh to kindly come up and hand over to Dr. Vikrant. So thank you. We close the session there. Now to start the second session, which is on endocrine diagnostics. So this session will basically focus on the diagnostic dilemmas. For this, I like to invite Dr. Anjali Tiwari, who is the medical superintendent and the head of laboratory sciences at Regency Health. And she has been working a lot in terms of quality control and how the assays are run very well. So we are always relying on her to have reliable, valid and precise assays. Dr. Anjali, please. Welcome, Dr. Anjali. I'll request Dr. Vijay Jaiswal, who is the professor and head of department at Department of Pediatrics, LLMRC Medical College, Meerut, to come up on the stage and to join us. And Dr. Vijay has been with us for the last so many years. I think first 10 years, all the programs he's been coming. So most people are coming all the time. So this is very, very good feeling in that perspective. So we will have 4 sessions in this program, endocrine diagnostics. Then second would be about bone age. Dr. Hemchand's slide might be delayed, so we'll see how it goes. And then your session on bone density, and then finally genetics. So the first session would be on endocrine diagnostics. Before that, I'll have some inputs from Dr. Anjali about how to lab, key mantras of lab.
Thank you, Dr. Anurag. Thank you for giving me this opportunity to come to this esteemed gathering. And I could attend some part of the previous lecture, which was very, very interesting. And the only key mantra for any laboratory, whether that is biochemistry or hormone or even histology or whatever, the only key mantra is that we have to take into consideration all the three phases, which is the pre-analytic phase, analytic phase, and post-analytic phase. So, and then while choosing the instruments or choosing the test methodology, we need to do verification or of whatever claims those manufacturing companies are doing, you know. So to verify, there are certain things which you have to do. That I mean, if the company says that this is the range of testing for a particular parameter, then you have to ensure that whatever is the lower range of the testing, that is to be confirmed, and whatever is the highest range of, because highest normally we consider that whatever they have claimed, if there are any parameters which come above that upper range of testing, then we have to dilute the samples and then we have to retest. But as far as the lower range is concerned, that we have to confirm for every test and every method by continuously diluting the samples and coming up to the range, whatever the claims were made by the manufacturers. So that is one thing which is very important. And similarly, I mean, this stands true for both the things, for the test methodology and for the instrument as well. And then apart from that, as far as pre-analytic is concerned, and especially when we talk about hormones and endocrinology, then all of us know that there are so many variations that could be circadian rhythm or seasonal or cyclical. So many variations are there, and the hormones also could be the bile and stable. So depending on that, we have to take special care while taking the sample, that what while we have to choose. So like for all the bile parameters, always plasma samples preferred. So most of the time we use PDTA or lithium in containers. And for rest of the hormones, we can use plain sample as well. Then another important thing is that not only the time, the test which you are going to choose, your clinicians, know much more than us, that which test should be chosen and what should be the right time for that testing. And then similarly, after taking the samples, how that sample should be transported to a lab. That is very important. And how that packaging should be done, what should be the temperature at which the sample should be transported to the lab. That is again a very important aspect as far as pre-analytic is concerned. Then more than that, the first and foremost thing is labeling the right sample, so that before taking any sample, I would always suggest that you should put the name and other identification of that patient before taking out the sample, so that there is no confusion as far as patient is concerned, whether it is OPT based or it is IPT based. That is about pre-analytic, some of the points which we can take care of. Then for analytic phase, I would say that the most important thing is quality assurance. And when we talk about quality assurance, we have to ensure the internal quality as well as external quality. So for all these things like precision and how precisely you can reproduce the samples and all those things are important. So normally for hormones, we run 3 levels of internal controls: low, normal, and high. So that's very important. And if your lab is working for more than 8 hours, then you have to run 3 levels of controls every day. And one should not work on the manufacturer's guideline. Whatever mean and the range is given by the manufacturer, good laboratory results only come and the precise results only come when you work on the lab generated mean. So what normally we do that for initial 40 or 30, depending on the lab. So we run these controls for 30 days and then we take a mean. Once that mean is generated by the lab, then we calculate the plus minus 2 SD range. So your result for that particular parameter or that level of the control, it should come between that range. So that's very important. And once we ensure that it is there, so you will always find that, like, suppose if somebody says that the range is 5 to 20, so their mean would be something else. But once you start using your own lab, that takes into consideration all the environmental factors. And when I say environmental factors, that means the age of the filters which we are going to use, type of machine which we are going to use, the life of the bulb which is going to emit the light, because most of these tests which we do that use.
So Dr. Anjali is really scaring everybody that the results we get, there are so many other variables which are go wrong. So you have to be very, very careful.
And then similarly for accuracy, we have to do EQUAS, and for that we get lots of programs. PT providers are there all around the world, and you can ask for samples, and those PT providers send you unknown samples. So you have to test and you send it back. So then they have various groups depending on the type of methodology which you are using and the type of instrument which you are using, and your result will be compared amongst that peer group. And that would show if your results are well within acceptable range, that means your results are good, or if they are not, because pathologists and clinicians, they keep fighting, often we also fight. So many a times Dr. Anurag would say that you need to repeat, and I say no, because I have seen my controls, they are absolutely fine. If you ask, I will repeat it, but if the same result comes, then you will be responsible for that.
Okay.
So
I
that's
think
the thing.
what we'll do now is that we will go forward the same scenario Dr. Anjali talked about, the problems which may happen in practical terms, what we encounter, and how it becomes relevant in that regard. Now, we all know in hormones, unless you do testing, there will be no problem. You can't get anywhere. So you have to do a testing. They often change your decision, but that is not very simple. Often you say whatever result is there, you get the result and you manage that way. Now, you require assays which are precise, accurate, and interpret in a proper fashion in that regard. The problems are even more in a pediatric assessment, because there the assays become very complicated. The range is much more. The levels may be different in a 0 year, 1 year, 12 year, 14 years. There are problems of pubertal transition. There are problems of neonatal transition, and a lot of variations which happen. So that's why we need to be even more cautious in that regards to assess in that scenario. So whenever you say that you have written a particular test and you get a test report, often you are happy that whatever the report is there is absolutely right. I don't have to think about anything. But remember, there are many steps which are involved in there. Starting right away with the test which you have recommended. Is it the right test or not? Have you done at the right time or not? Have you taken the right container or not? Have you sent it properly or not? And then finally, which method was done? So all of these things become important. So common errors, as Dr. Anjali said, could be pre-analytical, and 50% of errors are pre-analytical. Even before it has reached the lab, error has been done. So you have done some problems, 30% will be analytical, 20% will be post-analytical. So 50% pre-analytical, you have written a wrong test type, wrong sampling, processing is wrong. Then analytical, you have chosen the wrong technique, quality control is not there. And finally, you are not interpreting and reporting it properly. The most important part of a stethoscope is considered to be in between the ears. Similarly, the most important part in a lab is how you are interpreting that report. A PTH level of 50 will have different connotation for a calcium of 4, calcium of 8, and a calcium of 14. In one scenario, it will be hypoparathyroidism, one it will be normal, other will be hyperparathyroidism. So you have to be very cautious in how you are interpreting in that regard. So we'll start off with cases. It will all be interactive cases. So it's just like what happens in our OPD. Naveen will see some case and he will ask what is to be done, what is the problem, whether we should go to Dr. Anjali or not. So we'll do that way. Let's start.
We had this 10-year-old boy who came with complaints of growth failure, and on examination, his height was 127 centimeters, which was minus 2.4 SGS, and his weight was even more compromised, and which was minus 4.8 SGS, and he had a screening workup done, and which was found to be normal, and he also got the IGF-1 levels done, which was found to be low, and based on the IGF levels done, the patient was started on growth hormone therapy. So was it the right decision to start on growth hormone therapy in this case?
So this is a classical case of a pre-analytical problem. What we are seeing here is that this child is actually having a significant malnutrition. the weight is less. And we all know what happens in malnutrition to IGF-1 goes down. So it is a wrong thing to do IGF-1 in a malnourished child. So that's why this is a falsely low level of IGF-1. We should have done a growth hormone stimulation. And remember, IGF-1 is a screening test. So there, I don't need to go to Dr. Anjali. I can say this is wrong. Do a growth hormone testing, and this was normal. So this was a wrong test in the wrong setting. So this case very, very easy to identify. So don't do IGF-1 in somebody who is malnourished. So which test should we order? Normally, if you have large peptides like thyroid, cortisol, testosterone, these situations you can do a single test. The actual hormone can be. If you have a labile hormone like insulin, like AVP, then you want to use co-secretor. So if you want to assess insulin, half-life is 5 minutes. So then you can look at C-peptide. If you want to look at AVP, the half-life is 3 minutes. You go copeptin. That will be a better thing. If you want to look at the effect, you can look for calcium for the effect of PTH. You can look for ketones in insulin. So if you have hypoketotic hypoglycemia, that is more relevant for insulin than the actual insulin level. We discussed this in much more detail. And then you can look at metabolites, especially for steroidogenic defects in that scenario. So second case, Ravi.
We had this 15-year-old boy who came with concern for obesity. On examination, he was found to be hypertensive, and the classical finding of abdominal striae, which was thick villaceous, and his also BP was suggested hypertension, which was 140/90, and overnight suppression test was done, which was 14 nm/liter, and the patient was taken on an ACTH sample, which was serum, and it was found to be 50 pg/ml. Despite the high levels of ACTH, the MRI was found to be normal. So what could be the thing which went wrong in this case?
So one situation in which always things go wrong is Cushing syndrome. Often people tend to do a lot of confusions. Wrong test, wrong time. So what happened here was that first the overnight suppression was good. He was suppressed well on overnight. But then somebody got an ACTH done, which was 50. Now this, the guardian is concerned that this could be a CNS problem. But what is wrong, Dr. Anjali, here? They have done something wrong in the ACTH sampling. They have taken the sample in the serum. While it should be, as Dr. Anjali very nicely said, that if you have a labile hormone, do it in a plasma. So if you do a serum, your levels will be variable. So wrong type of test sample has been done in this case. So if whole blood basically is more for labile, so you can use it for those changes. But mostly it is point of care. Like you want to do a blood sugar, you want to do a HbA1c, you do it right away. Otherwise, you remove the blood cells using heparin EDTA, you will get a plasma, which is good for ACTH, which is good for PTH, these sort of things. And these have to be then sent on ice. This I'll talk about later, but again, you have to be careful. This is labile, so you have to send on ice. And finally, stable hormones, most of them you can do it on a serum sample. That will be like peptides, steroids. So again, wrong sample type will also affect the outcome, which you have to be careful about. Next scenario.
We had this 11-year-old boy with a concern for again growth failure, and its height was severely compromised, which was minus 5.4 SDS. And on examination, he had immature facies, and the screening investigations were done, and which was found to be normal. And based on the basal growth hormone level, the patient was started on growth hormone therapy. And is it advisable to start growth hormone therapy based on the basal growth hormone level?
So do you agree with the diagnosis? He is very short. His basal growth hormone is low, so why don't you consider him growth hormone deficiency? Do you agree? But will you diagnose growth hormone deficiency here? So it is not chances, you have to go for a definite test. Now what you need to remember is that basically, if you have a pulsatile hormone like growth hormone, basal growth hormone is a waste of money. So don't do a basal growth hormone, do a growth hormone stimulation test. So stimulation test is required for many scenarios. Then if there is a diurnal variation, particularly for cortisol, you have to do at the right time. Cortisol is basically highest in the morning, lowest at the night. So if you are looking for deficiency, you should do it in the morning, excess at night. So that is very important. So 8 AM becomes very, very important in that regard. Then, of course, if you have hormones which are affected by the menstrual cycle, often we get LH, FSH levels done at day 14. There you will have anyway the peak. So this will not be a good way to go forward. Some hormones are affected by season, like vitamin D, estradiol, and all those things are affected. So you need to know which hormones are affected by which, and then you order at the right time. So if you have, suppose, a pulsatile hormone, like growth hormone, what do you do in that scenario? You can do a pooled sample. So Dr. Anjali, can you just summarize what pooled sample means? Often people get confused.
Like normally you take more than one sample, like 3 samples usually are preferred at the difference of 20 minutes, like 0, 20 and 40 minutes. You take 3
So do they have to pay 3 times?
No, they don't need to pay 3 times. You have to take 3 samples and all the samples are centrifuged, and the plasma or serum, whatever you are testing, you have to mix it, and then that with that pooled single reading is given to the patient.
This is often confusing. So I have seen people who have done 0, 15, 30, 3 samples. So you have to pool. So you have to pool 0, 15, 30, then this pulsatility becomes less. No, different containers, and then after removing.
That's what I said, you have to centrifuge all the samples, and then you have to pool equal amount of water samples, and then mix it properly, and then test.
Yes. So you might have missed a pulse.
Not averaging, you know.
No, not like that. Because growth hormone pulses are only 7 to 10 times a day. So you pool the whole day, you can do. You can take 15 minutes every day and then pool, that is okay. But not for growth hormone. LH pulses are more. No, single.
Single report is given, and it is never average, no average is given, you know, like the first sample X reading X plus Y plus Z.
No. So basically what is done is that
you're taking a sample, you're mixing all equal amount of all the 3 samples, and then mix it properly, and then you run it.
Yeah.
And whatever is the result, that is reported.
So you mix all the samples. So that is the way. So if suppose one was low, one was high, it will automatically become an average. So this is a very important concept. Second, if you want to look at timing, cortisol, morning you do for deficiency, evening you do for excess. Co-secretion, again as I said, insulin difficult, do C-peptide, that will be option. And then dynamic tests come in, and as Naveen was saying, if it is high, suppress it. If it's low, stimulate it. So do a growth hormone stimulation test in this scenario. Now next case, Naveen.
We had this 13-year-old boy who came with concern for weakness, and on examination he had pigmentation, and his cortisol level was done, which was found to be low, 120 nanometer, but the electrolytes were normal. And based on the low level of cortisol, the patient was started on hydrocortisone therapy. Was it the right patient to start therapy?
So again, the message is, when was this taken? Cortisol will be low at midnight anyway. So if it was done at 8 a.m., I will give more meaning to that. So now 8 a.m. value was normal. So again, always go for timing. 7 to 9 a.m. is the best time for cortisol. Again, wrong timing will cause a confusion in that scenario. So this is the diurnal variation, as I said. Do for deficiency in the morning, excess midnight cortisol is what is recommended in that scenario.
Next case, we have this 15-year-old girl with complaints of hirsutism and menstrual irregularity, and her FGS score was 12. And based on the LH levels, she was labeled as a case of PCOS. LH levels were very high, 22. And is it really a case of PCOS based on this LH level?
So what will be the first question you will ask, Dr. Anjali, in this case?
When did you take the sample?
What day of the menstrual cycle did you take it? So that's a very relevant question. So we repeated on day 2 of periods, it was normal. So if you do it in a secretory phase, in the next luteal phase, your LH will be high. But you should do it between day 2 to 5. That is the big message which is coming out of here in that scenario. Now, problem of cyclical variation, you should do a particular timing becomes relevant in that regards.
And we move on to the next case. We had a 6-month-old girl with complaints of seizures, and it was found to be a hypocalcemic seizure with calcium levels were found to be very low, and the phosphorus also was found to be very low. And PTH was done, which was also found to be very low, and the patient was labeled hypoparathyroidism. So do you agree with the diagnosis?
Dr. Vijay, do you agree?
No, of course not. We have to be really very cautious. First is that your good history, your clinical exam, and the things are. PTS is a very fragile molecule actually. So if you are thinking that something, what you were expecting in this case, and that is not going in hand, then obviously you have to think that how that PTS sample was transported over there. So there can be the problem of transportation, because if you are not transporting on dry ice or if you are not maintaining the temperature, probably even the pH is very high, it is going to be always low, and you are going to make the diagnosis on the wrong way.
So here the phosphorus level was low, which will really go against a diagnosis of hypoparathyroidism. So as Dr. Vijay said, always be very careful for PTH. Often collection center people will come and they will give, by the time the level PTH, insulin, ACTH. I never rely on those values, and I ask Dr. Anjali, you do it immediately here and we find different results. That is a big message here. So vitamin D was low, so vitamin D deficiency was the cause, and pseudo was labeled. When we did PTH, it was found to be high. So it has to be sent on ice. In-house laboratory becomes very important in this regard. So how do you transport ACTH, PTH, insulin and renin? Always in a chilled tube. This is very important. Do not freeze IGF-1. If you freeze IGF-1 or AVP, you will go, because they are more like a biological hormones are there. And often many do not require temperature. Growth hormone, cortisol, thyroid, they don't really affect it. But remember, for these four, don't give it in a collection center. If a lab is doing, they should send with a proper process to send it. Otherwise, your results will be variable. We take very special precaution in these samples. And Dr. Anjali's instruction that ACTH should be processed immediately and we get the right results. That is a big message.
We had a 7-year-old girl with early puberty, and on examination, the staging was 3 with pubic staging of 2, and the bone age was very much advanced with bone age of 10 years. And the workup was done, and which showed LH of 1.2, FS of 2.2, and estradiol was low. On the basis of the estradiol, the patient was not given any treatment to agree with the plan of action.
So this girl has definite precocious puberty. LH is high, and I said LH is very important. But why is the estrogen low? And this is not an uncommon problem. Dr. Vijay, what do you think is happening here? The assays of estrogen are basically developed for reproductive women. They are developed for a high range of estradiol, 100, 50, 100, not for low level. So at low level, the coefficient of variation will be very high. So they will be very unreliable at low level. Testosterone will also be unreliable in females because the sensitivity, as Dr. Anjali said, that sensitivity will vary according to that. You have to check the sensitivity is actually there or not. So this is important. At low levels, you will have a lot of variations which are there. So this is basically because of the wrong technique. So immunoassays are not very good to get that low level of estradiol or testosterone or cortisol in the newborn period. What would be better is actually to go for a GCMS if you have available. Unfortunately, it is more expensive, but it is a good test in a specific situation. Or if you work like me, I would say the girl has precocious puberty, estrogen has to be high. I ignore that estrogen. I go more with LH, which is a more reliable test. So clearly, if you use your clinical judgment, you can then say, otherwise if you argue estrogen is only less than 5, so I would say do a GCMS. But that is like, why unnecessarily wasting so much money? So this is a big message, which test you are looking at. If you are looking at precocious puberty, look at LH. If you are looking at hypocalcemia, look at phosphorus. If you are looking at hypoglycemia, look at ketone. There are key tests, and everything else in clinical picture comes onto that. And this is commonly seen problem because immunoacids are like that. They are not meant for 5, 10, 2, 3. They are not going to measure that. They will be at a higher level. They will measure that way.
We had a 10-year-old girl with hypothyroidism, and she was started on levothyroxine of 100 microgram. And when she got a lab testing done, the cases was found to be 54. But the father gave the history that he was very much compliant with the doses. And when we did the examination, she was found to be euthyroid. So we had a doubt in the TSS level. So when we got it repeated, we found that the TSS levels were normal. So what is the reason for discrepancy between the two TSS levels?
So we have been talking about pre-analytical. Now it is time to have a dialogue with Dr. Anjali. First report was 54. Next is 2.5. So what could be the possible reasons which are there?
In good labs, always there's a practice of doing carryover studies, because if some previous sample was very high, and if probe is not being cleared by the machine properly, then there could be a carryover effect in these cases. And for that, I would suggest if you, well, I mean, because nowadays many of the endocrinologists, they also have their labs. So for that, you must do this kind of carrier studies every quarterly. And in that, you have to run low-level samples twice. Then you have to run same high-level sample thrice, and again you run once again. So you take the mean of those two low-level samples, and then with that mean you take out the difference, percentage difference of the last low-level same sample, and that says that okay, like if that is well within acceptable range, the variation should not be more than 10%.
Yeah.
So if that is there, then you can accept it. Otherwise, it will be
so carryover effect basically, suppose somebody had a PSH of more than 100 just before that, and you are not washing it properly, the next level will be falsely high. So this can happen. So if something is not fitting, there is nothing wrong, ask for a repeat. But and then you will get the result. But if your lab is good, as Dr. Anjali is maintaining the carryover effect, you will not be facing this problem. But we have seen this problem, which can happen in different labs also. So it is not that the lab was wrong, it is because the carryover effect was not taken into consideration. So next.
Next, we had a 12-year-old boy who was diagnosed a case of 21 hydroxylase deficiency, and he was on a stable dose of hydrocortisone at 15 mg per meter square per day. And he got a lab report of 17 volts Vd, which is found to be slightly higher. And his dad, on seeing the report, he wanted to repeat it again with another lab. And when he got it repeated with the other lab, he found it, the 17 volts was found to be in the normal range. And what is the reason for difference between two labs? And is it necessary to treat this or increase or decrease the dose based on these levels?
I think this is an important question. We need to understand what is the coefficient of variation. Every test will have a coefficient of variation. So 4, 3, if you take as cutoff, 4 is high, 2.4 is normal. But there is a 20% CV which may happen. So you may, any value may be 20% higher or 20% lower. So this is a coefficient of variation. Don't get stuck to a particular number. And anyway, when we see in this scenario, levels more than 10 you have to treat. So there is always a range. There is variations which may happen, and you can't ignore those variations.
Right. So these variations also, there are guidelines which say that the allowable error.
Yes.
So we need to understand that for which parameter, how much is allowable error. I mean, some of you might be surprised that for certain parameters, it goes up to 40%.
Exactly, because PSH has got a 0.5 to 5. It is like 10 times, 1000% biological variation. So 40% is nothing. So that means that if you have 40% variation also is acceptable. So this is something you need to understand, that variation will be there. Don't get stuck to the number. Now this is something which often people get confused, accuracy and precision. So precision is reliability. Every time you say that this is there, you may be wrong, but you are saying every time you are saying this is there. Accuracy means you are saying the right thing. So this is accurate and precise. This is precise but inaccurate. Every time you're saying values are low. So I will be concerned about this. This means there is a systemic error in your things. And Dr. Anjali maintains wonderful LJ curves which basically tell you how your graphs are going. And you will know whether it is going up, going down, and you will know your lab is doing fine or not. That is the control for precision which goes on. And this is imprecise and inaccurate. So precision and accuracy are two different terms which you need to understand.
Like I said, we use two types of control. One is internal and other is equas. So precision is basically the internal controls which we run. And for accuracy, it is the equas, which like your copies are sent for correction.
Yeah. So now what level of precision you need to vary? If your precision is generally less than 20%, we are happy. So at what point it is 20%, you consider the limit of quantification. This is there. Now, next very interesting case.
We had a 16-year-old girl with classical history of galacturia, and when the prolactin levels were done, it was found to be very low, and the patient was not started any treatment, and none of the investigations were sent further. And after a few months, the patient came with complaints of headache and vomiting, and MRI was done at this time, and which was called a large adenoma. So, what could be the reason for low value with the adenoma and the classical features of hyperprolactinemia?
So this case is interesting. Your prolactin of 16 cannot explain galacturia, and it cannot explain a large lesion which is there. So possibly I am thinking that there is a falsely low level of prolactin in this test. Now, what could be the possible cause, Dr. Anjali? What would you think here?
I think macro.
So it is producing huge amount of prolactin, and that huge amount of prolactin basically is causing a hook effect. So if it goes beyond a particular level, your every reagent gets saturated, and then it says, okay, I can't handle it anymore. It becomes low. So if you do it on dilution, you will have a good result, which is there.
And this is more seen in case of ELISA.
Yes, it was much more with RIA, RIA, and that it was much more common. Newer techniques actually, what we use is actually an automated assay. So all you have to do is to put that and it will interpret. So there are a lot of new improvements which have happened in these platforms. So this is there, but some situations, HCG, in particular prolactin, TSH can have hook effect. So you need to be careful about that, but less common compared to the previous generation assays. That is there.
We had a 17-year-old girl who was diagnosed with a case of carcinoma of thyroid, and for which the surgery and cardiac ablation was done. And during her follow-up, she came to visit, and we found the follow-up levels for thyroglobulin to see for any recurrence. There was undetectable levels of thyroglobulin, but the thyroid scan showed a lesion. So what could be the reason for the variation in the thyroglobulin levels and also the radioactive iodine scan? What is the basic reason for the difference between the two reports?
So what do you think, Dr. Vijay? Either the scan is wrong or the thyroglobulin is wrong. What do you think is more likely to be wrong?
Thyroglobulin is wrong because of the heterophile antibodies that is causing it.
So this is very important scenario. So Dr. Vijay will comment and then we'll carry forward. So this looks like a false negative result.
So we have to again see the scenario that we have to take the history that what was
So and thyroglobulin antibody was positive. So basically this is a scenario wherein you have got an antibody which is basically blocking the assessment. So for many assays, the antibodies may have a positive effect or a negative effect. So there is a rule that if you are looking for thyroid cancer follow-up, look at thyroglobulin and both antibodies. This is a big message coming out from that regard. So falsely low, you should either do a GCM assay. Next.
We had an 11-year-old boy with lethargy, and his pre-T4 was low and TSH was normal. And however, there was no goiter, T2 was negative. And when we repeated test, we had a normal T3 and T4. So what could be the reason for the variation between two tests?
So what we are seeing here is that the report says high free T4. The free T4 is high and TSH is normal. That is a very unusual scenario. That is either a brain adenoma, which is not happening in children. So we did repeat, normal T3, T4 was normal. So what is going wrong here? So this is basically an effect of what we were discussing, heterophile antibodies. Heterophile antibodies means antibodies against animals. And all the assays that we have, they have mice serum, they have got some other thing. So if you have antibodies against mice, your whole result will become discrepant. So what I'm trying to say is that you don't need to remember each and everything. But if you have a discrepant assay, use a different platform. When I say platform, it means you're using, let's say, we are using somebody is using Roche, you go to a different Abbott platform or whatever. They will give a different result because there the antibodies are different. So this is an important message that if you have discrepant result, go to a different platform. Then you will get a different result. Otherwise, the confusion will happen. So this is heterophile antibody, which is antibodies against animals, which is causing a confusion in your results. So different platform dilution studies and antibodies are there.
So we had a 14-year-old boy with complaints of gynecomastia, and on examination he had a breast staging of 2, and his testicular volume was 12 ml and pubic hair was 3, which was suggestive of pubertal status. And when you go the LH and FS is done, and it was found to be normal 1.8, 2.4, corresponding to the level of puberty. And the treating physician from outside also got a prolactin level done, which was found to be very high. And he also ordered an MRI, the same problem, and it was found to be normal. So what went actually wrong in this case? What is the reason for high prolactin level and the MRI being normal? And what is the basic reason for gynecomastia in this case?
So this is again opposite of the first case. You had galactorrhea with normal prolactin. Remember, hyperprolactinemia does not cause gynecomastia. Hypogonadism does. Hypogonadism is not there. So this is a classical case of what Dr. Anjali was alluding. In prolactin, you have two problems, hook effect and macroprolactin. There is a large prolactin which is not working and you are picking it up. So this is a case of macroprolactin, and all you have to do is a pegylated study which will give you a picture.
A 14-year-old boy with delayed puberty, and his hormonal testing were done, which showed unrelated to testosterone. And from another lab, testosterone was repeated, which showed a testosterone level of 24 nanogram per ml. So what is the reason for discrepancy in both reports?
So Dr. Anjali, now the doctor says that lab you gave undetectable, that gave 24. So what is the problem here? So again, it is the issue of low levels. So 20 is your cutoff. So below 20, you will say undetectable. Above 20, you will say 24. So this 24 could be 16. It could be 20. So that is why this don't go very much into all the 20. How, if it is 24, how does it make a big difference to you? So this is the message.
We also need to consider that what methodology has been used
Yes.
for these, because the ranges vary with the methodologies.
So significance will depend upon what test has been done. So different tests would be there. So sensitivity is the lowest limit you can detect. Now some machines like TSH, you talk about first generation, second generation, third generation. These are nothing. They also detect 1, then 0.1, 0.01. So it is not that they are very great, but they are reducing the lowest level of TSH they can detect. Now if somebody says 0.0001 I can detect, I am not bothered. It is not going to change my management. So 0.01 third generation assay is good enough. It is more of a marketing tactics beyond that. So you have to be cautious. So sensitivity is the lowest limit that you can detect. This will depend upon a number of measures.
And next we had a 20-day girl with complaints of seizure, and blood sugar was found to be on the lower side, and he was on a seizure of 12 milligram per kg per minute, and ketone was undetectable, and cortisol levels are normal for the level of hypoglycemia. However, the insulin levels were also undetectable for the hypoketotic hypoglycemia. So what went wrong in the analysis of insulin levels?
So what do you think, Dr. Vijay? This girl has a classical features of hyperinsulinism, no ketones. Insulin is undetectable.
Yes, that is going to be what we think that in case of hypoglycemia, what is the bodily mechanism that insulin has to be undetectable level. So we can't say that.
So this was undetectable, but there were features of hyperinsulinism. So again, the first question, whether the sample was taken properly, whether the NICU person took the sample and put it in the place, and by the time you did it, it is going low. So this is a most likely possibility. Plus, yes, it may be some other rare cause which may be there.
Next case, we had an 8-year-old girl with a concern of short stature, and height SGS was minus 1.5 standard deviation, and weight SGS was minus 2.2 standard deviation, and she had a screening test scan which was found to be normal, and growth hormone stimulation test showed a peak value of 9.2 microgram per ml. So we need to start growth hormone therapy in this case.
So this is again a very important test. If you see height is normal, so she is not really short. Now growth hormone is borderline 9.2. The key message is if your pre-test probability is low, do not do a test. 10 to 20% normal children will have a low response of growth hormone. So this is very important. Low pretest probability, don't do an endocrine test, otherwise you will be confused. Now this is something which I have explained a lot in our modules, which shows that depending upon your pretest probability, the post-test probability will increase. If your pretest probability is more, it will be more likely that a positive test will have a meaning. So if her height was minus 5 SDS and GH was low, I would be 100% sure. Borderline, less likely. This is normal. So I would say pretest probability is less than 1%. So this is not GHD. Do not unnecessarily work up anybody just because there are some symptoms which are there.
So just here I want to make a comment that we don't have to promote the package test. The test should be on the basis of symptomatology and the necessary test, and you priorly know that if this test is coming in this fashion, what it is going to help in making the diagnosis and how it is going to change your management. So please refrain from ये package में ये सारे हो जाएंगे और ये सारा कारण, please don't do that. Otherwise you are going to got some that is out of the box value, and it would be really difficult to explain to the parents.
And especially you get selenium and molybdenum and all those tests, what is the value and what is the role you get that. And a lot of paper is also wasted, I think.
We had a 12-year-old boy with concern for delayed puberty and examination. He had a pre-pubertal testicular volume of 2 ml and bone age was slightly less for the age. And he got a hormonal testing profile done, which was suggestive of pre-pubertal value. And considered that the treating doctor considered it to be a hypogonadotrophic hypogonadism and got a MRI there. It was normal. So, do you think getting MRI in this case was the right decision?
So now we are dealing with post-analytical tests, the most important, in between your ears or in between your eyes and the back of the head. So first of all, this is hypogonadotrophic hypogonadism, true. But every child before puberty starts is hypogonadotrophic hypogonadism. So this is normal for this age. This level at 6 months, I will be worried. That is mini puberty. Why is he not having mini puberty? At 16 years, I'll be worried. But why at 12 years even do the test? So don't do a test if it is not needed. That is the big message coming out of it. Unnecessary workup, nothing to be done in this scenario. So you have to go for age appropriate. Here, neonatal period should be high. I will be worried. Here it will be low always. So why worry? Unnecessary test clearly in this case, and that's what happened in this regard.
We had a 12-year-old boy with lethargy, and his TTO was very low, and TSH was not appropriately raised. And in view of low TTO,
no, so TSH was high according to the doctor.
So according to the doctor, and considering it to be a primary hypothyroidism, the patient was started on thyroxine, and 2 months later, the patient came with complaints of severe vomiting and weakness with shock. And when we got the testing done, we found that the cortisol levels were very low, ACTH were very low, and LH and FSH also were very low. So what went wrong in the diagnosis, and what should have not been started in this case?
So we all say that high TSH, low FP4 is primary hypothyroidism. The doctor was fine. He said the same thing. But do you agree, Dr. Vijay, with this diagnosis?
No, definitely not. We have to see that with this much low of FT4, what you expect the rise of TSS. So this is again, TSS is a bit higher, but for this FT4, it has to be very high. So it means that you are dealing a case of probably central hypothyroidism. And before commencement of this thyroxine therapy, you have to take the whole axis for that. And what went wrong in this case, that before thinking of that other ACTS parameters, and they have started thyroxine, and there was a big.
So anybody whose FT4 is low, TSH should be more than 20. If your TSH is less than 20, this is central. This is the message. Again, reiterated through this case.
We had a 7-year-old girl with tetany, and her calcium levels were found to be very low, and phosphorus were found to be high. And ruling out the chronic kidney disease, creatinine levels were there, which are found to be normal. And PTS was done with a treating physician, it was also found to be low. So what could be the diagnosis?
So this is not low. The lab is saying 10 to 72. Why are you saying it is low?
So it is low because of the for the level of calcium, it is definitely low.
So in endocrinology, often people say, what is the normal PTH? I say there is no normal PTH. It will depend upon how much your calcium is. If her calcium was, let's say it was 14, this 15 will be high. If this calcium was normal, this PTH is normal. But for hypocalcemia, I expect this PTH to be at least above 60, 70, 100, whatever. So this is a classical case of inappropriate hypoparathyroidism, which is there. So always correlate with the end result. It is not just a single value. So if you look for glucose, look for insulin, sodium, AVP, growth hormone, IGF-1, always correlate what is happening. Single result and you say, okay, this is normal, this is abnormal. So in endocrinology, there is no one normal value. It is the context, age, other tests that will give you a diagnosis.
Here, a 7-year boy with hypoglycemia, and his GI requirements are very high, with a 14 mg per kg per minute, and he had hypoketotic hypoglycemia, and cortisol level was very high, and it was normal for the level of hypoglycemia, and insulin level was there. It was found to be 2. And do you think?
So basically, the neonatology team called you, and you said this is hyperinsulinism. They said, are you trying to fool us? The insulin is low. Why are you calling it hyperinsulinism?
Sir, for the levels of hypoglycemia, insulin should always be suppressed and it has to be less than 0.2 and maximum allowed is around 0.6. So in this case, 2 is definitely high. So we need to consider this as a case of hyperinsulinism and start therapy based on hyperinsulinism.
So just to simplify that, what you expect or what your body mechanism is going to expect that in case of hypoglycemia, no detectable insulin to be there. Whatever insulin that has been detected, probably that machine is not going to measure below that. So that's why probably they have measured this or something has been wrong. So what we expect that in case of hypoglycemia, if we are thinking of this HIV, then it has to be
So insulin level is basically high for the level of hypoglycemia. So this is again an inappropriate response. So I think we had a lot of wonderful grand round with all inputs from endocrinologists, from laboratory medicine and all the aspects. The key point is what assay you are doing. You understand that. Look for pre-analytical issue. Don't write the wrong test, wrong time, wrong sample, wrong tube, wrong transport. Quality assurance, you need to have a brilliant lab science person working. So Dr. Anjali is there, so we don't need to worry here. But you have to look at where you are sending and then use your brains. Context. When was it taken? What time it was taken? What was the calcium? What was the glucose? You will get the right result. So I think we will close the session at this point of time on endocrine diagnostics. I thank all of you for patient hearing. I'll request Dr. Vibha to kindly hand over a memento to Dr. Anjali because she is going to go for a meeting and her concluding remarks.
Just one comment that you have to make a team. You can't say that your job for pathology, this is your job, that just you have to take the number. No. You have to give a very proper history. If what you were thinking at test is not meeting out that, better to discuss, not to make a hot argument. So that way we are going to have a very good result. If you are interviewing the case scenario, with you are discussing with pathologists, probability of success in that story is going to be very high. So always take a team. So no one is high or no one is low. It is always a team. So radiologist, pathologist, and the clinician, all the three pillars should be working together as a team.
Many labs are asking for clinical history.
And often we say, why do you need clinical history? This is why they need that.
Patient is locality, and whereas for us, patient is inside a tube. So for us, that has a number. We haven't seen patient, so that is why history is very, very important. And I would say that definitely we are also forced to write the interpretations as required by various accreditation agencies and all. But I think any interpretation, when the proper history is not given to pathologists, should not be considered. Our interpretation should not be considered because the right context, which here we have discussed various cases, I think you are the best judge to interpret the report. Because we would be writing based on whatever theoretical thing is there. So you are the best interpreter.
So I think that is a very, very important point which Dr. Anjali said. I'll request Dr. Vibha to kindly hand over a memento as a token of appreciation to Dr. Anjali. And unfortunately, she has to go for a hospital meeting. And I'm also like to welcome Dr. Poonam Gambhir, who is the genetics person, always a fallback person for complicated disorders. And we will be having the genetic session after this. Again, confusing discussions are there. So before that, we'll start off with the session on bone density assessment, which again is becoming very important because now we are seeing a lot of conditions in which bone can be affected. So we have got Dr. Neha, who worked as a fellow in pediatric endocrinology in our department, and now we are very proud that she is part of a faculty. in the Institute of Neurosciences in Kolkata. She has done her training from UK as well. So welcome Neha for this session on how we can assess, interpret Dexa in that scenario.
Yes, this is it.
So a very warm good evening, everyone. In the next 10 minutes, we will be talking about Dexa, which we all know is a newly emerging diagnostic modality gradually reaching our clinics. So why we need this bone mineral density assessment is a very important question. Should we use it as a routine automated procedure, or do we need to have accurate indications which need to be done in a proper methodological manner and precise interpretation? So our first question will be, why do we need bone mineral density assessment in children, or to say in any individual? So we all know that there is a variation in the bone mineral density across the lifespan, with peak bone mass being attained at around late 20s or around 20 to 25 years. And thereafter, there is a gradual annual loss of 0.3 to 0.5% beyond 30 to 40 years of age. And this exponential loss is more pronounced in females, particularly due to the loss of estrogen hormone after the menopause. So coming back to the historical background, before the advent of Dexa, how did we measure this bone strength? So historically speaking, X-ray was the first modality which was used to estimate the bone strength. But so X-ray could only assess the bone structure and could not give any information about the bone strength. So after X-ray, we had the functional modality known as the single proton absorptiometry. So as the name, so shall I wait?
Let's go.
So as the name suggests, it had a use of a radionuclear agent known as iodine-125. But the drawback was that it could only assess the bone mineral density of the appendicular skeleton or the forearm and the calcaneus. A decade after, it was substituted by a double proton absorptiometry, which used gadolinium as the radionuclear isotope scan. And it was for the first time that the central sites such as spine or proximal femur could be assessed using this double proton absorptiometry. A decade later, that is around 1980s, we had the advent of dual X-ray absorptiometry. So the advantage was that the radionuclear agent which was being used till now was substituted by X-ray. And this Dexa could be used to measure both the peripheral sites as well as the central sites. Then we have a whole array of radiodiagnostic modalities such as CT scan, ultrasound, MRI, but most of these are mainly for the research purposes. And among all these radiodiagnostic modalities, Dexa stands as the gold standard, mainly because of the following advantages. That is, it is associated with a low radiation exposure, making it a safe diagnostic modality. The scan time is somewhere around 1 to 5 minutes, so that it is a quick OPD procedure. And it is associated with high precision value, although the precision varies with the brand that you are using and the site that you are estimating, which we will be talking in the subsequent slides. So coming to the first advantage, which is the low radiation exposure. So as we see that the National Osteoporosis Foundation, the data published in 2004 showed that the effective radiation dose, which is delivered while doing a spine or whole body Dexa with the number of, as you can see on the right, the number of machines that are available with us, such as hologic, lunar, Norland, is far below the radiation that normally occurs in the United Kingdom, which is 6 to 20 per day. So it is quite a safe procedure as far as radiation exposure is concerned. So what exactly is the principle behind this Dexa? So first we need to understand that the Dexa is abbreviated as DXA and not DEXA. So the first thing which should go after this class is Dexa needs to be abbreviated as DXA, and please don't write it as DEXA. So the principle behind this Dexa is that it uses 2 photon energy beams. So these are 2 different photon energy beams which have different absorptiometry capacity. So just similar to ultrasound, what happens is that different tissues have different radiation absorption capacity, so that a different film is created for bone, organ, air, fat, fluid. Similarly, in Dexa, there are 2 different energy photon beams which are being used. So depending on the quality of photon beam, it can either be a pencil beam, a narrow angle fan beam, or a wide angle fan beam. So the initial Dexa machines had pencil beam technology, and as the technology is progressing, the newer machines have the wide angle fan beam. And the advantage is that if you have a wider fan angle beam, the time taken for Dexa scanning is less. So with pencil beam, the time was somewhere around 5 to 10 minutes. And with the newer technology of wide angle fan beam, because since you can cover a larger body surface area in a quick span of time, the time has reduced to less than 1 minute. So Dexa, as I said, could assess both the peripheral as well as the central side. So peripheral Dexa is a portable machine, as we can see here. The reproducibility and the precision is not as good as central Dexa, but it can be used to shortlist the candidates which will ultimately require a central Dexa, or it can be used in setups where central Dexa is not available. So with the help of peripheral Dexa, we can measure the bone mineral at sites such as distal radius and calcaneus. And central Dexa, which is used on a stationary scanning table, is used to assess the bone mineral at sites such as spine, femoral neck, distal radius, and whole body. So talking about what are the different sites analyzed and which site should we prefer being a pediatric endocrinologist. So the different sites which can be analyzed are spine. So among the spine, we have the L1 to L4 section. So this can be used in children as below as 0 to 5 years of age. The next scan we have is the whole body scan, which is used in children more than or equal to 3 years of age. Then we have the proximal femur or the femoral neck, which is used beyond 18 years of age. These age cutoffs are because of the presence of the database which is available. So for children below 18 years, we do not have a globally accepted database. And that is why, as of now, we are saying that this needs to be done in children beyond 18. Maybe down the line, we can use it in less than 18 years as well. Then we have the distal radius. The indications for doing distal radius is morbidly obese patients who cannot be accommodated on a scanning table, or hyperparathyroidism, because as we know that the changes in bone mineral density in case of hyperparathyroidism occur prior in the appendicular skeleton as compared to the axial skeleton. So if you have a case of hyperparathyroidism, consider doing a distal radius scan rather than a spine or whole body scan. So coming on to that in-depth, how to acquire these scans, because this is not an automated procedure where you just write, do a Dexa spine and the report will come out to you. You need to have orientation, how to make your patient lie on the scanning table, how to acquire the images. So a great knowledge is required in terms of technicality and the image acquisition. So the figure shows here the patient positioning. So you have to make the patient lie down supine and then a positioner is placed below the knee so that the spine comes down as close to the scanning table as possible and also eliminates the lumbar lordosis which is present. So we need to place the scanner in between the L1 to L4 vertebra. So this is the region of interest that we are interested in. So as you see that first, it needs to have all the L1 to L4 vertebra in the region of interest. The L5 vertebra upper body should be included, and the 12th thoracic vertebra with a pair of floating ribs should be visible on the image. So this is the correct positioning with the correct region of interest. Any metals or implants or osteophytes presence needs to be eliminated while interpreting the result. So if among the L1 to L4 vertebrae there are any fractures, any implant, that particular vertebra needs to be excluded from taking out the average BMD, and we need a minimum of 2 lumbar vertebra to get the average. So let's check if you can identify the potential errors which are present here. So on the left screen, you have the correct positioning of the spine scan. The middle image shows you a rotated scan. So if you get a Dexa result which shows a rotated spine, there is no fun in analyzing this result. You need to do it again. So this is the image which shows the presence of 6 lumbar vertebra or 6 vertebra along with a thoracic vertebra. So this will also give you a false result. You cannot interpret, diagnose or manage based on this Dexa scan. So the main difficulty that arises is in identifying the vertebra, which is a thoracic vertebra, which is a lumbar vertebra. So this is a pictorial representation of how a lumbar or L4, L3, L1, L2 images appear on a Dexa scan. So you can compare the images given on the pictorial side along with the one which are acquired from the Dexa. So as you see, L4 appears like a butterfly image. So you have to count from below upwards rather than from above downwards, because your 12th thoracic vertebra can have a similar anatomy as the lumbar vertebra. So you need to count from below upwards. So this is a newer concept of vertebral morphology assessment which is coming up. Till now, we have been saying that you need to measure L1 to L4, you need to measure L1 to L4. But studies have found that compression fractures at the level of thoracic vertebra, they have a higher relation to the occurrence of fracture risk in the future. But till now, we were not seeing the thoracic vertebra. So the newer Dexa machines have an advantage of giving you a vertebral morphology assessment. So just have a look at this image which shows compression fracture at the level of T7 and T9, but with a normal lumbar vertebra morphology. So if we were to assess only the lumbar vertebra in this patient, we would have declared it as a normal patient. But it is found that pubertal patients who have idiopathic juvenile osteoporosis or vitamin D deficiency, they have a propensity towards thoracic vertebra fracture as compared to lumbar vertebra. So in adolescents or per se in any pediatric patients in which you are considering a high risk of osteoporosis, always write a vertebral morphology assessment along with a Dexa. Similarly, as we write a FRAX assessment in adults, a vertebral fracture risk assessment for adults. So this is a newer concept for diagnosing pediatric osteoporosis. So this is how a report derived from Dexa looks like. So it will show you a region of interest in which you have to check whether all the proper vertebral images have been taken or not. Is there a rotation or not? Is there any metal implant or osteophytes? Then you get the bone mineral density in absolute numbers along with the pictorial representation as shown in the traffic light signal pictorial, green, yellow and red. Green is for a normal bone mineral density, yellow is for osteopenia and red is for osteoporosis. Coming on to femoral, you have to make the patient lie down supine. The lower limb which you are analyzing, you can analyze either right or left, doesn't make a difference. It needs to be slightly abducted with a foot holder strapped with the feet. And these are the region of interest that we have to look on the Dexa femoral scan. So you need to have a femoral neck, greater trochanter. So you need to have a femoral neck, greater trochanter, and the ischiopubic ramus in the field but the lesser trochanter should not be visible. So you need to abduct and slightly internal rotate so that the lesser trochanter is not visible in the field. So the potential errors which are associated with a femoral scan are lesser as compared to a spine scan and are limited to only visibility of lesser trochanter. So you have to rule out if there is any lesser trochanter visible, and you have to rule out if there is any metal implant placed in the picture. So this is how a scan obtained for femur looks like. So what are the contraindications of getting a Dexa? So as we all know, since it is a radiation-based technology, it should be avoided in pregnant females. All the metal implants, they should not come in the field of scanning. And a recent contrast study, which is less than 5 days, the subjects should not be subjected to a Dexa scan, because if it comes in the field of scanning, it will give you a falsely high BMD value. So how do we get a result? So the interesting thing is that Dexa, although a radiological diagnosis, gives you result in the form of a number. No other radio imaging gives you result in the form of a number. So the problem is most of the time radiologists do not report it because they say it is a pathological report giving the result in the form of a number, and pathologists are not trained in seeing a Dexa. So ultimately it is the clinician who has ordered a Dexa. It is his or her responsibility to see whether it has been acquired and interpreted in a proper fashion or not. So we get the result in the form of a number, which gives in the form of Z-score or T-score. So there is always a tussle whether to use a Z-score or a T-score. And in case you are ordering two regions, suppose you are ordering spine and femur, then you have to see the lowest value among the two. So when to use a Z-score or a T-score? So Z-score is used in premenopausal females and men younger than 50. So all our patients will have to use a Z-score. So the basic difference between a T-score and Z-score is that a T-score compares your bone minerals density to a young adult reference, while a Z-score compares the bone mineral density to a patient matched age, gender, and ethnicity. So Dexa nonetheless is also associated with limitations, and this is a very important point to learn from here. So Dexa, although gives you information regarding density, but it is a two-dimensional density. It gives you an areal density. But what we have been learning in our basic sciences, that density is a three-dimensional parameter. It has a volume. So if we take example of this cube, what we see here is that although the volumetric BMD is same in the small cube and the large cube, but the areal BMD is lesser in the small cube, which means that a shorter child will falsely have a lesser areal BMD compared to a longer child, even if the volumetric BMD is same. So if you are to follow up a child, the child will grow, the bone size will increase. So can you compare the initial report with the current report because the bone size is changing? No. So for this, we have the adjustment for the bone size, which have been given by 3 arithmetic equations. And you don't have to apply these arithmetic equations. These are inbuilt in your Dexa machine. This is just for a scientific discussion. And this is known as a bone mineral apparent density. So this was given by Molgard for the whole body Dexa. It is a 3-step process which corrects for the age, height, and bone area. For a spine, this was given by the Katzmann et al., which assumes vertebra to be a cube and then gives a corrected bone mineral apparent density by the formula given on the screen. For a femoral neck, Croger et al. Gave us an arithmetic equation for giving us a bone mineral apparent density, considering the femoral neck to be a cylindrical shape. This is a newer concept of comparing the total body bone mineral content with the lean body mass. So scientists say, why are we worried about bone mineral density, which is so much influenced by factors such as size, age? Why do not we consider the bone mineral content as such? And this needs to be corrected for a lean body mass because of the presence of mechanostat theory. So we know if we have stronger muscles, we have stronger bones. So this lean bone mass correlation with bone mineral content is now considered as a new marker of bone strength in pediatrics population. So second limitation of Dexa is that we need to use a pediatric software. So most of the Dexa machines which are installed in the hospitals, they have an adult software. So you need to check whether your Dexa machine is compatible with a pediatric patient or not. So for example, if we see here, This is a Dexa done for a patient. So on the left, we have a Dexa done by a pediatric software, while on the right, we have a Dexa done by using an adult software. So just see the bottommost value of total body done by pediatric machine, which says a bone area of 1810. So what we need to understand is that Dexa uses the edge detection technology. So pediatric bones, by virtue, they have a lower bone mass. So if we assess it using adult software, so what we see is that the adult software has limited edge detection technology. So that will not pick up the pediatric bone and give you a bone area of only 1315. But if the same is assessed using the pediatric software, which has an improvised edge detection technology, the bone area will increase to 1800. So if you have a higher area, then we all can apply mathematics and see that the bone mineral density will change if the area is changing. So one needs to do a lot of adjustments while acquiring a pediatric Dexa. We need to adjust it for the age, gender, height, and size. Over and above, you have to just check whether your machine has a pediatric software, whether that is using a ethnicity-based normative database or not, and that would be enough. So coming on to what are the correct indications of pediatric Dexa. So the National Osteoporosis Foundation has laid down the following indications for obtaining a pediatric Dexa. So you should order a pediatric Dexa only and only when there is a high suspicion of osteoporosis and not as a routine test like complete blood count. So these are the few indications: long-term corticosteroid use, chronic inflammatory disease like inflammatory bowel disease, primary or secondary hypogonadism, because we all know that sex steroids have a role in bone mineral density acquirement, prolonged immobilization. Osteogenesis imperfecta is a well-known genetically acquired low bone mass condition. IgAO, which is a diagnosis of exclusion in juvenile population, recurrent low trauma fracture, and apparent osteopenia on radiographs. So this is how a Dexa report looks like. So this is the one acquired from Regency Hospital. So it will have a hospital name where the machine is installed, where the Dexa has been acquired. Then it will have some patient-related details. Then it will give you a site-based assessment. So this patient was subjected to a spine and a total body Dexa. So it will give you separate results for both spine and whole body. And if we are using two-site assessment, we need to check the lowest value and we'll compare with that. And then there is a WHO classification, which is not applicable to pediatric population. It is applicable only to the adult population. So here we have two Dexa reports. So one is for the whole body, the next one is for the spine. So in whole body, you can see that the machine is giving you two images. So one is for the skeletal and the other one is for the soft tissue mass, because Dexa has a role beyond bones, which we will be discussing in subsequent slides. So Dexa, which has played an important role in the assessment of bone mineral density, has now slowly found its way in assessment of bone body composition as well. So it gives you value regarding not only the fat mass, but also the lean mass of the total body and also the regional viscosity adipose tissue. So till now, we have been using CT scan to understand regarding the visceral adiposity. But CT scan, you know, is associated with radiation exposure. So Dexa is now currently used for research purposes for getting the information on fat mass and lean mass in regional and a whole body manner. This also gives you information regarding the android-gonaid ratio, because AG ratio is associated with the incidence and prevalence of metabolic complications. So the take-home messages from this Dexa discussion would be that it should be ordered only in appropriate conditions and should not be used as a routine diagnostic modality. A correct methodology of how the patient should be lied down, what algorithm should be used, should be followed. And the same equipment should be followed for following up purposes because of the difference in not only the software, but also the hardware of the different manufacturers. Again, this is a only radiological instrument which gives you result in the form of a number, but you need to understand that just a number of -1 or -2 is not a diagnosis, but you need to have a clinical context. So diagnosing and managing pediatric osteoporosis is a topic for tomorrow, which we will indulge in detail. Thank you.
Thank you, Neha, for a wonderful discussion. I think the key message that we need to be aware that bone density is very important. We need to assess it more. But think of caveats. Pediatric software, yes or no in your case. If not, it will cause confusion. Send to a center where there is pediatric software. Correction for size, that is the second big thing. And third is, of course, age correlation and follow-up data, which is there. Thank you, Neha, for the wonderful discussion. Can we have a memento for Dr. Neha? And I will request Dr. Sumana to come up and please give share the memento to Dr. Neha. So Dr. Neha had been doing a lot of work on bone density as well from her training times as well. So she did work on type 1 diabetes and bone density as well. So I request Dr. Sumana to kindly hand over the memento to Dr. Neha. So now continuing in terms of endocrine diagnostics, we will move forward to the next session, which is quite relevant, and we are discussing a lot about the genetic aspects of diagnosis. And a lot of these cases that we discussed had a genetic basis of disease in the form, and we'll need to understand the genetics is going to become more common in clinical practice. We need to be aware about that and need to get through that. So what we'll do today is that we will go through a few cases to see where genetic tests can cause confusion and we don't have an issue in terms of diagnosis. I'm happy and really honored to have Dr. Poonam Gambhir, who has done DM in clinical genetics from Sanjay Gandhi Postgraduate Institute, and she is part of our hospital for the last, I think, 7-8 years, and she has been a big asset on that. So what we'll do is we'll go through the overview and then we'll take cases which Dr. Manoj will present, just like we did for hormones, and then we'll post questions to Dr. Poonam as well, and we'll go forward from there. So genetics, just to understand, we have all been taught that there is a central dogma that you have a gene which produces a protein which is then translated and causes a phenotype. So there is a genotype to phenotype correlation. But now life is not very simple. There are many other factors which affect this genome to phenome combination, and these include epigenetics, which means environmental effect on genetics, where methylation and other things come up, genetic modifiers, miRNAs, modifications. So a lot of factors are there. So when you are assessing a genetic report, you have to look at a total number of things before you really say what is right and what is wrong in that regard. Now, just to talk about inheritance, typically we know Mendelian inheritance is monogenic. Oligogenic is an interesting term in which many genes together cause development, and the classic example for that is which disorder in endocrinology? Hypogonadotrophic hypogonadism has an oligogenic inheritance, and most other like type 2 diabetes, type 1 diabetes have a polygenic inheritance. I will be focusing mainly on monogenic, which is of course the most common and significant in that perspective. Now, monogenic can be Mendelian, which means they are following the rules of Mendel, which may be dominant, recessive, X-linked, or non-Mendelian, in that there are some variations there in the form of whether it is penetrating, whether it is expressing, whether there is methylation, and a lot of other issues which come out there. Mosaicism, imprinting, we'll discuss all those cases in that scenario. So autosomal dominant, just to summarize, it basically means that one gene is enough to cause manifestation. Parents will also be affected, child will be also affected, 50% chances there. The generations will not be skipped. This is classical Mendelian inheritance in that scenario. There is no carrier, and if you have full penetration, everybody will be affected. Recessive basically means you are skipping generation. One generation may not have, and when you have a consanguineous family, both genes come, 25% chance of recurrence. This is basic genetics. I'm just going through very quickly to just recapitulate. And X-linked inheritance, of course, means that it is not inherited from the father to the child. Father gives to the daughter, which is basically a carrier. Mother is a carrier, but gives to the child. This is the basic thing. History will be there in maternal uncles, in maternal cousins, and all that history. We saw a lot of X-linked disorders like adrenal hypoplasia congenita. We suspected that in that onset course. So these are all X-linked conditions. ALD is again an X-linked conditions in that regard. So this is something which is there. Now we'll start off with cases, and the first case, Manoj, is?
So we have a 3-year-old boy who was diagnosed as a achondroplasia. but family was unaffected. As we know, achondroplasia is autosomal dominant disorder, but family was unaffected, and we just gave reassurance.
So we did not send to Dr. Poonam and we said, okay, nothing is going to happen to the next child. Be happy. It's an autosomal dominant condition. So now what happened?
But what happened? Next child having achondroplasia. So what was the mechanism behind this? Why it is occurring?
So Dr. Poonam, what do you think would be the
most common cause in sporadic type of these conditions is gonadal mosaicism, that one of the parents is having a particular group of cells in gonads that is mutated. So it depends upon which time, whether the mutated sperm or the egg has participated in formation of the embryo. We have no methodology by which we can prove this. Like this, clinically, when the next child is born with the same condition that is known to be a sporadic one, and the parents are happy to be normal, then it is considered as a German. And for few conditions, it is known that there is certain percentage, like this achondroplasia, we have like less than 1%. For Duchenne muscular dystrophy, if mother is not a carrier by blood testing, and she has a second child with DFB, then this percentage is known as high as 15% for Duchenne muscular dystrophy. So this is a known thing.
So this is a gonadal mosaicism. So don't always say that if it autosomal they are dominant, parents unaffected, it's not going to affect them.
So we have 2-year-old girl child who developed vaginal bleeding. Breast size was 2 and pubic hair was 1. And patient have capillary spots and ovarian cyst was there. So our working diagnosis was McCune-Albright syndrome. So LH was suppressed and FSH was also suppressed. But we did GNS1 test, which was negative. So why it is occurring?
So I think this again is the same mechanism. This was germline mosaicism. Here we are talking about somatic mosaicism. So we all know post-zygotic. If you have a defect, you will not find on the blood in every cell. This is very common. We know this about Turner syndrome. That's why you see so many macromosaicism has to be looked into. Similarly, McCune-Albright is a somatic mutation. So I think this is something which is again very, very common and we need to be aware. So how do we make a diagnosis in this case, Dr. Poonam?
The most probable affected tissue to take,
yes.
If we are able to take the sample from the cafe or its spots out, skin biopsy the most accessible.
Or if there's an ovarian cyst and somebody has taken the fluid out of it, you can get it done. So this again, it means that if you don't find it blood, it doesn't mean that it is not there. It is there in some tissue. This is what mosaicism is all about. So somatic mosaicism, we all know McCune-Albright, different tissues are affected. You will have thyrotoxicosis, precocious puberty, you will have polycystic fibrous dysplasia and all those problems depending upon which tissue is affected. Remember, if you have one tissue, only one manifestation may happen. So earlier we said triad of fibrous dysplasia, precocious puberty and cafe on spot. No, you can only have ovarian cyst in McCune-Albright syndrome. You can only have thyrotoxicosis. So depending upon which cells are affected, you will get the diagnosis.
So we have 5-year-old girl who having hypocalcemia. Calcium was 5.6, phosphorus was high. It is suggestive of impaired PTH effect. PTH was 5.2, which was suggestive of hypoparathyroidism, and patient having growth failure. We did NGS, which was suggestive of rate 1 mutation, and there is no family history. So what we have to do in this case?
So this is a very interesting scenario. You have done an MRI for headache and you find a pituitary adenoma. We call it incidental. You did test for hypoparathyroidism and you found a RET1, and RET1 we know is medullary carcinoma thyroid. So this is a genetic incidentaloma. Now, Dr. Poonam, do you think this child has the same chance of malignancy as somebody who already had a family history of thyroid carcinoma? Because the big question now comes whether we go for thyroidectomy or not. So one is that you've done for the family and then you did it is positive and this is incidental. So are they the same or do you think there could be some difference?
The age of manifestations actually the highest is within 1 year.
Yes. Yeah.
So probably that part has been
escaped from that perspective.
But still we can keep them at surveillance. It's not
yes.
indicated.
Maybe. Yes. So what we need to to understand is that this basically is an important issue of penetrance also is important. Now, if you do a whole genome sequencing in any of us, 20 to 30 defects will be there in us, but we don't have any manifestations. What it means is that other factors are saving us from having a disease. Suppose your androgen levels are low and your androgen receptor is working well, so you are compensating. So like that FAH which we are talking about is basically hypersensitive to ACTH. That is a base, it's not a disease, but they are responding well. So what basically means is that you need to understand what is penetrance and what is expressivity. Penetrance means that out of how many people, how many have actually the disease. Expressivity means out of them how much they are expressing. So it may happen that you have variable penetrance, you have variable expressivity. Somebody may have a milder disease, somebody may have a severe disease. Now, if the family already has shown that there is thyroid cancer, I will be very, very bothered about it. In this case, as Dr. Poonam said, if already 1 year is gone, chances are less, but the family doesn't have. So he either has a sporadic mutation or if it is familial, it is not that severe. Other factors in the family are saving it. So remember that beyond a simple Mendelian inheritance, penetrance and expressivity play an important role in that scenario. So you can have variable penetrance, variable expressivity.
So we have 10-year-old boy with obesity. Patient was normal till 3 years of age and now having rapid progressive obesity. Patient having hyperphagia also.
So diagnosis, we saw these cases. So you're thinking of Prader-Willi syndrome as a possibility.
But we and patient having small pelvic size, but fish was normal. So why this fish is normal?
So very, very high level of chance of Prader-Willi, but we got fish, it was normal. So Dr. Poonam, what do you think was it, was it the right test to do fish?
Pick upon availability because most common is deletional form. 70% is deletional form. So we can say it logically it may be opted for the first time, but yes, mutilation is the most sensitive one because it will pick up 99%.
So this is an imprinting disorder, and 70% cases that paternal gene is gone. The other cases, there may be some epimutation, there may be some methylation changes which will not be detected on fish. So if you want to go for MLPA methylation, 99% cases, you will pick up. This is very common. So fish is earlier good, but now MLPA comes for around 8,000 rupees also. So I think that's a reasonable test to do. So MLPA is a new technique which will give you, not a new, but it's a good technique to diagnose the condition. So remember, there would be issues in diagnosis. Don't just say fish negative, it cannot be Prader-Willi. There can be other situations as well. So imprinting is a group of disorder in which the genetic manifestations depend upon whether the gene is coming from the father or the mother. Typical case in endocrinology is Silva-Russell syndrome, Prader-Willi syndrome, Beckwith-Wiedemann syndrome, SDH paraganglioma, transient hyperinsulinism. A lot of these disorders are there which are there. And so they are becoming, and pseudohypoparathyroidism, I can't forget, that's a very important one in that regard. So you have to be aware that imprinting comes. So suppose you have PHP, we discussed yesterday with Dr. Nitya, that look at the mother. Don't look at father because it is never going to come from the father. So look for mother, whether she is short, round faces, whether she has brachymetacarpia or not, then it will come because it is an imprinting disorder. Father's defect will cause only skeletal manifestations. It will not cause hypocalcemia. Mother's defect will cause both manifestations in that setting.
So we have a 21-day-old boy who having irritability and patient having mild dehydration. Calcium was high, 14 milligram per deciliter. PTH was also high, 120 picogram per ml. Urine calcium create ratio showing lower side, 0.1 milligram per milligram. And the father we have found familiar benign hypocalcemia and mother was normal. So why this child having such a severe presentation in newborn periods?
So I think this is again an important consideration. We know if both genes are affected, that is autosomal recessive severe form of hyperparathyroidism. But here only one gene is affected. But yet the child has hyperparathyroidism. Anybody can have a clue. Why is it happening? No, this is basically a calcium sensing mutation is there, but only one gene. Because mother has normal calcium. So this baby, for him, the mother's normal calcium are actually low. So that is why he is having this hypercalcemia, and this will improve over time. So this is not really imprinting, this is pseudo imprinting, in which the body is behaving such that this is a case. So if both genes are affected, you will of course have a severe form. There is no confusion. But if there is an effect which comes from the father, mother's levels of calcium are falsely found to be low. So if you talk about GDM, what happens? Your mother's glucose is high, you become hypoglycemic. Similarly, he perceives that mother's calcium is actually low, so he becomes hypercalcemic. This will resolve over time. So this is a very interesting scenario. If it comes from the mother, it will be a benign condition. So again, it is looking like imprinting, but it is not imprinting. You got the point? So basically, mother is being thought to be hypocalcemic by the child because he wants calcium to be 12. He is not happy with 9. That is why he develops hypercalcemia.
So we have 7-year-old boy who having growth failure. Height was short. Weight was 16 kg. Patient having doll-like faces and peak growth hormone was 2.1. Liver was 10 centimeter enlarged. Thumb and SGPT was very high.
So this is GSD. Which GSD? Type 1. So this is a late presentation. Lactate is normal. I haven't given the figure. Liver is very big. SGPT is high. So this is GSD 3. Most likely GSD 3. Now what happened, Manoj?
So as sir discussed, our working diagnosis was GSD 3, but we did a blood investigation. In that the reports came negative. So why it is occurring?
So we got the GSD 3 study, which was negative. Then what do you think would have happened? This is a very common genetic thing. What is known as locus heterogeneity or phenocopy. Now it's not just GSD 3, GSD 6, GSD 9. All of them have similar features. So then comes the importance of targeted panels. So if you are 100% sure this is the disorder, you go for that particular Sanger sequencing. But if you are unsure, and if you have a number of disorders, suppose you have XY DSD, nobody on the earth, as Vibha was saying, XY gonadal you don't know it is NR5A1, this is WT1, this is SRY. So if you say SRY, then every time you keep on doing tests, it will be huge fun. There comes the role of targeted panels. So Dr. Poonam, what do you recommend in terms of like, where should we go for a specific test and where should we go for a targeted panel?
It depends upon if you are very, very sure, like achondroplasia. It's a evident diagnosis. Even we don't sometimes go for then that is one gene, one test. But it's like GSD group. So we have several types and several genes. But you are pretty sure that it will fall under that group. So then it is good for going targeted. The difference for the lab comes for once you go for a targeted panel, they look into exons, they look into periexons, splice site. So the depth of this splice site is also best depending on the target. Like I'm seeing 12 genes in a group, so they will see the splice site up to the depth of 100 base pairs or something. But once you are not very sure or clear of the diagnosis, like mental retardation, could be a non-syndromic type. Like most common nowadays is autism. Right, so autism has 40% kinds of genetic background, but sometimes the child has nothing as a physical feature. So then in those cases you go for a wide field. And you cannot say for a targeted, so then you have to go for many genes, maybe clinical exome, maybe whole exome. So then once the lab takes number of genes or more, the depth reduces. So they will be seeing all the genes, all the exons, but maybe splice sites that go, the space pairs that we have, these space pairs. So depending upon your clinical diagnosis, you should order the test and accordingly the lab will reply. And obviously the diagnostic yield also varies. The highest yield is with targeted panels and it reduces, it's more wide.
So basically, let's say this way, that suppose you want to learn about a particular topic and you know I want to read only about XY DSD. You're going to read only that part. Then you say I want to read about entire part about gonads. Then you have to read the whole book. So if you read the whole book, you may miss 1 or 2 points. If you're reading only one paragraph, you will be more focused. So if you do single gene, Sanger, that is of course gold standard. It will say yes or no. If you do a targeted panel, you will be able to read, okay, it is correct. But if you read the whole book, you may miss something. But if you don't know where to find, you have to read the whole book. That is what Dr. Poonam is saying. So single gene defect, you go a Sanger sequencing, otherwise targeted panel, clinical exome, whole exome. So this is the way you decide.
So we have next case, a 12-year-old boy who having obesity, weight was 67 kg, height was 156 centimeter, plus 1.2 SDS with normal faces and normal development. So it is looking like a physiological obesity. So either in this case, should we have to advise genetic test or not?
Now everybody is doing genetic tests. We have seen patients in which no biochemical tests are done and genetic test is done. So which condition should we do a genetic test, Dr. Poonam? So what are the indications? Suppose like obesity is very common. Which obese child shall we do a genetic test? Yes.
That is, we are
Sure.
But like in this case, I would like to see for the parental height.
Yes. So we will look for thyroid, all other things before you. Yeah. So what about this girl? 2-year-old girl, weight is 24, rapidly progressive, hyperphagia is there. So this case, I think everybody will agree a genetic test needs to be done. Yeah. So what Dr. Poonam has said is what we discussed, 4S, soon, severe, segregating in the family, and syndrome. These 4 cases you have to do the genetic testing basically. In all these 4 cases it becomes important. So this is what, first case it is waste of money, second case you have to do it. So too soon becomes important. So this child had early, severe, unusual hyperphagia was there, and we found a leptin receptor and other receptor defects can come. So now to summarize, genetic techniques can be sequencing in which you are reading each and every sequence. Now sequencing could be the Sanger one or a next generation one. You compare this versus that, or you go for a particular locus, fish and karyotype cytogenic techniques. So these are the various techniques. So just to summarize, in Sanger you are going one by one. You're looking at, suppose you are in charge of the railway, you're looking at each track and seeing how it is going. So this will be the Sanger technique. The other one, you look only at patches. This is like the fish technique. And the other one would be that you have 100 people employed and they are looking. They are not as good as you, but they are at least looking there. So if I summarize this, the one in which you are looking at everything is Sanger technique. Second, NGS, you have got thousands of probes looking at different regions. You are at least looking them. You may be having an error or not. That's a different question. If you are looking at specific regions, that is fish. So depending upon what you want to look at, you will then make a diagnosis from that regard. So Sanger, I won't go into technique, is a way of looking at each and every DNA sequence from there. NGS has a much more high throughput. The technology is becoming better. So over time, we expect it to be much better in that scenario. And this is going to be there. And so now the next big issue comes is when you find a variant. Now we don't call anything as mutation. Earlier people used to say mutation. Now we call variants. And now the question is, when will you say a variant is pathogenic? So if it is in the family, if the gene frequency is low, if it has been there for millions of years and suddenly it has changed, if you have clinical correlation, if you have a functional study, and then there are prediction models. So in silico study means you not have clinical tests, you just predict based upon computer, what computer is saying, and you get the result. So every variant you identify is not pathogenic. It may be variant of uncertain significance, it may be benign. So like radiologists say category 1, category 2, pathologists say category 1 to 5, same. Genetics now talks about benign, variant of unknown significance, and a pathogenic, definite pathogenic variant in that regard. This is the point Dr. Poonam was saying. Single gene, one mutation, hotspot testing you can do. Single gene, multiple mutation, do a Sanger sequencing. Multiple genes, go for a targeted next generation panel. Unknown, whole exome, whole genome, then you keep on looking at. You are trying to find the needle in the haystack. And copy number variation. Now, what is copy number variation, Manoj?
It is a gene defect that occur due to the deletion or duplication.
So small areas, it's not a single nucleotide. Some come, some go. There you use MLPA or FISH in that technique. And multiple genes, you want to compare multiple, you go for array CGH and MLPA in that regards. So likely monogenic, Unlikely, no, don't do unnecessary testing. If there is there, you have candidate genes 1 to 2, do sequencing. Up to 20, you can go for targeted panels. Normal or unclear, you go for exome sequencing. And if it's abnormal, go for functional study. And if everything is normal, you can go for genome sequencing. So not everybody requires genetic testing, but go by sequencing. Now we will go through a few cases.
So we have three-day-old child who having DSD and palpable gonad was there. The other stage was 4, but there was no gonad. Uterus present and the karyotype is showing 46XX. 17 hydroxylase was in borderline 25 nanogram per ml and diagnosed as a CAH. A hydrocode tapered according to 17 hydroxylase and 17 OHP was normal, but patient having delayed puberty, but there was a typical history of maternal virilization was there, and genetic report was showing.
So what do you think here? Clinical diagnosis first. So this looks like a aromatase deficiency. Now this is the clinical report, Dr. Poonam. They are saying it is autosomal recessive inheritance, aromatase deficiency, both alleles are affected. So do you think this is significant? So this is likely pathogenic, and in fact we are diagnosing aromatase deficiency. The report is there. I think there is pretest probability is so high. So when you look at the classification, which is very, very important, and they also tell you how common it is, how much it is conserved. All the points I said is there, but this is the key thing to look at. Whether it is and it is fitting your diagnosis or not is very important.
So we have 6-year-old boy who was failure to thrive. Birth weight was 2.4 kg, and now weight was 2.5 kg. Bilateral gonad was there, and in USG there was no uterus. Testosterone was high, 17 OHP was borderline 30. Sodium was 126, potassium is 5.8, showing impaired RAS effect. So now genetic report showing.
So now we have got this child with hyponatremia, hyperkalemia, borderline 17 OHP. Now we are getting this result as 3 beta HSD deficiency. Again, pathogen. So I think Dr. Poonam, we will think that this fits into the diagnosis. So we will carry on with the same diagnosis. So this is clearly a targeted panel which is showing the defect.
So we have 6-year-old girl who having diabetes and which was diagnosed in infancy. Patient was insulin and patient having disease abnormality which was showing it could be the MODY type or syndromic associated. And inpatient GAD was negative. So type 1 is out and we did genetic investigation.
So digit abnormalities and diabetes, what are we thinking of? Digit abnormalities and diabetes, anybody? Not obese. So this is what came out. EIF2AK3, which is basically for Volcotralis. Now they are saying uncertain significance. Now, Dr. Poonam, does it mean that it is not Volcotralis? Clinically, I am thinking of Volcotralis. There is digital abnormality, diabetes. I thought it could be Volcotralis, and they are saying uncertain. So, do you think it is? What do you think most likely it will be?
If it is going with the clinical diagnosis, then it will be likely pathogenic. But because the type of variants are such, that is making the lab to check the lower side.
So lab is not seeing the patient. You are seeing the patient, and lab is basing upon their probability prediction models. So you have to look. Okay, for me it is positive. This is classical case. I was expecting this. It came out. So again, use your own. As I said, most important part will be between your eyes and the back of head, which will give you the diagnosis in that scenario.
So we have 8-year-old boy who having short stature, height was 92, -2, 6.2 SDS, small child was SGA, and there was a normal metabolic workup, NGS advice, but in NGS we found there was a 10 variant of unknown significance. So in this particular case, what we have to do?
So none of these variants were explaining his short stature. So what do you think, Dr. Poonam, would be the way forward? And none of the clinical features were there for those variants.
On what type of NGS was done? Was it a targeted panel? Was it
It was a it was whole genome.
Whole genome has a very low sensitivity. The a reverse phenotyping. The patient once again, try to correlate, try to find out more clinical markers, and then you can send me clinical features to the lab and ask them to be on basis of these new clinical criteria and please read the data.
So what I'm trying to say is that when you do whole exome and these sort of sequences, you will see a lot of reports which are of no sense. So don't do wide reports. There are specific guidelines of reporting also. So now labs will not even report those ones. They will say only if they are very, very significant. So this is something you may get unusual report. Don't get worried about that if it is not fit.
So we have 29-year-old lady who was diagnosed as a man 2B, which was severe variety. Sister's son was three months old and concerned about MCT, medullary carcinoma of thyroid. So, and the genetic was suggestive of genetic study rate 918 defect was there. So in this case, either we have to go for thyroidectomy or not.
Yeah, so I think this is what we were discussing, that there was no family history there. The family history is there. You have to be clearly worried that you should do something. So I think this is where genetic prediction comes very, very nicely out here. So this required immediate surgery, and this is prediction can be there.
So we last case we have 12-year-old girl who having incidental hyperglycemia. HbA1c was well controlled 6.5. Fasting sugar 128 and 2-hour sugar was 135. Ketone was negative. BMI was 16. So might be we are dealing with the MODY type. And GAD was negative. So type 1 is out. And now child was on the genetic test. It was GCK deficiency. And what will you advise now?
So this again is the case we saw recently in the on-site course. So this case, this genetic diagnosis helps us a lot. It tells us that this is a non-progressive diabetes. We don't need to bother, don't require insulin, won't require anything else. So we have shown how genetic tests can help you reach a diagnosis, prognosticate, tell you what will happen in future, and go forward in that perspective. So I think this was, the learning point will be genetics is now integral part of modern medicine, but select the right test, appropriate technique and interpret it properly, and always be close within our arm's reach of your geneticist who will be able to tell you how it will go and how to interpret from that regard. So I think this was a good discussion. If you have one or two questions, we'll take and then we'll start with our inaugural session.
I'd like to know what is the difference between clinical exome sequencing and whole exome sequencing, number one. Number two, when we get, we have high predictive probability and all the features of certain diseases there, and we order genetic test, and it comes out to be non-pathogenic. So it uncertain significance. So is it the novel variant we are getting, or it is not in their database which is causing pathogenesis?
So I'll answer the second question. Dr. Poona will answer the first question. So second question answer is that maybe they don't have enough data to say that that is pathogenic. In some time, they might get more data, and you suppose you report your case, it may become that this is pathogenic. So this will change. It may change over time. Now, Dr. Poona, very important, whole exome versus clinical exome versus clinical whole exome.
The clinical exome, out of the 23,000 genes that we humans have, 18,000 genes for clinical relevance is known till date. And this whole exome sequencing actually reports the 18,000 genes. Out of that, if we say the most extreme part of 8,000 genes have been taken up into the clinical exome, that will be able to detect 60% of the patients with genetic disorders. So what it was thought like maybe 2 years back, the stepwise approach was there. That clinical exome 8,000 genes was the first test to be ordered in any suspected genetic etiology. But you should be sure that whatever is your clinical diagnosis and the most common gene associated with it is covered in that clinical exome. If it is there, then you should order the clinical exome because there is a difference in the cost. There used to be a difference in the cost, but now it is like the cost difference between clinical exome and whole exome is very narrow, maybe 2,000-3,000. And the other thing is the depth of the reading of the machine in clinical exome and the whole exome is same, almost same. So now gradually the clinical exome is becoming outdated. And so once once you think of a monogenic disorder, you actually go for a whole exome, that will be a wiser choice. But always and always give a good clinical clues or handles to the lab. Then only the detection will be. Otherwise, it's something like some kuch deख लिया, सब कैसा डाल दिया, फिर the result is normal. So you cannot rule out that if you get a normal report, does not mean that a patient is not a case of genetic disorder. That is very important.
So it is something like you were saying that if you have some short stature, you start looking at molybdenum, selenium, all those levels are coming, and then you say this is high, this is low. So you need to look at specific things. That is the first thing. If there is confusion, then you go. Otherwise, it's like in the dark, you are just trying to find things, and that may be difficult. I think last question, Dr. Seema.
Gain of function difference.
Gain of function.
Gain of function. So any defect in the sequence of a gene that is increasing the protein content and then causing the defect on the higher side. Like achondroplasia is a gain of function defect.
Like activating mutation, like McCune-Albert DNA, activating mutation. So I think this was a wonderful program, and Dr. Poonam has given very wonderful insights. I'll request Dr. Pradeep to kindly hand over the momentum to Dr. Poonam. And thanks Manoj for this participation in the session as well, and it was quite interactive for all of you. Okay, thanks a lot. And now we will be moving towards the inauguration part of the program. I am really honored to have with me Dr. M.M. Methani, who is considered the Bhishma Pitama of pediatrics in Kanpur. Sir, please come to the dais. He is a patron of our Glow Society since a long time. Always had listened to us. We have got Dr. R.N. Chaurasia, who is a senior pediatrician also at Kanpur, and he is also the patron of Glow Society. Sir, please come to the stage. It is indeed a pleasure to have both of them right from the beginning. All programs, both of sirs have been there in our program. It is again a great honor to have Dr. Atul Kapoor, who is the overall founder of this whole empire, which is there. It is really spreading across regions, across cities, and has been really, since I've joined, there has been always stimulus to do new things, and we have been going through. Whatever has happened has been possible through Dr. Kapoor's directions and help and guidance and blessings. And Dr. Rashmi, of course, who is the backbone of both Grow Society as well as pediatrics in Regency. So a warm welcome to all of them, and it's been a wonderful time. We have been spending here for 14 years with regards to that. So we'll invite all of you for that in that perspective. So the reason we are all here is to be part of the Advanced Pediatric Endocrine Symposium. So I'll go through again about what we have been doing and what we want to do in future. It might be something which will be progress from there, and how we are progressing and what the future direction is. So as we had discussed earlier, that it was through a long time we have been working in terms of awareness about pediatric endocrinology. But often when I had come with regards to pediatric endocrinology, the awareness issues were significant. And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorders, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there we started our program, and 2012 we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of Medi classes 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there, a lot of people are part of that program as well. Now we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians, and pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting, but what is, and you can simultaneously assess bone age there. So it looks very simple. You're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis, this is the investigations required, this is the likely treatment, and then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken, you will get results, interpretation. This is a work in progress. Lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussions happened in that regards. And we are now here for the third APES. We already done here. We are now going to talk about sugar, pituitary, and other aspects as well. So I would now request Dr. Atul Kapoor, who is the Managing Director and in charge of Regency Health, sir, to kindly come up and give a few words of encouragement. We also have Dr. Rishi. Dr. Rishi, please come and join. I think you were there.
Yeah.
Good evening, everybody. So welcome to Kanpur and welcome to this advanced symposium. Well, our history of the Department of Endocrine started way back in 1994. So she got us in 1994, so about 27 years back. That's when the department started. And gradually, 30 years back, and now the second member of the team started this business related to endocrinology was in vacancy. And I was supplement that Ra has been running around the whole country from north to south and east to west to make people aware of endocrinology. And with that, we have done great work. I'm sure that ultimately this education that we are trying to give to people, or we are imparting to all over the country, will bring better pediatricians and better pediatric endocrinologists to the benefit the entire mass. As you said, we are just 100. So to have maybe as we grow, we'll have more and more people. Now, see, basically, our department of pediatrics as such is quite big now. After a long time. Where are you? Let's work it out. Great. So we have with us way back resident also. That's where we started. Right? So the Department of Pediatrics and Agency is a big department, and we have most subspecialties in the department, headed by Dr. Rashmi Kapoor, the Director of Pediatrics. We have, I think, 4 EMBCs. How many? 4. So NB also we are running at pediatrics for the last 4 years. And the pediatric department per se has a pediatric endo, we have pediatric gastro, we have pediatric surgery, and neurology, intensive care, we have intensive care, all separate consultants for all these, for the various specialties. And so, very well, that's how, and that's been one of the biggest contributors to pediatric endo, because single-handedly getting the whole show. Well, once again, I'd like to and last 27 years, like also last 27 years, she was of Embryology department. So basically, PDC per se is now we have people who are working since we got it. So and a lot of people are joining the IIT. We have about now 1,000 people working on this one. About 150 consultants. We have a presence of about 5 hospitals in Kanpur, 1 in Lucknow, and we're looking at other flagship in Kanpur, about 350 bedded. Maybe as a company, we have also put the one group. But just spread out because space is less. And we also basically saw the seats for the hospital in Gorakhpur, which is already started. We got hospitals there in Gorakhpur. 24, June 24, there should be operational. I would, audience people are here. So, why I'm telling you these things that we welcome people to join us, go with us, and to go forward. Basically our attrition rate doctor level is hardly 1%. People are happy, they're satisfied. So I request all of you to spread word far and wide. If anybody wants to join the department, join the company, welcome. Then was in the energy, they will be new technology, they will new ideas, and we over here at PDC always accept them, try and support them so that they go forward. Thank you very much once again. Thank you, sir. I now request Dr. Arvind Chaurasia to say a few words of encouragement, sir.
Thank you, Dr. Anna. My proud privilege to be associated with the since its inception. And I have seen last almost 10 to 12 years. It's grown like to the country level and the international level. All credit goes to Dr. Anurag, who is really an asset to Kanpur. Now an international figure. We are proud of him and wish very best to him. I welcome all delegates here and I hope that they will benefit by this third advanced pediatric endocrinology update. Thank you very much.
Thank you, sir. I'll now request Dr. Mathani, who is really the father figure of all of us, to kindly have some blessings to us.
I'm grateful to the chairperson, Dr. Rashmi Kapoor, Dr. Rishi, grateful to Dr. Abdul Kapoor, who is the founder of the society. I'm grateful to the director of the program, Dr. Anurag Bharti, who has given me this opportunity to be with this unit. It is a great feast of knowledge as well as the subject of growth and obesity, hormone differences concerned. I would say human personality is an orchestra of the kinds. Every endocrine system is like a musical instrument, vibrates with a note, single note, and the symphony goes on. Similarly, the life is also a symphony. It goes from the childhood, the adulthood, and the old age. So the symphony has to be with the note of the life. And this how short you are, how fat you are, how brilliant you are, how the other qualities are also given by the enterprise. So this I will make to understand why Dr. Anurag is more than 2 decades. This is the third advanced Symposium. And the great spirit, Dr. Rishi Kapoor has been providing great appreciated. I appreciate if you delegates pick up the sense of knowledge and application. There are many things which are discussed in this symposium. We have to understand and make people understand all this. I am grateful to Dr. Anurag Bharti who has given conception of growth, capacity, and the kind of amongst the pediatricians also. So that's why they give all this to us. And thank you very much. I appreciate your efforts and it will bring better tomorrow.
Thank you, sir.
Good luck.
Thank you, sir. I'll request Dr. Rishi Shukla, who is the head of Department of Endocrinology, to give us some blessing.
Thank you, Raj. I decided to stand in front of you and speak in front of you. Like, good evening, friends. In the last 28 years, 2 great things have happened. And when I started, I was like you guys. Imagine younger Shukla or younger Raj. 2 great things have happened. One in the sense that the hospital that was being explained by Kapoor, it was a wonderful phenomenon in the city. Because at that point of time, even if you have money, you have no ability to save a life. The facility with infrastructure. And I was, when I joined this hospital and staying in this country because my parents here, so I came here, because everybody suggested we have to finish an endocrinology from here, that is not a right place at that point of time, 23 years back. But I decided to help me. And I've seen those hospital days also. There has been a huge resistance for hospital. Everybody was against hospital, and so much has happened. Now there is one place that I can go with those guys and at least make full effort. My mother's epidemiology was planned, my two surgeries were tested, my father passed away. So something has happened. So this is one wonder that I wanted to share. And second wonder is standing in front of me, next one is standing in front of you. Dr. Anurag Award. He did one bad thing also that I would like to share with all of you. Because 29 years back, when we used to be talking about pediatric endocrinology, the huge group of endocrinologists, the pediatricians, the endocrinologists. Because that time there was no order of other things. So I'm trained quite nicely in pediatric endocrinology. But now he's bifurcated. But good is bifurcated. And second back from that is that my interest in pediatric endocrinology is so again, it has benefits. And the reasons are there's enormous amount of work in diabetology, reproductive osteoporosis. Because every subspecialty is growing. I'm unable to cope with diabetology or basic thyroidology, obesity. It is complemented very nicely. And our 10 years, 13, 14 years went very nicely. I remember Dr. Kuchu came, how do you want to work together? We'll work together. I always believe in positive things, and somehow after 27 years, I can say if you move positive, if you move deep, you get it. And something similar is done by Dr. Tom. Not that he has done a good work, he could do good work because he moved with the team. So I request all of you to wherever you are, involve your team at whatever level. So that is.
Thank you, Dr. Thank you, Dr. Rishi.
Thank you so much.
In the midst of us, we have got a doyen of pediatric endocrinology, Dr. Subrato. Dr. Subrato, please come up and have some blessings from you. He presented wonderful 2 cases, and Dr. Subrato is the doyen in eastern part of the country, and he's one who started pediatric endocrinology there. So we love to have your blessings as well.
My pranam to all the senior pediatricians and the directors of this institution. The reason I have been associated with Anurag from 2008, he came to Calcutta in 2009, and there itself I saw that here is the future of pediatrics. And 12 years later, you can all see what he has done. He has grown as a person, as a department, as a society, and as an institution. It's been asset to all. And mine, is almost like my younger brother. When the first program happened, I came, and from there on, every program, of course, during the COVID times, it went online. And what I can proudly say is that all these, delegates, participants, students, whatever, they are starting their knowledge at a much higher plane than many others in defining pediatric endocrine. And this truly is so exhausting. And I've been actually participated, and now I was following the program through this wonderful IT technology. And it's all zooming all over the world, real time. And we are getting questions from Nigeria. So I think the important thing about is the impetus, the zeal, the knowledge is brought not only to this institution, but the state and the country. And I want to give everyone a big hand.
Thank you.
My father is for the last 5 days has been working with one more day to go tomorrow. And I think my best wishes are with you, with the program, and I'm sure everyone who's associated with both Anurag and his wonderful wife, both extraordinarily bright people who have brought a lot of value to to whatever specialty. And of course, I will miss if I don't say that every year that I've come, I've enjoyed the hospitality of Dr. Rashmi and so thank you for inviting me year on year. And I wish to be associated, and our relationship is bilateral. The next program that we do, we had one in 2019, the state program to the national level, and Anurag was in charge of the abstract. That went off flawlessly. Perhaps it was the biggest program ever, which we had in Kolkata. Many of the current people would have attended, and those who didn't will try and do another program. So thank you for the invitation. Thank you.
Thank you, Dada. So now I'll request Dr. Rashmi, who will be the backbone of all these efforts, to please share her experience and guide us in the future direction.
Good evening, everyone. And I have been seeing so many of you before also, again and again. So that speaks volumes of the kind of symposium that Anurag organizes. See, study and practicing or going to college and teaching students is something entirely different. Then imparting knowledge. See, everybody is practicing, but who is interested in imparting knowledge? He imparts knowledge to the fellows, and I'm so proud to say that all his fellows are practicing only pediatric endocrinology. So here we have Dr. Chetan, who was his fellow a few years ago. Like the time flies, so he was just telling me that his daughter has become 10 years, and I was actually amazed that it has been 3 or 4 years that he went away from Kanpur. Dr. Neha is there, who's working as a pediatric endocrinology. Dr. Rithi is one of our fellow, is again doing only pediatric endocrinology. So if you create a niche for yourself, I'm sure you don't have to go in for general practice. And when Anurag started pediatric endocrinology, as he put his first slide, that it was like, ये तो हमें पढ़ना ही नहीं है. हम लोग, see, I did my MD in 1984. That was we were the first generations probably in this hospital. Anurag is the second generation, and in our hospital we have already started having the third generation doctors, right? So at that time, endocrinology was a no-no for a general pediatrician. Right? But then gradually, as Dr. Rishi came, and we started seeing so many we used to discuss cases amongst each other, and then used to diagnose such cases, and I was actually surprised that we actually can see and we actually can diagnose pediatric endocrinology cases. And then came Anurag, and it has been really a treat to see the number of cases that he's collected over the years. Last 3 days has been really a treat to see a collection of all endocrinological cases. And many of you were there, I think, the last 3 days, and nobody will deny this fact that it was a real treat. So congratulations, Anurag, and year after year, I think it is just blossoming, and I wish you all the best and the society all the best. Thank you very much.
Thank you, Dr. Rashmi. So now I think what we'll do is that we'll be giving away the certificates for the people who had come for the on-site program and those who have completed their courses as well. I request Dr. Atul and Dr. Rashmi to kindly come up and hand over to the people the certificates, so we can call one by one the people and they can share the experience also. So we'll start off with Dr. Sumana. Dr. Sumana Kumatagami. She has done her advanced course and she's pursuing her fellowship in pediatric endocrinology. So she is from Kolkata. You can have something for that.
No, every time sir asks me to tell something, I feel overwhelmed and I can't put my exact feeling into words. I mean, that is not exactly how I feel. Sir is my guru in the truest sense of the term. I respect him, I adore him, and I mean, I don't know how to thank him. If it were not because of him, I couldn't have been standing here, and whatever little I have been able to do, I mean,
Dr. Pragya. Dr. Pragya has been with us now for last 3 years, so she has already done the basic and advanced. Now she did the diploma course is completed and she is working for the fellowship program as well. Pragya is from Bhilwara. Pragya.
I am with sir since I think 2018, and every time we come, we get to learn new things, and I'm still like when I'll be going tomorrow, I'll be looking forward to coming again next time. So.
Thank you. Dr. Mahesh Maheshwari. Dr. Mahesh is the professor of pediatrics at AIMS Bhopal. So he is finished the advanced course. And Dr. Mahesh and me go for a long time. He was in AIMS Delhi also. And now he is doing the fellowship with us.
Thank you, Dr. Anurag. I think for me, there are so many things to talk about, Dr. Anurag. When I joined senior residency at AIMS, Dr. Anurag was my MBA student. So initially as a senior, when you go, you always feel that he is a junior to you. But within a month, I realized that he is having something different and different. And since that time, I think that I was new to him. So he helped me a lot in settling down at a new place. And since then, I'm seeing his interest and sleep. And I think we are talking about his skills about endocrinology, his knowledge about endocrinology. But I think as a person, Dr. Anurag is a better person. And I think you can approach him at any time, any day, with the same gene. And I always feel I can call him at any time and any moment of various things. So thank you, Dr. Anurag, for giving me the support.
Dr. Nitya. Dr. Nitya is currently at Ernakulam Medical College. She is the assistant professor there. She is pursuing the fellowship, has completed the advanced course successfully. So we had a formal exit exam yesterday. It was a tough one, I believe. So that was the exam was there. Dr. Nitya, please.
I already told nothing much to say about Anurag sir. We are like, for us, pediatric endocrinology is almost equal to Anurag sir. So we are maybe a fellowship is maybe almost out of our reach because we are almost settled in pediatrics. We are doing teaching as well. As sir has come up with this fellowship and further courses. And as ma'am told, maybe pediatric endocrinology is one of the topics which we least read during our PGA. We just read it for the sake of passing exams. So now it's actually a new door towards pediatric endocrinology, sir, and officer. Thank you so much, sir.
Seema Rai. Dr. Seema is at Faridkot. She is the associate professor there, and she is pursuing the fellowship and she is the advanced course for yesterday.
It's been a wonderful experience over here, and we are learning excessively and robustly for the past 3 days. One thing I would like to share is I have been to so many places like PGI, professionally, I would say. And majority of the people who have spent high, they are not approachable. They do not have around the head. So I'm so thankful to sir that he's so nice, wonderful, we can approach him and then I'm thankful to sir. Thank you.
Dr. Manoj Mahajan. Dr. Manoj is a senior pediatrician in Mumbai, and he has been really pursuing all the technology and all the things. He's following very well. He's finished the basic and advanced, and now into the fellowship program.
Dr. Guru Prasad. Dr. Guru Prasad is also very dynamic and young endocrinologist practicing in Karnataka. Dr. Guru Prasad.
I'm one of the physicians who have enrolled in the pediatric endocrinology course. So everyone's asking why you want to go to pediatrics from when you are practicing adult endocrinology. What I felt that when I saw Dr. Arnav's first YouTube video, just it was I thought of studying this pediatric endocrine. So I feel endocrinology Kumbh I think, and Kanpur is the pilgrimage center for every person who seeks the. Thank you.
Dr. Guru Prasad. Dr. Manisha. Dr. Manisha is Associate Professor in Motilal Nehru Medical College, Prayagraj. She is also part of the fellowship, completed the advanced.
It was a wonderful experience here. For last 3 days, we have been seeing more than 300 cases. I don't think when we were in on-site, we would have seen so much of different varied presentation for pediatric and adult endocrinology, which we have seen in just 3 days. So I think 3 cheers to Anurag sir for such a Herculean efforts to gather so many patients at one time. Thank you, sir. Thank you very much.
Dr. Kamlesh Agrawal. Dr. Kamlesh is Assistant Professor at SMS Jaipur, and he is completed an advanced course yesterday. Only the exam is done. I think he's finishing in August, but I think he's cleared the exam. So.
Thank you, sir. I want to say that last 3 days we have learned a lot here, and the cases we have seen different type of cases. We will never see in our OPDs. We will never do the workup. And I hope I will do the workup after going there. After I will do the workup.
Dr. Kamlesh, now you have already done the advanced course and undergoing fellowship programs. Dr. Deepak. Dr. Deepak is from Janakpur, Nepal. He is in the Janki Medical College there. Dr. Deepak was with me at AIMS Delhi. He did MD there, and so Dr. Deepak. This is the second visit to.
Hello. Good evening, all. Actually, endocrinology was my basic interest when I did my MD examination, but the opportunity to learn endocrinology was very few. And we used to refer the cases to the IS and get my test because I was working with more part of the past. Then I came to the YouTube channel because I was not in direct contact with the search, and it was so marvelous that I thought this is the time I should start learning endocrinology. And when I came to this center, and as the time passed, 2 to 3 years, I've learned so much, and I have seen so fantastic cases that probably I would have never seen in my life. Even at APES, at that time, we didn't have that variety of cases. So I'm really thankful, and I wish many young people could join the program and spread the idea of pediatric endocrinology.
Dr. Pradeep is the Assistant Professor at AIMS Patna, and he has been very keen in spreading pediatric endocrinology in that region.
As I always say, sir is not only a guru for me, but I copy him for everything I do. Endocrinology came as good serendipity to my life. When I joined AIMS Patna, in AIMS you have to do it differently to survive. So you have to choose some specialty. And I came to know that very time, sir had started online course, and I joined that. Although I know sir, when we first APES, I came here in 2015. So I was knowing sir, but when I started, and now pediatric endocrinology is oxygen for me. I live for pediatric.
Geeta Das. She has just joined our program recently. This is the first visit. She is at AIMS Nagpur.
Unlike others, I just want to say I'm just a budding pediatrician. But since first year, the diagnosis of Moriarty syndrome of a child, I was sensitized to endocrinology, and I used to do extra in endocrinology, like Nelson. I used to be more like that. So after passing, I joined AIMS Nagpur, and that's what I got. Like since 2-3 months only, I'm with touch with sir. But one thing is like this visit has sensitized me, sir, so much. I don't have any scope to do wrong right now. I know the protocols and I have to follow it, and I am happy and I'm lucky that I'm able to do this since my beginning of my career. And I promise this is not my end. I'm going to go longer with you, sir. Thank you so much. And one thing also I want to say, I am really impacted by his personality. I mean, he is so famous, he is so like learned person, but still he's so down to earth, like answering to each and everything with a huge greater smile. It is really nice being exposed to such a personality. Thank you so much.
Nature is control. Dr. Priyanka Gupta from Jaipur. Dr. Priyanka is in the fellowship program. This is the second visit.
This is my second visit here. I started with the basic course. Initially, I also got to know about the course from the YouTube videos I watched. So I wanted to do something after pediatrics, but I could not. So after watching the videos, I came to know that online course is also available. So I didn't join it. And I feel really overwhelmed and after seeing so many interesting videos.
Sona Gupta, also from Jaipur.
एक बात कहना चाहूंगी कि आई एम फ्रॉम प्राइवेट क्लिनिक, आई रन माय ओन प्राइवेट क्लिनिक एंड बिग जनरल प्रेजेंट, बट ये हमेशा था कि कुछ करना है, लेकिन जैसे आई पास एक्सपीरियंस हुई कि देन अब देयर इज नो स्कोप, नथिंग टू डू, है ना, काफी था, पर शुरू से आई वाज गुड स्टूडेंट एंड वांटेड टू डू समथिंग. सरकार सारे को जयपुर आए थे 10 साल पहले, आई सॉ टिकट तो बहुत ही अच्छा लगा. My bandmate for that maybe आपके approach करने की, but I was so inspired by the sir. I did the basic course and now I joined the fellowship course. And it's really helping me even at my private clinics. Now the cases are coming and we are seeing that, working them, and it's really so good. जैसे कहते हैं ना कि सपनों को उड़ान दे दिए सब. Really, I'm so grateful to you, sir. Thank you so much.
Dr. Lovelis Gopalia, Albert. So Dr. Lovelis is a senior resident currently there. She's also part of the fellowship program. First visit, I think.
This is my first visit at Nagpur and it's a great learning experience. Thank you so much.
Anusha Reddy. Dr. Anusha is from 7 Air Force Hospital in Kanpur, and she is very keen in pediatric endocrinology. Just recently joined with us. This is the first site visit.
Good evening, everyone. I was sensitized to Dr. Anurag Vajpayee and the aura about him during my residency days when I used to go through the YouTube videos that sir had posted. Incidentally, it so happened that after this, I finished my DMD pediatrics just last year, and then I got posted to the 7 Air Force Hospital in Kanpur. The moment I came to Kanpur, I just searched through this website, and then I came to know that there is going to be a fellowship program which is going to be started. So I thought, why not utilize it to make my dream come true regarding endocrinology. And sir has been kind enough to, since I'm based in Kanpur only presently, sir has been kind enough to offer me to come to his OPDs. I will definitely try and take time out of my regular schedule and see cases here as well. Thank you, sir.
Dr. Arpita. Dr. Arpita is Associate Professor at KGMU, Lucknow.
It was saying, being in a university, you have to choose some specialty, and I was interested upon pediatric endocrine, and with our MD experience, we are not so exposed to endocrinology. So I had again a chance to search for pediatric online fellowship program, and I saw sir, and I had during my residency days attended the group workshop sir did, and it was just fantastic. And I would just say one thing, that he makes such complex endocrinology flow charts, which we were scared during our MD days, so simple. That's nothing about it. Thank you so much.
Dr. Alka Jha. Dr. Alka is an endocrinologist, actually, adult endocrinologist in Fortis, Delhi. But she is very keen in pediatric endocrinology. Yeah.
Thank you, sir. It's a dream come true. Sir, you are because of the revenue. I met you when we joined Fortis CEO at Gurgaon and Delhi. That time I came to you for the simple cases. You explained it so elaborately. A thought come to me after looking for an update. So it's a dream come true. Thank you, sir. It's a wonderful experience.
Dr. Bifina. Dr. Bifina is Associate Professor at Ernakulam in Kerala. So she has just joined the fellowship, and this is the first visit.
Thank you, sir. Actually, I have come all the way from Kerala, and initially I was very apprehensive to travel this much. But now I thank God I have come this much, seen sir, and seen such a variety of cases. So I couldn't believe that there was so much variety of cases in pediatric endocrinology. Thank God, thank you, sir, and I've come to learn a lot.
Dr. Princey Joseph from Kollam, Kerala. She also recently joined our program.
Only I'm working in a private medical college. Whenever some endocrinology cases come, I have to refer all the patients. They have to travel some 100, 200 kilometers for my tertiary center. So I thought, if I have some interest, but I become better, it will be better for the other patients also. And that time I am searching in the YouTube many for the workup of the patients. I came to know about the sir's videos and everything, and impressed by that. I am very much apprehensive to come all the way from Kerala to UP for the first time I come here. I actually asked sir whether somebody will help me out here. Okay, so it's a wonderful time for me. Thank you, sir.
Scared of the company employs about 350 Malayalis who are working with us. We are coming and going from the left.
Dr. Nitin Pandey from Lucknow.
So, first, the circuit subject, most of the time we see it remains centralized, but sir has decentralized and making a complex, complicated things to very simple flow chart, so that we can diagnose a difficult case in small amount of time. So, thank you, sir.
Dr. Santosh. Dr. Santosh is from Trivandrum, SAT Medical College. He is a professor there in SAT Medical College.
I will say a single word about sir, because already everybody had talked a lot about sir. He's a great karma yogi. Thank you.
Last but not the least, Dr. Sanjay Kumar. Dr. Sanjay has been the one who has been associated with us for decades now. And he's been coming for every program, even if he is sick, even if he is healthy. So he is really the one who is dedicated on pediatric endocrinology. He comes from Sitamarhi, but he is pursuing his interest continuously.
During the class, he asked the maximum questions.
Two or three things I want to share. One of our colleagues over here was saying that Dr. Anurag is banyan tree, don't like banyan tree. In the all over India. But I don't think so. Banyan tree gives only shade, but don't allow to grow any other plant. But even a shade, but he has allowed us to grow. So it is not together we learn, but together we grow. Last night, one of my friends from London had phoned me after 10 to 12 years. You are participating in the program. You are participating. I told him, he phoned me after 12 years. And even that, when he speaks, one of my friends from Dexa, junior college, she phoned me. We are separated 22 years back. She phoned me, boss, are you in Dr. Raj program? So he is so famous. He is famous all over the world. Actually, I took admission in pediatrics by default. I was not very interested in this field, and I was very much dissatisfied. So I thought to do something extra. After passing my MD, and when I was practicing, I began to make growth chart of my patients and analyze it scientifically by going through the textbooks again. And in the meanwhile, I met him in 2009 or 10 in Kolkata. And since then, we are associated. Thank you.
Thanks a lot, Dr. Sanjay, and thanks everybody for the all the patients. We will have the lamp lighting, and then we'll start with the next session. In between, once the lamp lighting is over, we can then somebody can have tea, and then we'll start the session. So I request Dr. Chaurasia, Dr. Mehtani, and Dr. Rishi, Dr. Subrato. Thank you, everybody. And I'd like to thank the entire team which has been involved to make this event successful. I'd like to thank all the faculty who has come from across the country who have to make this program successful. Dr. Methani, Dr. Chaurasia, Dr. Rishi, Dr. Atul, Dr. Rashmi, Dr. Subrato, the entire team, all the participants from across the country who have come, our team of the entire Regency, CDR, Growth Society, Mediclasses, who has been involved, all the sponsors, all the fellows. So everybody will give a 3-round, I think it's a big round of applause is required for everybody. And this event has been very successful. And I thank all of you. We will have just a couple of minutes of break because this is a live streaming session. And we'll be starting the session in a couple of minutes only. So you can grab some tea there if somebody has not taken and come back. And we'll start with the next session in a couple of minutes. हो गई। who has joined this. Dr. Pratik, you can just now maybe unmute yourself. Dr. Pratik is a close friend of ours, and he has been working in the field of hyperinsulinism for a long time. Dr. Pratik, can you please unmute and open your video? We can then start the session.
Can you hear me, Anurag?
So we are joining also, Dr. Ved Arya is there also, and Dr. Pratik, both of them have joined us. Dr. Ved have a session on hypothalamic amenorrhea, which will be happening at the subsequent session, and we've got Dr. Pratik who has joined with us.
Can you hear me, Anurag?
And Dr. Pratik will be talking about a very, very interesting topic of hyperinsulinism. And his whole work of interest, area of interest has been on hyperinsulinism. This is one condition we are seeing more common, and especially in the neonatal period, severe hypoglycemia, how to assess, how to manage, we'll go forward from there. So Dr. Pratik. So Dr. Pratik, you can share the screen. ये वॉइस इसकी आवाज बड़ी इसके थ्रू आउटपुट ये कौन सा है, इसका क्या आउटपुट का नाम क्या होगा? हाँ, एक्सटर्नल हेडफोन आउटपुट आ चुका है ना टेस्ट की तो. So Dr. Pratik, somehow we are not able to get your audio. We are waiting for that. Dr. Pratik Shah is a consultant pediatric endocrinologist and honorary senior lecturer in Department of Pediatric Endocrinology and Diabetes, Royal London Children's Hospital, and Barts Health NHS Trust. And his work has been focused on Queen Mary's Hospital. So, somehow the output.
Can you hear me now?
Yeah, Dr. Pratik. कौन सा वाला USB Nova. Yeah, Dr. Pratik, can you speak something? I think now might be.
Can you hear me?
Dr. Pratik?
Can you hear me?
Somehow your voice is not coming.
I can hear you. Can you hear me?
Yeah, now I can hear you. Yeah, coming.
I can hear you. Can you hear me?
Yeah, now I can hear you. Yeah, coming. Yeah.
I can hear you.
So I think Dr. Pratik, we can hear you now.
Can you hear me? I think.
Yeah, now I can hear you. Yeah, Dr. Pratik, you can carry on from here.
I can hear you.
Dr. Pratik. So I think Dr. Pratik, we can hear you now.
Can you hear me? I think Anurag, this is an audio problem because it is just playing my voice.
Yeah, now your voice is audible, Dr. Pratik. You can start. So I think Dr. Pratik, we can hear you now.
I think Anurag, this is an audio problem because it is just playing my voice.
Yeah, now your voice is audible. Okay, you can start. So I think we can hear you.
Anurag, this is an audio problem because it is just playing my voice.
Yeah, now your voice is audible. Okay, you can start. So I think we can hear you.
Anurag, this is an audio problem because it is just playing my voice.
Yeah, now your voice is audible. Okay, you can start. So I think we can hear you.
Anurag, this is an audio problem because it is just playing my voice.
There seems to be a confusion. Dr. Pratik, can you hear me? You can start. Dr. Pratik, can you hear me?
An audio problem because it is just playing my voice.
Dr. Ved, can you hear me? Dr. Pratik? You can unmute yourself, Dr. Pratik, and we can try again.
Check, check. Is it okay?
Yeah, now the voice is there.
Is this good?
Yeah, it is good now. You can start. Yeah.
Check, check. Is it okay?
Yeah, you can start. You can start. Now we can see. Listen to you.
Is this good?
Yes.
Is it okay?
Yeah, you can start. So you can share this and we can start from there, Dr.
I just wanted to make sure that because here I'm getting a lot of echo and it keeps playing up the voice. I just wanted to make sure that here I'm getting a lot of echo and it keeps playing up the voice.
It seems that there are, do we have another system running the voice?
Can you hear me?
Yeah, now I can hear you very clearly.
Do you want me to start then?
Yeah, it is clear now. Yeah. So, Dr. Pratik will now be talking about hyperinsulinism, a very, very important phenomena which is very common in pediatric practice. Dr. Pratik, you can share the screen and start. Yeah.
Thank you very much, Anurag and the team for inviting me. I hope the audio is clear. Please stop me if obviously you cannot hear or if there's any problems. So what I'm going to do in the next 25 to 30 minutes, I'm going to talk about recent updates in the management of hyperinsulinic hypoglycemia. And I always show this slide as this picture first, because I just want to make sure you all have got normal blood glucose levels. So in the next 25 to 30 minutes, what I'm going to cover is first about a bit of hypoglycemia, how to make diagnosis, and why is it important to actually make diagnosis. And then I'll talk about hyperinsulinic hypoglycemia, mainly about genetics and the recent, some of the mutations that has been described to cause hyperinsulinism, the causes, and then also diagnosis about newer imaging techniques. And management, where there are certain clinical trials going on right now in managing this condition. So when we talk about hypoglycemia, well, when I ask junior doctors and when we discuss about with neonatologists and and non-pediatric endocrinologists, we would always say, what is normal blood glucose range in a child? And it actually varies. And still over the last 30 years, there have been numerous publications that have been published to show what is a normal blood glucose levels in a newborn or in a pediatrics. And at the moment, there is no as such universally accepted definition of hypoglycemia that can determine absolute clinical risk and predict sequelae. So when we see a child with hypoglycemia, we always have to think about look at the plasma glucose concentration in association with the risk factors, the clinical state of the baby, and the intermediary metabolites that is available or that is present at the time of hypoglycemia. And hence, we have to have individualized approach to manage some of these children. And in the UK and EU, we keep blood glucose levels above 63 milligrams per deciliter, which is 3.5 millimoles per liter, to manage hyperinsulinism. And in US, they actually keep the cutoff as 70 milligrams per deciliter. So we aim to keep the blood glucose at least above 63 milligrams per deciliter. This was published about 6 or 7 years ago by the Pediatric Endocrine Society, and we've just submitted our international guidelines a few months ago, so that will be out soon as well. And what was recommended is that for neonates with a suspected congenital hypoglycemia disorder and older infants with who have confirmed hypoglycemia disorder, then the recommendations was to keep their blood glucose above 70 milligrams per deciliter. And for those high-risk neonates without a suspected congenital hypoglycemia disorder, then to maintain at least above 50 in the first 48 hours of life, and then about 60 after 48 hours of life. This is one of the publications that was reported about 6 years ago in the UK, and this was reported by the midwives. And what they reported was how many claims have occurred in the UK due to neonatal hypoglycemia brain injury. And NHS have paid out in about for 10 years, there were about 25 claims, and NHS have paid out £162 million in terms of the complication that has been developed or missed due to hypoglycemia in babies. So as we know that hypoglycemia can cause severe brain damage, and it's really important and crucial to recognize the signs and symptoms. However, when I ask this question, do actually all babies or children have signs and symptoms of hypoglycemia or ketosis? And no, they don't. We always look at it that sometimes they obviously may not have, and they don't have symptoms of hypoglycemia, and hence it is even more important to monitor them regularly and making sure that actually we treat them quickly enough so that they don't develop any long-term complications due to hypoglycemia. So when we do a hypoglycemia screen or hypo screen, it is very important. If it's done in a controlled manner, then we have to make sure we prepare everything in advance before we actually do a controlled hypoglycemia. So we obviously make the baby or a child hypoglycemic, and what we take as cutoff as less than 3. Obviously, in babies in the first 48 hours, you may take the cutoff as so less than 54 milligrams per deciliter, but you may take the cutoff as 50 in the first 48 hours of life. But more importantly is that you reduce IV glucose infusion in a controlled manner. Depends on how much glucose infusion they are on, but generally it works out as 1 milligram per kilogram per minute in every 15 to 30 minutes. So we have to think about and monitoring blood glucose every 15 to 30 minutes, making sure as soon as they drop the blood glucose below 50 or below 54, we take the hypoglycemia screen, we treat the hypo, and then we put them back onto normal fluids. This is just our fasting protocol that we use at our hospital. Obviously, this all depends on the age of the child when we fast them. And obviously in neonates, we look at around 6 to 8 hours of fast, whereas in older children, we go up to 18 to 24 hours of fast. So what is hyperinsulinic hypoglycemia? So hyperinsulinism is due to inappropriate secretion of insulin in relation to the blood glucose concentration. It's a cause of recurrent and persistent hypoglycemia in infancy and childhood. And it's actually a major cause of hypoglycemic brain injury. And this is just one of the MRI images that just shows that how baby has had hypoglycemic brain injury in the parieto-occipital region, and subsequently developed severe neurodevelopmental delay. So this is a normal brain MRI, as you can see, and this is the child with severe parieto-occipital brain damage. And this child was actually normal, with a normal birth weight and no risk factors, and then presented with at 48 hours of life with hypoglycemic seizures. Subsequently turned out to be hyperinsulinism, but it was a transient form, so it did eventually come off diazoxide, but obviously now has this hypoglycemic brain injury. So when we talk about causes, they can have transient hyperinsulinism, where it could be due to infant of diabetic mom or maternal use of drugs like sulfonylureas, and IUGR babies are small for gestational age, perinatal asphyxia, rhesus hemolytic disease, or erythroblastosis fetalis. So they are all the ones which can cause transient. However, there are obviously the permanent forms, which is there are certain genetic forms which I'll come in a minute. And we would normally see that they would have a fasting hypoglycemia. So these babies would not be able to fast appropriately for their age. And as you try to wean fluids, or if you're giving them regular feeds and they still continue to have hypoglycemia, or even on normal 2 to 3 hourly feeds. There are other forms of hyperinsulinism, which is postprandial hyperinsulinic hypoglycemia, protein-induced and exercise-induced, and there are genetic mutations that have been described. But what has also been described in the literature, and it is now well evident, that both transient and the permanent forms are equally actually responsible to cause hypoglycemic brain injury. Hence, it is really important to actually determine and make sure that we regularly monitor these babies and treat them if necessary. There are various syndromes that has been described to cause hyperinsulinism, and the list is actually getting bigger and bigger. The most common, which I would like to mention here, is the Beckwith-Wiedemann syndrome, Kabuki syndrome, and Turner syndrome, or Mosaic-Turner syndrome. There are other, as I mentioned, there are other obviously syndromes that we need to just keep in mind. And I would just like to go through some of the literature in terms of syndromic forms of hyperinsulinic hypoglycemia. So there is an international expert consensus guidelines that have been published, and for Beckwith-Wiedemann syndrome, and what they suggested that if there is any baby with suspected Beckwith-Wiedemann syndrome, then they should have a fasting test before they go home, because up to 2/3 of children with Beckwith-Wiedemann syndrome can have hyperinsulinism. Obviously, they vary. They can have a mild form, or they can have a severe form where they don't respond to standard medications and requiring pancreatectomy. The Japanese group actually published their survey, the nationwide survey, in 3 syndromes, mainly Beckwith-Wiedemann, Soto's, and Kabuki syndrome. I think they had over 300 children who were diagnosed across the country, and they actually looked at how these children present. And most of them would respond to standard medical treatment. But again, it's really important to make sure that obviously this group of children or with suspected syndrome should be screened for hypoglycemia. And we published our long-term study, 15-year follow-up study, and we had about 70 children who we had retrospectively looked into, with all forms of syndromic hypoglycemia or hyperinsulinemic hypoglycemia. And what we found is up to 2/3 of children were actually they were able to come off diazoxide after 2 years of age. So generally they were milder and responsive to diazoxide, and most of them do come off diazoxide eventually later in life. So hence it is really important to follow up this group of children in terms of monitoring and making sure that, if they do come off diazoxide. And again, we, along with the US group, published 9 children with Kabuki syndrome, which is very similar to what the Japanese group had published. And it was more important that actually, again, this group of children would generally respond to diazoxide, but they can even eventually come off diazoxide. So when we talk about congenital hyperinsulinism, it's obviously thought as a rare disease, but actually I think it's been recognized more, especially with the transient forms, and making sure that we obviously manage them and recognize them and manage them promptly. We published in the UK these couple of years ago where the incidence actually was calculated, and it was about 1 in 28,000, where initially it was thought about 1 in 40 to 45,000. And actually, it is more commoner in countries where there is high rates of consanguinity. So you obviously see more babies with hyperinsulinism if there's high rates of consanguinity. It typically presents in neonatal period. However, they can present later in life in infancy and childhood as well. The typical biochemical hallmark is low ketones, which is hypoketotic, low fatty acid, which is hypofatty acidemic, detectable insulin at the time of hypoglycemia. So hence it is really important to take the samples, the critical samples at the time of hypoglycemia to help and reach to the diagnosis. It is very heterogeneous in terms of clinical presentation, histology, the molecular biology, and genetics. And if you look at the genetics and we look at the monogenic forms, yeah, there are about 8 to 10 genes that has been described. However, the list is now actually getting bigger and bigger. And over the last few years, there are several genetic mutations that has been described to cause hyperinsulinic hypoglycemia with other systemic involvement. So you could kind of say they are like syndromic forms with having multi-systemic involvement. However, the first two which I've put in the red is the most commoner ones, which is a KATP channel gene mutation, which is really important to determine the two forms of hyperinsulinism, which is focal or diffuse, which I'll come back in the next few slides. However, the recent in genes which has been described to cause multisystemic involvement is the fork head box protein A2, FOXA2 gene mutation that can cause hypopituitarism as well as hyperinsulinism, catenate, which is calcium voted channel mutation that can cause heart problems along with hyperinsulinism. And we described two genes, which was EIF2S3, which is actually causing hypopituitarism, neurodevelopmental delay, as well as hyperinsulinism or diabetes. So what we found is this gene is expressed both in pituitary gland as well as in the pancreas. And there has been adults or adolescent or adults who have been reported to have diabetes. Obviously in young children and present with hyperinsulinism. So again, this is really important that how actually, these genes help us to determine the cause, not only the cause, but also in terms of monitoring, because they can develop diabetes later in life. And a similar protein, which is called DNA JC3, which is it's a heat shock protein. It's produced by the endoplasmic reticulum. And again, this protein can cause neurodevelopmental delay or neurodegenerative disorder along with other endocrine problems. And we reported 2 cases who had severe short stature and hypothyroidism, though they did not have growth hormone deficiency. But with severe neurodevelopmental delay and hyperinsulinism. And there is another group who had published with similar gene mutation who actually reported, individuals with diabetes with the same mutation. So again, that's, this just shows that how this gene can present and cause hyperinsulinism or diabetes. So when we talk about the 2 genes, most important genes about the KATP channel, which is ABCC8 and KCNJ11. So the ABCC8 gene is encoded by sulfonylurea receptor 1, and KCNJ11 is by potassium invert rectifying channels. And they both are KATP channels. And the autosomal recessive ones are usually quite severe ones. However, there are autosomal dominant forms which can be quite severe, and there have been reports about that they can be medically unresponsive. However, they can generally be responsive to it. And later on, they develop MODY or diabetes in life. So this is a cartoon model that explains the KATP channels and insulin secretion. So essentially, the glucose enters into the cell and that undergoes glycolysis and increase in ATP molecules. That actually causes the KATP channel, which is expressed on the membrane, to trigger and depolarize the beta cell membrane. As a result, it actually opens up the calcium channels, and the calcium enters into the cells and causes insulin secretion. So this is a normal mechanism that involves KTP channel. However, there are other mechanisms which also which has impact on beta cell to cause insulin secretion. However, when we talk about the KTP channel mutation here in this, when you see that if the child has got KTP channel mutation, then the channels are not expressed on the membrane, and as a result, the beta cell membrane is continuously depolarized, irrespective of glucose entering into the cells. So, like I said, when we think about fasting hypoglycemia, so even if the baby is feeding or not, there will be continuous depolarization of the membrane, and that will cause dysregulated or unregulated insulin secretion. So in terms of diagnosis, when we look into is that most babies would require glucose more than 8 milligrams per kilogram per minute. There is a presence of insulin and C-peptide at the time of low blood glucose concentration, and there is low fatty acids and low ketone bodies at the time of hypoglycemia. In terms of management, it's really important that we maintain the blood glucose levels about 3.5 or about 63 milligrams per deciliter. And we monitor the blood glucose frequently, ideally 1 hourly. If needed, have a central venous access to give intravenous fluids or high concentration of glucose, or sometimes they need continuous feeds, and also monitoring their fluid balance. And the reason we need to think about monitoring fluid balance is because of the drugs that we use. And the first line of treatment is diazoxide, which can cause fluid retention, and hence it is really important to monitor the fluid balance when we monitor them. And we always give diuretics along with this. So we use chlorothiazide in babies, or if there is any concerns, or if they have any underlying cardiac problem, then we use stronger diuretic like furosemide and spironolactone. There has been reports about use of calcium channel blockers along with diazoxide like nifedipine. And if obviously they're not responsive, then obviously then they go on to somatostatin analog like octreotide, which is usually given as 3 to 4 times a day subcutaneous injection. I would just like to highlight that somatostatin analog is always given subcut, and please do not give IV if given on the unit, because there is a risk of necrotizing enterocolitis. We reported our UK experience in terms of diazoxide causing pulmonary hypertension, and the US group has also published their recommendations in the last couple of years. So it's really important to think about the rare side effects of diazoxide, especially the pulmonary hypertension. And what we found was that most of the babies we require to fluid restrict, which is around 130 to 140 mL per kilo per day. Obviously using diuretics, but if they have any underlying cardiac problems like ASD, VSD, or even PDA, then think about using stronger diuretics like furosemide and spironolactone. Obviously, they can have lots of other problems, so hence it is really important to monitor them for feeds, their orality, and trying to make sure that they are regularly monitored, and if needed, do a regular echo. So when if they're not responsive to medical therapy, what's the next step? So when we talk about the two forms, it's mainly the diffuse and the focal form. So the diffuse form is where you've got all the beta cells, which is affected throughout the pancreas. And then focal form is a very small part of pancreas is affected, and the rest of the pancreatic tissue is normal. So how do we distinguish between the diffuse and the focal form? So it is by genetics and imaging. So when we talk about genetics, it's if the mutation is inherited from the father, which is paternal inherited KTP channel mutation, then we obviously need to look into any focal form. And obviously, if they've got homozygous or compound heterozygous, so autosomal recessive forms are diffuse form, causing diffuse form of hyperinsulinism. But if we need to do imaging, then the standard imaging that is currently being used to identify focal lesion in the UK is 18F-DOPA CT scan. However, we've had issues in the UK about 18F-DOPA production, and I know other countries have been using, and even in India, I think we're using more of gallium-labeled exendin, which apparently I've heard that it's really accurate. But however, it's really important that we have a good nuclear medicine radiologist who can actually read those images. So we actually did a multi-center EU trial some time ago, and we published about our gallium exendin data, which is called a beta peer study. And what we found was actually it does help in terms of detecting focal lesion better compared to 18F-DOPA. And I'm just showing some of the images from the article where you can see this is exendin PET CT and this is 18F-DOPA PET CT. So you can see that this is the focal lesion in the head of the pancreas, where you can see this is 18F-DOPA, which was reported as diffuse disease in the first place. However, when we did the gallium exendin, we found that actually there's a focal lesion in the head of the pancreas. Very similar here. You can see that this is much less highlighted. So the standardized uptake value here is much less compared to this area. Whereas you can see that these both are pretty much equal brightness on 18F-DOPA. So now you can think of whether they have got multifocal or they've got focal lesions multiple sites. Again, a similar scan here, you can see that two areas which is similar highlighted, whereas here you've got tail of the pancreas, where the focal lesion is in the tail of the pancreas, which again in exendin was more useful. But as I said, it also depends on who reads the exendin scan. So it is really important that actually they are read by an expert. So when we talk about glucagon and octreotide, I would just like to mention that, yes, glucagon octreotide can be used as an emergency, or if you don't have an IV access, you can use as a subcut infusion. And the usual dose is 2.5 to 10 micrograms per kilo per hour. So I just wanted to show you that there are just two cannulas here under the skin that can be used to give a subcutaneous infusion. So in case if you lose an IV access. But more importantly is to make sure you change the infusion syringe every 12 hours because glucagon sticks to the tube and it can block to the tube. Octreotide is a somatostatin analog, and as I mentioned, please do not use it as IV. It should be used as a subcutaneous infusion or as a subcut injections 3 to 4 times a day. And the usual dose is 5 to 40 micrograms per kilo per day. As I mentioned, there is a high risk of necrotizing enterocolitis in babies and newborns. So it's really important that we actually monitor them and not to use very high dose and not to use IV infusion. When we talk about newer therapies, and that's one of the things that is currently being looked at right now, over the last several years, and I've been involved in a couple of treatment, which is one is long-acting somatostatin analog or lanreotide, and the French group had published a long-acting octreotide experience with long-acting octreotide, and I know that in India we use more of long-acting octreotide, which is LAR. Which is usually given once every 4 weeks. And there are other drugs like sirolimus, which is mTOR inhibitors. But the more important thing with sirolimus is obviously it's an immunosuppressant. So we have to monitor them very closely in terms of the levels, in terms of trough levels, as well as any side effects they can develop due to sirolimus. The US had used GLP-1 receptor antagonist, which is exendin, where they actually, obviously this is used as an IV infusion. So this is used in the hospital setting. So you cannot send children home with this infusion, but this can be used as an IV in the hospital setting. However, there are several clinical trials going on right now, and I will be talking about, I think there are some trials which is being planned to start in India. And I think that is really beneficial to our patients in India with severe form of hyperandrogenism. So mainly is dasiglucagon, which is another form of glucagon that is used as a via insulin pump. So that can be given as a continuous infusion, like we do in diabetes in a closed loop fashion. Resolute is one of the pharma companies who uses insulin receptor antagonist, and there is phase 2 and phase 3 trial being done in this drug. And Trinetics, which have just developed SSTR5 agonist, which is an oral drug, which is really interesting now, and they are doing a phase 2 trial as well. So this is the only oral drug which is available and in terms of managing hyperandrogenism. So let's hope that we do find some new treatments in the next few years. And again, nutrition and feeding is really important because most of these babies will have some feeding problems because we feed them frequently, and sometimes they need nasogastric or gastrostomy feeds, so they actually lose the orality. So it's very important that we promote feeding oral feeding as much as possible. Diazoxide, somehow it has been reported that it can affect orality. So it's really important to monitor them for feeding and orality. So to conclude, persistent and recurrent hypoglycemia should always be investigated. We always have to think about the long-term implications that babies can have due to hypoglycemia. Early recognition and prompt treatment is really important in preventing hypoglycemic brain damage. Genetic diagnosis may help in guiding management as well as recognizing other systemic involvement, like I described the syndromic forms. Gallium-labeled examine scanning is now is kind of being adopted as a newer modality in terms of scanning. However, we need to have good nuclear medicine and radiologists to read those scans. And there are obviously a lot of clinical trials being undertaken for looking into newer medications managing hyperinsulinism. So I'd just like to thank Anurag and team for inviting me. And I work with various colleagues in UK and India, as well as internationally, as well as my colleagues at my workplace. And I also am working with Audi, and I'm a professor at Karamsad, and I'm supervising a PhD student right now who is doing actually genotype and phenotype in children with hyperinsulinism. So that's one of the research studies that is being undertaken. Thank you very much. I can't hear you, sorry.
Can you hear me now? Yeah.
Yeah, I can hear you.
So there's a lot of interest about the role of genetics in terms of preventing the need for scans. So often these PET scan become the difficulty. So how do you find these genetic issues in terms of the specific predictors of a diffuse disease versus focal disease? And that could be one surrogate. What is your take on that one?
Yeah, so I think, yeah, it's a very good point. So genetics is definitely helpful, and we should do genetics before we undertake scanning. So that is what currently we are trying to develop, to have some kind of, genetic testing that can be done in India. And that's what the PhD project is as well. So just to help in terms of, if you do get a confirmed homozygous or compound heterozygous disease, KATP channel mutation, then you know it's a diffuse disease and it's an autosomal recessive form. So they do not need scanning. However, if they have a paternal inherited KATP channel mutation, which is suspicion of focal lesion, then they will need scanning.
That's a very interesting point, at how genetics can really guide us towards evaluation and management. The second important point from our side is the interesting developments of newer drugs. Because earlier on 10-20 years ago, we were always talking about pancreatectomy as a major cause. But now there seems to be a plethora of drugs. So which particular drug you will suggest that we should watch the space for?
Sorry?
So which particular drug should we watch the space for in terms of response, medical treatment? Which drug do you think is the most expected to have a good response?
Sorry, I can't hear you, Anurag. The volume is very little.
Can you hear me now?
Yeah, I can hear you.
Yeah, so which drug do you think has the most potential for the future for medical treatment of hyperinsulinism? Based upon
that's a very interesting question. I think what is going to come out is that some of the children, I think that all these drugs would be available, but some children may respond, some may not. And that is what currently is being kind of felt, that, all children may not respond to, this medication. So at least we would have a couple of medications to trial, and that might help. But obviously oral will take priority over the injections route. So let's hope that we get more oral medications available.
So I think this was a really informative talk. And any particular comments from the panelists? Or any other questions that you want to take from there? So I think these were the two major. Dr. Bhaskar, you want to make some comments? Yeah, so it is a very interesting area. A lot of research is going on, and hope next time Dr. Pratik talks, we'll have many successful oral therapy also comes into the picture. Thank you, Dr. Pratik, for sparing your time, valuable time for us, and we'll give a big round of applause to Dr. Pratik. there.
Thank you very much. Thank you.
So from here, we'll now carry forward to the next part. So next session is about newer insulins. And I'll introduce the speaker because he is actually the one who was one of our first fellows who passed out from here, Dr. Chetan Dave. Dr. Chetan joined our session, our program as a pediatric endocrine fellow along with Neha as the first batch. So that was 2017 and we are really proud. He had done such wonderful accomplishments. He had training in UK, training in US in diabetes, with special focus area on diabetes and hypoglycemia, and now he is working as a pediatric endocrinologist and he will be talking about newer insulin. So I like to have the inputs of Dr. A.C. Agarwal and Dr. Bhaskar about how newer insulins are changing the way we are managing diabetes on that regard.
Thank you, Dr. Anurag. Good evening, friends. And I am neither a pediatrician nor an endocrinologist. I am a senior physician. And thank you, Dr. Anurag, for making me a part of this session. See, insulins for almost more than 100 years are with us. And with the advent of closed loop insulin pumps, hybrid pumps, now we are more bothered about the type of insulin which can be given through pumps. So there is a constant change and constant upgrading in the type of insulin, from bovine insulin to human insulin and to analogs and now piggybacking short-acting insulin or other insulin WDEC. So we have to see which are the insulins which we can give, what are the advantages and disadvantages, and how we can further proceed in this line for newer insulins to come with modification of their amino acid sequences so that we have better insulins. So I think Dr. Chetan is here to highlight about this aspect. Thank you, Dr.
So thank you. Hello, good evening all. Kanpur is a second home to me, and I would like to thank Dr. Anurag for making Kanpur second home to me. I was waiting that when sir will call me, because after completing my fellowship, I was in UK and US. And then due to COVID, I had to go back to my home. And so after fellowship, this is the first time I'm coming to Kanpur. And it is always a special feeling. So thank you, Dr. Anurag. And along with that, I would like to thank these two fellows. Can anybody tell who are these? Yes, Belting and West, who discovered insulin in 1921. So it is approximately 100 years back. So before that, all the patients were left in a ward called death ward, and they were allowed to die. So after that, this is the dog over which they tried the insulin, and now we have battery of insulins which are making life of a diabetes possible. So I think we have many from the institutes or government institutes. What insulins are you using? I mean, Lispro, Aspart, Glargine. Yeah, Epitra. Any other? Apart from this, anybody using mixed insulin? You are using. Okay, fine. Then any other insulin or brand name or any other thing you remember? Okay, fine. So we'll be discussing a few more newer insulins that has been approved and some are under trial for approval. So we know that insulin is a peptide hormone which is produced from the beta cells of the pancreas, which is situated below the stomach. And these beta cells has a specific sensor called glucokinase. And even blood glucose reaches the blood, there is a pathway called incretin pathway. So this pathway stimulates the pancreas to release insulin even before glucose reaches to the blood. So insulin is present there in the blood before even glucose reaches to the blood. That's why this insulin acts rapidly. Whenever we eat something, insulin is already there. And after that, by measuring glucose, again more insulin is released. So insulin is a complex hormone which has been preformed and stored and synthesized even before the food comes. That's why this insulin is quick. And this is the reason why our blood glucose is so tightly controlled, because blood glucose is measured minute to minute, and according to that, insulin is released so fast. And this is the reason why we need more and more insulin, because right now whatever we have available, they are not that either fast, They are not the long acting. So this is the normal insulin secretion in our body. So we know that we all eat meals and all meals have carbohydrates. Even if we eat green vegetables, they have some carbohydrate. So we need insulin at each meal, right? But apart from them, whenever we sleep for 8 to 10 hours, we have hepatic glycogenolysis. So liver will start producing glucose, and that's why we don't experience hypoglycemia during night. The normal healthy people I'm talking about. So even to suppress this hepatic glycogenolysis, we need insulin. So all 24 hours, we will have some insulin in our blood and in our body. And this is all we should replicate whenever we treat the patient of type 1 diabetes. Why? Because they don't produce insulin at all. So we need to give them insulin to suppress this hepatic glycogenolysis as well as to cover their needs. And that's why basal bolus regimen is the standard care. When I was in PG, we were using mixed start 30-70, 2/3, 1/3, right? That was the standard practice. But nowadays, when some of the stalwarts of the pediatric endocrinology say that to use a mixed start or mixed insulin in a patient, in a kid with type 1 diabetes is a crime. Why? Because if you use mixed start, the child has to eat according to the insulin because there will be fixed amount of insulin which will be there. So if you use basal bolus, the child has to take insulin according to the food. So we know that the child might eat large meal, they don't even eat at all. So basal bolus is the thing. We give fixed basal at fixed time of the day that will act probably for 24 to 26 hours. And we give bolus whenever child wants to eat. So this is the reason why basal bolus is the treatment of choice. And what do we all have till now? Regular insulin. Of course, we know that this is the human origin, genetically bioengineered insulin, which has got chemical composition same as our normal insulin produced by the pancreas. So this can be given as IV as well. But the regular insulin has limitations. Right? We all know that regular insulin start acting by 30 minutes after injection. It will have its peak at around 3 years of injection, and it will there in our body for next 6 to 7 hours. Next, so to overcome this benefits, we develop rapid acting analogs, right? So what do rapid acting analogs? All lispro, aspart, and glulisine all are called as rapid acting analogs. They have some change in their composition so that they are working rapidly. So their onset of action came from 30 minutes to say 15-20 minutes, and they will have peak at 1 hour. Exactly at that time, the glucose from our food is highest, and they will excrete by 4 to 5 hours of the day. So rapid acting analogs definitely is an upgrade from the regular insulin as far as the bolus is concerned. But now what about the basal level? So for basal we have NPH. It is called detimir or NPH. They can act for 12 hours, but still they have a peak at 6 hours. So after giving NPH, if at all you are giving 2 NPH, that is available in many government institutes, you should ask the child to eat something at 6 hours of that NPH. Otherwise, child will have hypoglycemia. So this is again a limitation of NPH. So again an upgrade came, say in 1990s in form of glargine. So what is glargine? It is a long-acting insulin which nearly mimics the basal insulin secretion. It starts acting by 1 to 2 hours of the injection, and its effect will last for next 20 to 24 hours. It is got very low peak, so there are very less chances of hypoglycemia, plus a single day injection is suffice. So this is all what we have till today, but still why we need further improvement? What are the drawbacks? Can anybody tell what are the drawbacks of all that hypoglycemia risks? Okay, as I discussed earlier, with NPH as well as regular insulin, there is a hypoglycemia risk. If the child is not eaten properly after giving regular insulin, child might experience hypoglycemia at 4 to 5 hours of the injection. Same as with NPH at 6 to 7 hours of the injection. Lag in the onset of action with regular as well as rapid acting analogs. So these all need few minutes to get into the blood and have their actions. So definitely there is a lag in action, and while because we know that our childs are kind of a cranky, mujhe kuch do, right? So there are many instances in which child is not ready to hold for say 20-30 minutes after giving the injection, child will be demanding that I need food, I need food. So definitely we need improvement as far as the onset of the action is concerned. Then duration of action. NPH we have to give 2 shots. Now if I talk about glargine, if the requirement is in high dose, say maybe somebody is requiring glargine at 30 or 40 units a day, then they have experiencing their action to be finished at around 20 to 22 hours of injections. So they might have elevated glucose after 20 hours of injection. So in older child or adolescent, this may need 2 doses of glargine as well. We have many patients when we require 2 doses of glargine. So again, we need a further long-acting insulin. Post-meal shot is not possible with any of our available insulin. Many times it happens that we don't know how the child will eat, how much he will eat. So if there is any insulin which we can give soon after food, that will be definitely beneficial for the kids as well as the parents, because otherwise mother is fearing that if I give 3 units of regular insulin and the child is not eating, what will I do? Many a times what kids do that they want to eat sugary things. So after his or her mother gives the shot, they will deny that no, I will not eat the food, because they know that now my sugar will be down, my mother will be anxious and she will give me chocolate. I have 3 to 4 patients. This is a real experience. So again, if at all any insulin can be given post meal, that will be again the benefit. And daytime variability. So glargine is a long acting. There has been a notification of the fluctuation in the concentration during that 20 hours as well. So these all are problems with the regular or rapid acting or a long acting insulin. So what do we need? We need a faster acting insulin, even faster than rapid acting analogs. We need a longer acting insulin, even longer than glargine, and we need a stable concentration. So if we can change the insulin molecule so that it become faster or it become longer, then definitely we will have good timing range. So nowadays the concept is timing range as compared to the HbA1c. Ideally 50 to 60% of the time child should be in the TIR, that is maybe 80 to 140, 80 to 160. So that the long-term complications, either macro or microvascular, can be prevented. So nowadays ultra rapid acting analogs have been developed, and first is PIAS, that is fast aspart. Many of you have heard that PIAS is officially now approved by the International Society for Pediatric and Adolescent Diabetes. So what they have done, they have added arginine and niacin to the normal aspart, so that it gets quickly into the blood and its onset of action is very faster even the normal aspart. So we can see that it starts acting within 5 to 10 minutes of injection. So again, this is good for the kid who demands his food soon after the shot. So again, it has got action onset of action at 0.1, that is 6 minutes, so 6 to 12 minutes. It has peak action at 1 to 3, and again it has the same duration of action as compared to the rapid acting analogs. So it is very beneficial as compared to our normal rapid acting analogs. And also, if I want to talk about the cost of PIAS is even lesser than some of the rapid acting analogs. So definitely this is way better as compared to the normal rapid acting analogs, and it has been approved by the FDA for use about 2 years of age. So PIAS is definitely worth using it nowadays, and there is very low chance of hypoglycemia as far as the PIAS is concerned. Second is Lispro. We have ultra rapid acting Lispro, which is called URLI. It has been started using in Belgium and all, and there are few adult studies related to the ultra rapid acting Lispro, and they have added these 2 molecules of citrate and treprostinil, so that the Lispro has been made as rapid acting. So again, this is a comparison with the normal Lispro. It starts action early, 5 to 10 minutes. It has got better sustained peak, and again it has got action up to 5 to 6 hours. So definitely it is better than Lispro, but still it is under trial. So it has been not approved in the kids. But many studies, and this is from the Japan, they have found that it has got accelerated insulin absorption with a reduction and in late exposure. So again, this is beneficial because it acts fast and it gets excreted quickly, so that there are low hypoglycemia as compared to the normal Lispro. But again, this is not approved in the kids, but it will be soon available once the approval is there. Now coming to the long acting. So long acting, It started from 1946. The NPH was first discovered in 1946. Then glargine came very late in 1992. But again, they felt that glargine is not enough. So they have started detimir, which is there in 1996. But again, detimir is having peak, and also you need 2 doses of detimir. That is same as NPH, more or less. So then research were going on by changing the few amino acids in the insulin molecule, and then they come out with the diglutec. That is in 2010. So we'll be talking about diglutec and glargine 300 because these two are the long-acting which has been approved and which can be used in pediatric population as well. So diglutec we call it ultra long-acting insulin. So at the position of B29, it is conjugated to hexadeconic acid with lysine. So what does it do? It will form hexamers below the skin. So that's why it will be very slowly released in the blood, and that's why the half-life is more than 20 hours. So most important is the action, longer action. And this is a comparison. This is our normal glargine, which has got some peaks, but this has got sustained concentration all over 24 hours. So even if mother has a delay of giving long-acting insulin by 2-3 hours, we don't have to worry if we using diglutec. So diglutec is available as Cresiba in the brand name, and these are the official recommendations. It has been officially approved by APES and FDA. It is virtually peakless insulin. I think it is not visible. Single daily dose is enough even in bigger kids or those kids who are weighing above 60 kg, and it has been approved above 1 year of age by FDA as well. So again, if we compare glargine with diglutec, the cost is 3 times. So definitely cost is a major factor as far as the endocrinologist practice is concerned, because we are prevented by this cost issue. But still, those who are requiring high doses, those who have Lentus dose, which is a glargine dose, which is not enough, then definitely diglutec is the insulin because it is far better pharmacokinetics as compared to glargine. Second is glargine 300. Now, what is this? This is the same glargine but concentrated glargine. So this is glargine 300 means 1 ml of insulin contains 300 units of glargine, while that normal glargine is 1 ml contains 100 units. So this is 3 times concentrated. So just by making concentrated, they were able to delay the absorption. And again, this is the same as diglutec as far as the pharmacokinetics is concerned. So again, as compared to our normal glargine, it is virtually peakless. It can act about 24 hours as well. And this is also approved. So it starts by action early by half to 1.5 hours. It has got minimal peak and it has got half-life of more than 42 hours. So if at all there is a delay for say 3 to 4 hours, if you are using glargine 300, it is fine. So again, this is an ultra long acting with peakless effect, minimal hypoglycemia because there is no peak, and once daily dose is fine. But again, cost is the issue. As compared to the normal glargine, again it is 2.5 times, 2.5 to maybe 3 times costly. But still, this all insulin will be available in the low price in the upcoming years. And looking at to the hypoglycemia management and low hypoglycemia, if we can prevent just one admission of hypoglycemia, all costs can be recovered. So definitely, it is worth trying in those patients who can afford the either diglutec or glargine 300. But it is approved above 6 years of age by the APES and FDA. And this is the study where they compared glargine 100 to 300 as far as the nocturnal hypoglycemia is concerned, and they have found that the event of nocturnal hypoglycemia, which we fear the most as an endocrinologist, was very low, 4 events per participant year as compared to 9 of. So it almost reduced twice as the nocturnal hypoglycemia is concerned. So again, this is a comparison because glargine 300 came later than the diglutec. They have again, this is an in-range study, which is a first randomized controlled trial. They have compared directly glargine 300 with the diglutec, and they have found that this glargine 300 was non-inferior. Non-inferior means it was similar in reducing the HbA1c from 8.5 to 7.5, and nocturnal hypoglycemia and glucose variability all were have similar effect. So these both ultra long acting insulins are way better than our glargine as far as the hypoglycemia is concerned, as far as the stable concentration of the insulin throughout the 24 hours is concerned, and glucose variability is concerned. So newer insulins provide flexibility, because if you use glargine, you have to tell parents that this should be given at the exact time. If you delay, then there will be a lag phase of insulin free in the blood. They have more time in range, of course, less glucose variability. They have less chance of hypoglycemia, which we fear most, but cost to be considered, because these all are right now costlier, say maybe 1.5 to 2 times as compared to our normal insulin. But still, these are the way forward as far as the newer generation insulin is concerned. So with this, I would like to end my talk, and I would like to thank you all again for patient listening. Thank you.
I think it was very nicely summarized by Chetan that we are talking about longer than longer and shorter than shorter. That's the aim. So, Dr. Agrawal, what is your thoughts about the question?
Yes, it's really enlightening to know about the various insulins which are available and making the insulin suit to the needs of the patient. That is more important for the lifestyle, especially in children, rather than your insulin and then the child is advised accordingly. So this is very important to prevent hypoglycemia and quality of life. That is a variable which is very important, especially in pediatric type 1 diabetics, because quality of life has to be there rather than compromising with this, and that is possible with the newer insulins if used with wisdom like Dr. Chetan's. Thank you.
Dr. Ganguly?
Congratulating you on a very eloquent talk. You have beautifully summed up the advantages of the analogs and the next gen insulins. You're right. As far as efficacy is concerned, probably there's nothing to do between the human insulins and the analogs. But yes, when it comes to the safety parameter, hypoglycemia, and the flexibility, there's nothing to beat it. And very correctly put, cost is the value. That's it.
Dr. Chetan asked, is there any effect of inhaled insulin?
Sorry?
Inhaled.
Yeah, right now at the Cleveland Center and two centers in USA, there is a trial going on for the pediatric inhaled insulin. When I was there, that trial was started by Dr. Jamie Good. They are using in adults. The adult approval is there, so they are using as a bolus insulin in the adults. But still, pediatric trials and pediatric results are awaited. It is called Africa, and maybe soon we will have inhaled insulin available within the next 12 to 18 months. But again, still it is under trial.
Yeah. The problem with dose is high and it comes in a multiple quantums of dose. You can't give 0.5, 1, you have to give 4 unit, 8 unit, 12 unit. So it's not going to be as easy in terms of that. So probably the way forward is more towards the pump way rather than the inhaled way. That will be the way forward, because inhaled insulin came and was already lost once. We all know what happened to Vertebral. And now Africa also, what is happening is that we are giving 4 unit, 8 unit, 12 unit. So how many children will require 12 unit equivalent, and then reliability, delivery, all those issues will be there. So I will be skeptical. I don't think it will be the only way inhaled insulin has been used is prevention of diabetes. And there also it has not been found to be successful in that. So I think thanks Chetan for this wonderful session. Dr. Alka.
We can use it to Rizopac and make that response. So is it physically?
See, Rizopac contains what? Diglutide and the short acting, right? So we need to fix those combinations. In children, what we want that we should be given 3 doses, because we want to decide the dose by looking to the pre-meal sugar level. So that is not possible with the Rizopac. So if at all you want to increase your short acting and you increase the Rizopac dose, what will happen? The dose of long acting will also increase. So it is very well suited in adults, but still we are not using any fixed drug mixed insulin or even Rizopac as well. So maybe in older children, say 17, 18 years, you can have their fixed breakfast or then to reduce just one shot we can use. But Rhizotec I would definitely not use twice a day, morning and evening, and the dinner time as part is himself. Definitely not.
So we are talking about more flexibility. So pre-mixed insulin is definitely we do not encourage definitely because the flexibility goes. And even if you give an extra dose, then what is the point? So best is to give a basal separate, bolus separate. That is I think the baseline as far as pediatric adolescent diabetes is concerned. Thanks Chetan for the wonderful session. I'll now request the next speaker, Dr. Subrato. And Dr. Subrato has also delivered two wonderful high quality presentations on very interesting cases today. So we know, and his delivery style is unique. And so I request Dr. Subrato to now, he is a pediatric endocrinologist known to everybody. He doesn't need any introduction. And he will be talking about the topic of time in range. So before we start, I request Dr. Ganguly and Dr. Agrawal to kindly say their words about what they think about time in range. And then we'll go forward. Dr. Subrato will start off with the presentation from there.
Thank you, Dr. Vajpayee. And as we know that the monitoring of diabetes, blood sugar levels, plasma glucose levels is very important. And from self-monitoring of blood glucose to CGMS to AGP, what is important? Something like time in range is because earlier we used to see that the patients who have controlled fasting, controlled BP, and controlled HbA1c, but the incidence of the cardiovascular mortality and other complications did not decrease. So they found that it is time in range which is very important, and normally our blood sugars they appear normal, but because of the variability, the time in range has come as a very important parameter. So the role of the ambulatory glucose profile or CGMS, how they help in the management of the patient. We have Dr. Subrato to tell us about it, and we'll be happy to know your views. Thank you.
Thank you. Before I start, just one observation. The overwhelming appreciation from your students. What struck me is that for 15 years, we were giving random talks to different segments, pediatricians, general physicians, and, I think what the paradigm shift that Anurag did was he reached out to people who are interested. And that is why this room is full of people who are eager to learn, eager to excel. And I think the reason I'm making this comment, you have a major responsibility to disseminate this knowledge, because most of you are in general pediatrics with special interest. Some like Chetan, they're Neha, they've moved out and they're doing their own individual things, who are the earliest graduates from this program. So you have a big responsibility to not only transmit this knowledge, but also to transmit the enthusiasm and get more people. And that's the only way in the next 10 years we'll have enough pediatric endocrinologists to serve the country. Maybe it may take longer. But yes, this ivory tower, kind of approach, which a lot of us did in the early years, has clearly not worked. So I think I wanted to, inform you that with, there's an old saying, with great power comes great responsibility. And you have the power of knowledge now. Okay. The other thing I wanted to say is, have you seen professional live show orchestra, and you have seen karaoke also. So what happens in a karaoke is you have a fixed beat and the singer has to sing with that beat. Whereas in a live orchestra, the singer can sing whatever the orchestra has to follow. So basal bolus is the orchestra. It revolves around the food, it revolves around the sugar. Many parents will say, "Aaj thoda breakfast kam khana hai, kyunki dinner mein dawat hai." No problem. Eat less for breakfast. Take less insulin, because the insulin will basically revolve around the food. So anyway, I'm actually going to take this opportunity to to talk to you a little bit about the history. I'm sure all of you are aware, just a refresher, because as we go on to newer technologies, the newer, path-breaking information, sometimes it is good to revert back to history and see how all this care evolved. This is a favorite saying from Bertrand Russell, and so this is in 2019. We had a wonderful program. Some of you may have been there, and you know what? This was a way to get the mantra of pediatric endocrinology across the East. Now, I'm sure all of you know, but I just want to reiterate that the earliest records of diabetes mellitus was in 1500 BC in the Ebers Papyrus, and the Egyptian physician described a disease associated with the passage of much urine. In 1st century AD, the word diabetes, which means Greek, is siphon, and Aretius noted that patients with diabetes had a disease that seemed to result in a siphoning off the structural components of the body into urine, a melting down of the flesh and limbs into urine. And only in 1674 AD, Thomas Willis, a physician, compares the sweetness of diabetes-associated urine to honey, and mellitus in Latin means sweetened with honey. Anyway, this is the timeline. As Dr. Chetan very elegantly talked about insulins, the origin was in 1920, exactly 100 years ago, and it was, discovered, and Marjorie the dog got better, and that was when the modern era of insulin started. But it lingered on for a long time till the DCCT study came around in 1993, and it was published in NEJ, and over the same time I was in the United States during my fellowship in Cincinnati. And HbA1c was hailed as the gold standard. And what they showed, the worse is the HbA1c, worse is the microangiopathic complications. And the UKpedia study in 1998 on type 2s also basically mirrored the same thing. The worse the control, the worse the micro and macro angiopathic complications. So these are some objective numbers. In DCCT study, when they found they lowered from 9 to 7%, the retinopathy decreased by 63%, nephropathy by 54%, neuropathy by 60%, and macrovascular disease by 41%. There's another study, the Kuomoto study, which happened in Japan, which also mirrored the same findings. So these are the diagnostic criteria. HbA1c added the list in 2020 by the American Diabetic Association, equal to and more than 6.5, but it should be a certified laboratory. And that's why that session on analytics earlier today was so brilliant, because labs vary, techniques vary, and sometimes our interpretation should be cautious. But now the question is HbA1c still the gold standard? Now, are all HbA1c values created equal? With this rock and roll, A1c is 8%. But you see, this blood sugar profile is also 8%. So an average of the last 3 months blood sugar, which gives you 8%, may be erroneously reassuring you. Of course, the gold standard now is 7%, which you all know. So A1c does not tell the whole story. A1c does not track glycemic excursion. 60% of lows may not be revealed by SMBG alone. CGM identifies 4 times more serious glucose excursion than SMBG. And this is a very interesting cartoon. If I stand with 1 foot in a bucket of ice water and 1 foot in a bucket of boiling water, on average, I'm comfortable. So this is HbA1c, I'm sorry to say. So anyway, there are a lot of limitations. I am not going to, for interests of time, I'm not going to go into the minutiae. You can take a pick of that, but if you're aware and know, then we'll move on. So then CGMS is the game changer. Why? Because it is the movie. It shows the entire movie delivering information in between finger sticks. So you see this, It records glucose readings every 10 seconds and displays them every 5 minutes. And now, as you know, there are different kinds of CGM. We have now the Abbott Libre, which has come upon us in the last couple of years, where real time you can measure, and it essentially, you can record it. The Libre Pro, there was a lag of 15 minutes. With the Libre, they say it's real time. And with the reader, you can keep looking if you want to. Now look at this. Here, these are all, these are all, if you see the dots, those dots are SMBG numbers. But you see how many excursions are there above and below that. Only the CGMS picks it. It provides visibility into the overnight period. But CGM is not only novel, but it can improve the lives of patients. So was the AACE statement in 2010. The advanced technology and treatment for diabetes basically showed that using CGM, you increase time in range. And the SPAT recommendation for patient selection, patients who are doing frequent blood glucose testing, patients who have severe hypoglycemic episodes, hypoglycemia unawareness, nocturnal hypoglycemia, wide glucose excursion regardless of HbA1c, and patients with T1D and HbA1c levels below 7%, because you may be worried they are having hypoglycemia. And one other indication which is not written in these is that you have, a lot of you would have encountered, A1C, 10, SMBG, all numbers between 180 to 130, and you do a CGMS and you find that the sugars are all 400. So what's going on? The A1C is clearly real. So even the SMBG you cannot, so then you go and see this patient has been squeezing the fingers such that a lot of capillary fluid comes out, and those sugars are SMBG or CG is spuriously low. So that is one indication. The other indication is, so that is you're getting normal values on the glucose diary, but HbA1c is high. Yahan to CGM banta hai. And the only problem with Libre is expensive. So if the Abbott people are here, we should try and see how we can get the cost down. So anyway, the gold standard now is 7%. And except for those children who have hypoglycemia, unawareness, are challenged, etc., don't have access to local care, there we can lower the A1C to 7.5%. Now, TIR is the emerging metric. So it is 70 to 180. That is the TIR. 70 to 180 is time in range. Less than 70 is level 1 hypoglycemia. Less than 54 is level 2 hypoglycemia. More than 180 is level 1 hyperglycemia, and level 2 is more than 250. And DKA, of course, is the last step. And similarly, in hypoglycemia, somebody having severe hypoglycemia is level 3. So this is a, it's a very interesting concept of time in range and time out of range. The more you go away from this, and that green octagon is basically the time in range. Anything outside that is out of range. And look at this, a real ambulatory glucose profile of a given patient, and you see how skewed this is. Time in range is only 47%. And high, that is level 1 hyperglycemia, 23%, and very high, 20%. This is not what you want. So the differences we have spoken about, and I'm not going to necessarily, it is obvious that this CGM is a real-time thing. You are watching it, and with this Libre now, or even the Medtronic, sensor, if you are linked to one of their state-of-the-art pumps, you can see this real time. So there is no doubt that time in range is superior. Now, it is interesting to know the relationship between TIR and A1C in type 1 diabetes. So if you want an A1C to be 7%, which is the goal, you 70% of the time your TIR, which is from 70 to 180, should be in range. Now, this is very interesting that if you made the time in range 70 to 140, then, you know, if we're 70% in there, then 6% would be the A1C. In any case, now, conventionally, across the world, especially with the ATTD group, it is concerned time in range is 70 to 180, 70 to 180, which will give you an A1C of 7%. And for every absolute 10% change in percentage TIR, 0.8% change in A1C. And interesting, in the DCCT study in 1993 publication in NEJM, they were smart enough to have conceptualized a form of TIR. And what they did actually was they did 7-point glucose profile for 1 week every 3 months on those patients. And they found the better the control. So they had 7 points, and that constituted their, you know, a modern day CGM, if you will. And they found that those with the best time in range had the lowest angiopathic complication, microangiopathy. So, you know, this is so illustrative that if you have 50% your time in range is 50%, then the chances of microangiopathic complication is lowered to 3%, 2%. And that is the power of the time in range. And look at this other panel. When time in range is less than 10%, retinopathy is 58%. And here, frequency of microalbuminuria is 27%. And when it is 70%, the results are even better. Now, very quickly, I want to shift to another important aspect. We all grew up looking at hypoglycemia as a major problem in type 1 diabetics. But over the last 4 or 5 years, there is, ever since they have been doing the time in ranges, the CGMSs, and they found that cognition and type 1 diabetes in children and adults, exposure to hyperglycemia, hypoglycemia, and diabetic ketoacidosis, what they found is that there is a lower cognitive performance in children who have poor metabolic control. And what was interesting, these are more sophisticated studies which showed that the alteration in white matter structure in children with type 1 diabetes, they found there was no significant difference in white matter structure between children with hypoglycemia in type 1 diabetics. And this is a little advanced, the fractional anisotropy, the FA by tensor imaging. These are basically serial MRIs. And you have fractional anisotropy and the concept called axial diffusivity. So the worse the sugar control, the worse the fractional anisotropy. The worse the sugar control, more the axial diffusivity. And what happens is, when you have increasing axial diffusibility and decreasing fractional anisotropy, you will find that there is a decrease both in the performance and full-scale IQ. And persistence of abnormalities in white matter in children with type 1 diabetes. And they found more hyperglycemia, worse cognition. And conclusion of a single episode of moderate severe decay in young children at diagnosis is associated with lower cognitive scores and altered brain growth. I want to stop here by saying that when I was in training, we didn't want hypoglycemia. We didn't care about 250, 300 blood sugars. And when those parents say their head buzzes when the sugar goes over 300, we used to think, it's probably a figment of the child's imagination, how ignorant we were. But this world has changed to this new paradigm only in the last decade. And let me tell you, there's one message I want to leave with you, especially these young children. Don't just concentrate on hypoglycemia, which is bad. Persistent hypoglycemia can cause you parieto-occipital damage. We're all aware of that, especially in the small children with other causes of hypoglycemia, refractory hypoglycemia. But do not ignore hyperglycemia. So this is the most important slide. Any hyperglycemia, cognitive impairment. So low is bad, high is worse. So what is the TIR target? So they had lots of meetings and they're continuously having meetings. They're especially the ATTD group. And what they have said, this is a picture you can take if you don't have. And it says that time in range should be 70%, level 1 hyperglycemia 25% acceptable, and 5% when is level 2. And hypoglycemia is level 1 4% and level 2 less than 1%. So the mantra is, the better the time in range, better is the control, and you can keep in a narrow band so there's no hypo or hyperglycemia, and that is best for the cognition of the child. So technology has helped, and in fact, as you're all aware, the 780G is now among us, which essentially causes autobolus corrections. It alters the basal, and it is now in the market. And I'm sure the Medtronic people there, because they are the pioneers, will have something to say about it. But the important thing is, the only breakthrough going forward is not stem cell transplant. It's still in the infancy. It's not giving the beta cell transplant or pancreatic transplant. The reason is they've all been proven wrong, in the sense they all fizzle out. So you're left with only the super sophisticated pumps, which will be the artificial pancreas for tomorrow. So summary messages: CGMS is now a globally recommended tool. HbA1c has its pitfalls. We still have to work with it. It gives us a lot of cumulative information. TIR, or time in range, the new paradigm in type 1 DM management. 70% CBS between 70 to 180%, which equals to A1C of 7%. Time out of range is associated with neurocognitive impairment. Hyperglycemia causes worse white matter damage and cognitive impairment, so beware. Maintaining glycemic excursions within time in range will prevent both microangiopathic and neurocognitive complications. This is a picture taken a few years ago with my little type 1 diabetics on World Diabetes Day. Yeah, that's one thing if you guys are not doing in your center, World Diabetes Day. You have to observe, you have to, what do they call that? You have to thrust yourself into the system where you are. Start with the World Diabetes Day. Thank you, Anurag, for the opportunity, and thank you, the chair, for the permission to speak.
Thanks, Dada, for the wonderful talk. First questions from the chair or comments?
Thank you, Dr. We have seen a paradigm shift in the glucose control paradigms from the triad of fasting, postprandial, and HbA1c. We have moved on to the pentad, where you add on minimal glucose variability and minimal hypoglycemia. You get a CGM done, you get all the information in a 14-day meeting. So you have achieved all the targets. So to my mind, also CGM, particularly in type 1 diabetes, is one of the most important things, and they should be real-time CGM is the right thing to do. Thank you.
So I think this was a very, very clear message that you gave. The time above range is also something you have to worry about. It's not just hyper is also important. Thanks a lot, Dada.
Thank you. Thank you.
Discussion. So the next part that we will be moving on now from here is about diabetes advancement. So I'll be focusing about what's new in terms of diabetes. So Dr. Agrawal, what do you expect and what do you want in terms of if you have a child with diabetes, suppose you represent him, what are the things you would like to want from their side?
Thank you, Dr. Anurag. What we want is that the child should grow normally. That is very important without facing any complications like hypoglycemia or hyperglycemia. And what Dr. Subrata just told us about the neurocognitive disorders when the child is having hyperglycemia. So it is not only hypoglycemia, but we want the child to grow normally, to come out and to have a good quality of life and live a healthy life. So that is very important with the minimum hassles. If he is able to grow normally with type 1 diabetes, he can live a better quality of life. I think that is very important for the child as well as the family.
So let's see what is in store in future and what we can afford and what can we do now and in future. So type 1 diabetes, everybody has talked, is a never-ending saga. A lot of developments happening, but every time ye dil mange more, every time we want more new developments to happen in that perspective. So what really we want? We want a system which is actually able to assess and detect hypoglycemia or hyperglycemia, react accordingly. When required, it will be able to secrete insulin. When required, stop insulin. When required, give glucagon. So we are sensing as well as response both for hypo as well as hyperglycemia. First of all, we want to prevent diabetes. We preserve the beta cell function and then finally restore the beta cell function. These are also the goal which we want to do in that setting. Well, what are the problems? You can never have a portal delivery of insulin because we are having the pumps in the subcutaneous. It goes in the blood and then in the liver. So portal delivery is impossible. That is something, a big challenge which is there. We want a seamless sensing. There is often a lag between by the time your capillary glucose matches with your actual blood glucose. So there's a lag there. Then your pump has a lag. So if you have so much lag, there will always be confusion as to achieve a good control. So we'll see what has been achieved and what needs to be done in that direction. So I'll start off with this case. There are twins, Sita and Geeta. Sita at 7 years is diagnosed as diabetes with DK. Now parents are very concerned what will happen to a younger girl on follow-up. So what can we do? Can we predict it in a manner? And if we can predict it, can we prevent it? So now we have done antibody status and studies have shown that we can predict very well whether this child will go on in developing diabetes. Now already multiple antibodies are positive. Insulin is low. There is a 5-year risk is 90%. Now what can we do to prevent diabetes? Because if we can't prevent, what is the point in predicting? So for prevention, there have been multiple studies which have been done. For primary prevention, starting from gluten-free diet to hydrolyzed formula to DHA, all of them have been found to be unsuccessful. For secondary prevention, once diabetes has maybe started, talk about insulin for sensitization, nicotinamide, all have been found to be unsuccessful. So right now we can predict but not prevent diabetes. So don't worry about 4% chance in siblings. If it is there, let it, we will handle it and manage accordingly. On 2 months follow-up, her dose is much less. So she's now on a honeymoon phase. There is a preserved C-peptide. Now the question is, can we prolong this honeymoon phase? If we are able to prolong the honeymoon phase, that is also good. Quality of life will be better. Hypoglycemia will be less. So there are trials specifically with anti-CD3 which have been found to be effective. But just to prolong for a few months, would you like to give us such an agent which is an anti-CD3? I think that's not something anybody will do. So at the moment, again, prolongation of honeymoon phase is also not going to work. So this is something which is not working, and all these studies are also not yielding any results. So the next question is, she is now 1 year on follow-up. She does not want to go for insulin. What are the options? So we are talking about Afrezza. So Afrezza basically is an inhaled insulin. The problem with that is that there are a lot of issues about availability, bioavailability, and the quantum doses are huge. So you can't say 4 unit, 8 unit. What about 5 unit, 6 unit? You can't give it. And it is only going to work as a bolus insulin. It is not going to work as a basal insulin. So I don't see a future of inhaled insulin at the moment. There are other talks about oral insulin, that also is not working. Biocon has been working on oral insulin for a long time, nothing yet has come. So now the question is, can we use non-insulin drug options in the management of type 1 diabetes? So the option which can be used, metformin, yes, insulin is not there, you're giving outside, you can sensitize the child with that. Amylin is a drug which is approved in adults, it will delay the gastric emptying. What about the GLP-1? Sulfonylurea, of course, not going to work because you don't have any insulin. What about GLP-1 receptor analog? Definitely a potential, especially because it is working on other pathways. It is working on the brain to cause satiety. It is working on the stomach to delay the gastric emptying. So there is a chance you can use it. DPP-4 inhibitors, no, because you don't have any insulin. Glucosidase inhibitors, very mild drug. I wouldn't be thinking much about that. SGLT2 inhibitors, lot of potential. This is an insulin independent way. You are increasing urinary excretion. So even if you don't have insulin, it will work. But the problem is it will lower your glucose, but will not give you insulin. So you will remain insulopenic, and what quote unquote euglycemic decay may happen in this condition. So you have to be very, very cautious with the use of these drugs. So frankly speaking, metformin in obese, NAFLD, PCOS, that is one situation you can think of. Probably similar situation, GLP-1 receptor analog, plus minus, you need more evidence. And SGLT2 inhibitor, very, very cautiously, are things which you can consider. So what about the other options which have been used till now in that regard? So there is a trial on metformin. Again, obese individuals with NAFLD and PCOD, only 3 indications. Don't give metformin in a lean individual. That will cause a huge problem, and that too adolescent, 14, 15 years, not before 12 years, definitely. We will not give. GLP-1 agonists, lot of work is going on, and with oral agents coming in, hopefully new research will come up. It will cause 3 to 5 kg weight loss, which is good. So if you have an obese individual, it is good. Otherwise, probably you will reduce the dose of insulin, but not too much benefit in HbA1c. What about sotagliflozin? Now, sotagliflozin is unique. It is a dual SGLT2 and SGLT1 inhibitor. So this can be an agent which can be helpful, but again, the risk of euglycemic decay is there. So if you are not giving enough insulin, the child is at risk of decay. So first, ensure insulin, then give this, and then maybe 10-15% reduction in insulin you may expect. Don't expect it as a replacement. So all these agents are sidekicks. They are not really the primary agent. They are not going to stop insulin, definitely in that regards. Now, what options we have are insulin pumps. So ISPAD has now said that any age, any child is a good candidate for insulin pump. You don't say, okay, this age has to be there, this child has got this. So at any age it can be used, but very importantly, the family has to be motivated. They would need to know the cost. They should bear the cost. Otherwise, you start and then there's no benefit in that regards. Studies have shown that pump reduce HbA1c, lower hypoglycemia, more time in range, and less decay. So there are benefits, but don't expect dramatic decrease in HbA1c. If the family is not monitoring well, HbA1c may actually go up. So you have to be cautious with the use of pump. Good correction is required. Now we have all been talking about a closed loop journey, and now we have got the 780G, which a lot of you had actually experienced in the morning, which is trying to bring it as close to what we wanted in the first slide. So it is basically what it is doing is that it is actually detecting, then it is analyzing, based on analyzing it is delivering, it is changing the basal rates, it is changing the way bolus is being given. So in a way it is working like an artificial intelligence closed loop, which is something which is desirable, very good, improves time in range. But again, everything is not perfect, so we have to be a bit cautious in that regard. Very importantly, it is recommended beyond 7 years of age and somebody who is on a reasonable weight dose on that. So this is something for children, something which can be used. Again, cost is an issue and sensor cost is an issue. But otherwise, studies have shown that you will achieve a very good amount of time in range, up to 80%, many studies have shown. It provides autobasal, So it automatically keep on changing the basal insulin based upon how your sugars are. So it's a very good way to go forward, and you can set your target. Best is to set target of around 120 initially, then go back to 100. You will get a good control in that scenario. So this is how auto basal works. Based upon sugars, the basal will go up and down. So this is much better. Lantus, you have given one dose. U300, Degludec, you have given one dose, you can't change. Here, automatically it is changing. So this is something which is good. And there are specific algorithms which will then predict the risk of hypoglycemia and change accordingly. So this is a nice way to go and manage in that, and good time and range can be achieved. But of course, cost, sensor, you have a sensor, you have a pump, and you have to change the sensor, change the pump. So pain and all those issues will also be relevant in that regard. So now if you have a child who wants cure, what do you do in terms of cure? That is a big question. So there are now restorative strategies, two types: pancreatic transplant, out of question. For pancreatic transplant, you will need to give immunosuppression. So only if somebody is going for renal transplant, think of it. Otherwise, this is useless. What about beta cell transplant, islet cell transplant? Again, require immunosuppression. Not a cure, just a prolongation of your honeymoon phase. Not very good. We are looking at stem cell transplant. Again, experimental. A lot of people come, okay, this center does stem cell transplant. So I always tell that whenever anybody discovers a treatment for diabetes, they will get the Nobel Prize next year. So don't go for all these claims. China, India, a lot of places they say stem cells. So this is all a hoax in that scenario, in that regard. Now there have been a lot of work which has been gone in terms of bioprinting, so 3D printing. In terms of, so you may actually go and order beta cells for you in future. You can say, okay, I want so many beta cells, they will be printed and you will get it. Problem is, they will again be damaged because antibodies will kill them. So you want a system in which insulin can go out, oxygen can come in, but antibody doesn't come in. So there are ways people are trying to design encapsulated forms in which you can actually have a porosity which will determine the oxygen, the insulin will go out, but nothing else comes out which may help. So again, work for future. Not much is done in that regard. Lot of work was done about beta trophin, which apparently increases the beta cell mass, but again, it was not found to be proven on subsequent studies. So whenever we talk about diabetes future, we often talk about 2 steps forward and then 4 steps backwards. And I remember very well that my professor in Australia, Professor George Werther, used to say that right from the 70s, people ask, when will cure come in? You always say next 10 years. And since then, every 10 years, we have been saying next 10 years. So this is not an easy disease. Don't expect much cure. So probably what we are looking at, improvement in technology, which will be the way forward rather than a miracle cure, which may happen. Now, the other big issue is about the use of technology and how technology can improve. Now, we all know that patients are living in a different areas and everybody can't afford pumps, they can't afford, they don't even have knowledge. So how do we impart their knowledge of day-to-day practice? That also is important. So we can use different applications which allow remote monitoring, remote education. Patients can say, okay, this is the sugar, what do I do? They can immediately manage on that. And telemedicine has now also opened tools in that regard. We have developed specific tools for the doctors in the form of a mobile application to calculate the doses, correction, and sick day. And we are also coming up with a patient tools in multiple languages so that once they know what is their sugar, how much they want to do. So this will day-to-day help it out. So while we are talking about technology in the form of pumps, in the form of CGMS, in the form of other things, technology can also be used to allow simple things which may be life-saving in that regard. And one of the things which we developed, which has really been proven to be effective, is our DKA tool. So we discussed in the morning that we did studies which showed that protocol deviations are common in DKA and that cause problems of hypoglycemia and other issues because expertise are not available. So we have developed a specific mobile application which allows the personalized management of diabetic ketoacidosis. You have to feed some basic inputs, and based upon those inputs, you will find a validated information about what fluid to give, which duration, how frequently, how to monitor, and this we have shown to be effective in improving quality management of DKA. So technology is a way forward. we have to consider on both the spectrum of India and Bharat. Both of them have different needs and we have to go for both aspects. So while pumps and all those things are there, they will always be used by a minority, a very small minority. We have to think of other people, how we can improve lives with simple technology, and there also technology is going to help us subsequently in that scenario. So I think now we have got so many things we can now predict but not prevent. We can monitor. Dr. Subrata talked about very well. Replacement, again, smart pens are coming up, newer insulins are coming up, closed loop is coming up, non-insulin options are sidekicks which are there. Restoration, islet packaging, I said, but these are all more of science fiction at the moment than the actual ones. And then 3D bioprinting and stem cells. And of course, there is a role of technology which is there. So there are various things which are going to happen over the next 5-10 years, but definitely it's going to be an incremental one. It's going to be 1, 2, 3, not 0 to 1. I don't expect 0 to 1 immediately in diabetes, but there are ways things will improve overall in that perspective. So I'll thank all of you for patient hearing and take any questions and suggestions from the panel, sir.
Thank you, Dr. Anurag, for a very enlightening talk about the future of diabetes. It looks glistening, sparkling future for the type 1 diabetics and even all diabetic patients, especially with the artificial intelligence that we have that will add to their life. Sensor and pumps, as you rightly told, they are expensive, but if they are affordable, then they may really change the outlook for type 1 diabetic patients. So we have a bright future ahead with diabetologists like you and the classes like these and the doctors being produced under your experience and guidance. We have a bright future for diabetic patients.
Thanks a lot, sir. Yeah, Dr. Rishi.
It was a very nice talk, and you at the end covered the pump. In your inaugural lecture, you used a very nice thing. The basic problem in the country is not the poverty. The basic problem is understanding. You can drink every day 180 ml, but they will skip it. They can take one masala and they will skip their fish. So, why I'm giving a statement? Since you talked about pumps, my thing is type 1 diabetes once pump starts. My experience it is almost curable. And with this latest technology, 780 and it is almost curable. So, any type 1 patient that comes across you, my request is at least put forward an idea of thought. Put forward. Whether he or she or the family can purchase or at least put forward. If we are not putting it forward, we have barriers in the mind. Patient will not afford, so why not this or that? At least put forward. Say what is not happening. So one message that I would like to do, because once I'm again the person of old philosophy with this philosophy, understanding hormone. Once we understand, once our patient understand, most likely we will offer more and more. And the good news for you guys is, I think in future we are going to have very cheap pumps. Very cheap pumps. So that is something good that's yeah.
Thank you, Dr. Rishi. And I'll invite now Dr. Rishi to carry forward this talk about, again, a futuristic talk. So we talked about newer insulin, we talked about TIR and CGM monitoring, we talked about type 1. What about adolescent with type 2? We are seeing so many adolescents with type 2. What options? Can we carry forward the GLP-1 and SGLT2 which the adults are using? What is the potential in children? So Dr. Rishi, please, stage is all yours for presentation on this.
Good evening, friends, and thank you, Dr. Anurag, for giving me opportunity. And second thanks to you once again, Dr. Anurag. Dr. Anurag, 1 minute. 1 minute. Second thanks to you also. You fulfilled my last wish of my life, because I was missing in life the teaching that you permitted to do something. I teach all Dr. Anurag's pediatric endocrinology fellows, I make them worse with adult endocrinology. So I try to cover diabetology, algorithms, osteoporosis, reproductive endocrinology, and couple of things. Because in any case, there is huge overlap. Thank you. Go ahead. So I'm going to talk about SGLT2. GLP-1, Dr. Anurag touched it. And what am I going to talk is a basic pathogenesis. Why are these things being used? And then role of these two molecules. Finally, what is role in adolescence? And then at the end, I'll be sharing. So one question I'm asking all of you, are you guys are aware of what are GLP-1 analogs? Say yes or in one line, those who are not aware of GLP-1, raise hands. Not many. SGLT2. So maybe one line I can very briefly tell you. From intestine L cell, there is a hormone known as glucagon-like peptide. This is 30 amino acid molecule, and this is released. And what it does, after having meal, it is released, and it does basically two things. It stimulates beta cells of pancreas to release insulin, so it helps in controlling blood sugar. And on second hand, it suppresses the glucagon. So by suppressing glucagon, there is additional control. So these are two things. But the half-life of this molecule is very short, 4 minutes. And so they are DPP4 inhibitor, diabetes dipeptidase peptide inhibitor. This hormone degrades. So once, that's why we use all DPP4 inhibitors. So if you can stop the degradation, we can increase the level. But what has been seen, if you give this hormone in a bigger volume, the weight reducing properties more, the blood sugar controlling properties more. It also has effect at the level of brain, and so it suppresses the appetite. So this is the basic understanding. So anything you want to know about it, because this is the natural hormone produced from our body, from intestine. So when we give it from exogenously, what happens? So this is what am I going to talk. Sodium glucose transporters, are you aware? All right, so I'll not be talking about this. So SGLT2 is important. And what am I going to talk a bit about? See, if you talk about diabetes control, what we do, what is Dr. Sobeto was talking about the DCCT data. DCCT, are you guys aware? Diabetes control and complication trial. This was the first trial that came in 1993, and this was first trial in diabetes, instructor trial to prove, because prior to that, the understanding was if any complication of diabetes comes, it is progressive. Once nephropathy appears, retinopathy appears, whatever happens, it is progressive. But that was the trial that came for the first time and said, even if complications are there and control is good, it is arrested or it can be reverted back to normal. So this was diabetes control and complications. Why am I talking about this? So from those trials, and there was another trial, BKPD, United Progressive Diabetes Study trial. These two trials, this was on type 2 diabetes. Now you guys see also type 2 diabetes in young. So you are also type 2 people. So the control part came into the picture. So if the control is good, we can do lot many things. So for now, things are still changing. Control means how you control, that is important. And why? Because controlling simply digital control is one thing, or are you offering something else beyond control? That we are going to discuss. So I'll be talking a bit of adult diabetes, the basic pathogenesis, that will give you understanding. So once type 2 diabetes occurs, the faults are at many levels. First, if you look at pancreas, ये किससे चलता है? ये क्लिक करते जाएंगे आप तो आगे चले पॉइंटर अच्छा पॉइंटर ये पॉइंटर से रूट पूरा लगाना पड़ता है पॉइंटर चल रहा है नहीं इधर पॉइंटर हाँ जिसकी मैं विशेष चलती but that's it. If you look at the basic pathogenesis, if you focus at the pancreas, there is a insulin secretion is decreased. There is a bit altered glucagon secretion. So defects at multiple levels. Defects at the level of liver, hepatic glucose output, then defects at the level of brain, appetite regulation, defects are at the level of muscle, defects are at the level of intestine, because all this GLP that I was talking, with passage of time, the GLP level goes down. Sorry. So defects at the level of kidney also. And there are total 8 defects, and now we have enumerated more than it, around 11 defects we have enumerated. So if we can address these defects, are we doing something at the level of insulin? Are we doing something at the level of glucagon? Are we taking care of kidney part? Are we taking care of muscle part? Are we taking care of fat part? So if we attack at those levels, perhaps the management would be better than going merely for a digital control. And once we combine these two molecules, sodium glucose transferase inhibitors and GLP-1 glucagon like receptor analog. So what happens? The advantages are there is a weight reduction. Hypoglycemia is minimal. Essentially, these two molecules with metformin, there is minimal or no hypoglycemia. So what we want, I mean, I'll tell you a very small story. The understanding how much is the normal, how much A1C is target A1C. Can anybody tell for type 2? 7, 6.5. Pediatric practice, we consider young 7.5 up to 8 also the prescribed guidelines. But otherwise, for type 2 and type 2 adults, the understanding I just want to put forward into your mind. Patient with pre-diabetes, diabetes, and diabetes. So from diabetes, if you grab anybody at 7.2, use these molecules, bring it to around 6.5, go further, bring it to 6, go further, bring it to 5.7, 5.2, and maintain it. If you use these molecules, GLP-1 and SGLT2 metformin, the chances are, see, what is the problem? If you try to lower HbA1c, chances of hypoglycemia increases, am I right? But with these two molecules, chances of hypoglycemia is low or minimal. So if you lower it to the lowest possible, to bring blood sugar to diabetes, to pre-diabetes, to non-diabetic range, and maintain in non-diabetic range forever. So that is the beauty of science, beauty of these molecules. So we can address, I mean, if you use, there are a lot of cardiovascular benefits, lot of renal benefits, lot of weight reduction benefits. These two molecules, if you look, the SGLT2 and GLP-1, there is a lot of overlapping common benefits. They have a solid cardioprotection, solid CV death. And if you look at SGLT2, only the heart failure part and the hardcore renal part, there is advantage. One more thing, this is not here. SGLT2 have shown a beneficial effect in retinopathy, especially in macular edema. There are a lot of trials. Then stroke part, SGLT2 are not very good, but GLP have shown some benefits. I just want to make you understand basic pathophysiology, then it will be easy for you to understand in younger children. What diabetes does, there is hyperglycemia and insulin resistance, hyperinsulinemia, obesity. So this all makes patients more prone to have atherosclerotic cardiovascular disease, hypertension, then impact at the level of heart, the structural effect, ischemic or hypertensive cardiac myopathy. And then there are metabolic disturbances, structural alteration, autonomic neuropathy, so all these things. So it is divided into two parts. One part gives abnormality at the level of blood vessels. Other part, the later part, the metabolic abnormality, it gives abnormality at the level of myocardial cell. So it can manifest as ischemic cardiomyopathy, or it can manifest as diabetic or dilated cardiomyopathy. Because DCMP is now a very, very common problem in especially adults. If we use both, so we have proven CV as well as how does it the CV benefits are there when we are using the SGLT2 inhibitors. What it does, it reduces afterload preload of the heart. The blood into heart goes down, so heart is soothed. At the other level, there is vascular dilatation. The efferent renal arterial dilatation is there, so there is a renal protection. Then at the level of GLP-1, what it does, the higher amount of glucagon-like peptide, like it has effect at the level of brain, so appetite has gone down. I shared it reduces glucagon, it increases insulin, and it has some vessel wall benefit. So net is the cardiovascular protection. A chain of roads originating from this factor, which ultimately, so the basic thing is obesity, dyslipidemia, metabolic syndrome, and who is responsible for it? I'll say you guys are responsible. Raw material is cooked by all pediatric endocrinologists and pediatricians. Then we receive the adult patients, and then it goes. So if it is not a blame. Dr. Amar has a very nice study obesity in children, and if we can prevent at that level, at least pass a message, and we can do a lot. So basic problem again is not money, poverty. Basic problem is understanding. So that is very, very important. So if we can take care of this, because when we get raw patients, this is a very raw patient for heart patients, then they are more prone for hypertension, atherosclerosis, and we progress into heart failure. And the most common cause of death in diabetes is CV, cardiovascular death. This is a busy slide, but just a gross GLP-1 and SGLT2. If we look here, a small comparison. GLP-1, glucagon like 1, and SGLT2. Two things is there at any level. Whenever they are compared together, it has been found that the HbA1c reduction is more with GLP-1 compared to SGLT2. So this is one thing. The great part also is little more with GLP-1. There are number of trials on upper part, glucagon like peptide and the SGLT2. Both have shown the cardiovascular benefits in terms of percentage. There are some statistical significant. There's something similar with SGLT2. So if we combine these two molecules together, number needed to treat. Are you aware of NNT word? Number needed to treat. NNT means you need that number of patients to prevent one event. So if you compare these two, this is glucagon like peptide. So and this is SGLT1. So you need 97 patients to treat with SGLT2 inhibitor to save one patient, whereas you need only 70. So it is statistically head-to-head wise, this is little superior in cardiovascular protection. How to choose between SGLT2? I mean, now you have two molecules. Still we are in adult, but this knowledge will be useful when you exercise in your pediatric population. How to choose between GLP-1 and SGLT2? If you look at the heart part, the cardiorenal part, if the renal part is dominating, better would be go for SGLT2 because SGLT2 inhibitors have shown definite benefits in renal outcome, in heart failure. And if you look only for atherosclerotic part, the definite benefits are shown, which we got on like peptide. Glycemic control and decay. The glycemic control wise, SGLT2 inhibitor, GLP-1 is little superior, I shared with you, but both are very good. Diabetic fetus, this is whenever the chances of precocious increases with SGLT2, always keep in your mind. Then comorbidities. If there is obesity, this is a good choice, GLP-1. If there are frequent genital infections, a subgroup of patients, I mean, this is a side effect of SGLT2 because it gives glycosuria. So a subset of patients are very frequent. Whenever they take, they have, in spite of all best efforts. So better would be to go for SGLT2 or GLP-1. Osteoporosis, fractures, lower limb. Canagliflozin is one molecule which has been associated with some limb amputations. So if there is history of limb amputation or GI genitourinary infections, go for GLP-1. If there is a gallbladder disease, any gallbladder disease or history of pancreatitis, avoid using it. Any history of medullary thyroid carcinoma. I remember rebelses there. They are enthusiastically, I wrote to one person, the patient called me and said, sir, my nanny has a medullary thyroid carcinoma. How come you wrote this? So sometimes, again, in busy practice, you are not able to exercise your knowledge. So same factors. When to write? What factors would be considered in choosing between? So when should we use GLP-1? If GFR is very low, better limb amputation, genitourinary symptoms. If you want a greater HbA1c reduction, sometimes patients come and read, doctor, this is very nice medicine. Weight reduction part is more, and if there is dominantly atherosclerotic cardiovascular disease, heart failure is dominating, then better use. There is any history of pancreatitis, don't write. Any history of medullary thyroid carcinoma, don't write. This is a glimpse about different glucagon-like peptide. At least two are in your liraglutide. Has anybody of used the liraglutide? Any one of you? So that's very good. So this is approved for a pediatric, and there is another semaglutide oral. So liraglutide is very wonderful one because it has been proved to benefit all 4-point cardiovascular death or cause mortality. And in these oral semaglutide have shown benefits in terms of percentage, but not statistically significant. These are different trials of because eventually I'll be touching semaglutide. Different trials of these are different. These are different trials on semaglutide. So it was tried with placebo, with SGLT2 inhibitor, with DPP4 inhibitor, with insulin in Japanese patients. So there are a number of trials with oral semaglutide. And if you focus here on the blue lines, dark blue lines, and again it's different compared to monotherapy, placebo, exenatide. But if you look, it has been the oral semaglutide has worked wonderfully compared to any of these things. Either it is comparative or little superior. So oral semaglutide is a nice thing. Are you aware of oral semaglutide? All of you? All of you know. Again, I use the word. This is an innovation. The basic problem with all protein molecules. Why we talk of insulin? Because it is injectable. Had it been oral tablet, nobody would have asked. And we have a lot of trials of was talking about Afreeza and other things. Inhaled insulin. The glucagon peptide is a 31 amino acid protein. Somehow we do not convert insulin into a pill. But this we could convert into a pill. Small protein size perhaps is useful, and because of a molecule known as SNAP, it is helpful rapid absorption from the stomach to convert this into oral. So now injection is converted into a that is the only disadvantage that will get expensive, but cost is equivalent to liraglutide. So if you look at it, so this is a new innovation for you guys, and it is useful in adolescent practice. I should be sharing. It is useful in reducing of weight controlling, cardiovascular safety. There is statistical percentage by difference. Overall, it is a safe molecule, and efficacy was established during early in therapy, late in therapy, at any stage you can give, regardless of renal or hepatic impairment. So you can give it at any stage. And how it should be taken? It is a small peptide. See, all the medicines that we prescribe are absorbed from the intestine. Am I right? This is only salt that is absorbed from the stomach. So what is recommended is give a small amount of water, 120 ml or 100 ml, half cup of water, so that it does not slip into intestine. Number one, and empty stomach, and then patient should not lie down. And there is a small dose. Start with a small dose, because like another there is nausea, vomiting, anorexia. So start with a small dose. Once patient tolerates, give this for a month. If patient tolerates, then make it 7 hours, 3 milligrams again next month. When patient tolerates, then make it 7. And the doses are somewhere between 7 to 14. I mean, I think perhaps one of the largest prescriber in this part of the country, but not many of my patients are on 14. So to reach 14, you have to have really a nice clinical experience and understanding. So GLP-1 analog have this is, I think, after insulin. Insulin reduces HbA1c 3, 4, 5, any amount of it. But otherwise, all sulfonylurea reduce HbA1c somewhere in the range of 0.4 to 0.6, 0.7, 0.8. But after that, glucagon peptide is the only molecule that reduces HbA1c 1, 1.2 up to 2 is not. Now, what about adolescent and young population GLP-1? This was a trial on liraglutide in adolescent. It was between 10 to 17 years of age, 2 arms, and double-blind trial. 1 arm placebo and metformin, other arm metformin plus active, and they were not knowing, double-blind. And after 26 weeks, it was open label. The people knew what they are taking. And look at the data. The more number of patients reached to 63 versus around 35 reached to A1C less than 7. The significant reduction in fasting blood sugar. The change in weight was also noted. So, HbA1c reduction in this study was noted up to 0.6 from base. This is, I am talking in pediatric population, 11 to 17. From base, whatever has happened. And if you look at the other arm, which received the placebo, the A1C increased 0.4. So the net difference was 1.06. And GI adverse events were higher in liraglutide group. Then another trial. Now you will ask if there is a trial of this oral semaglutide in teens. So there is no trial, but this is an ongoing trial in children in type 2 diabetes. And this is semaglutide versus placebo. It is a 52 weeks trial. Those will be escalated to maximum tolerated doses. I shared with you 3, 7, 14. So whatever they can tolerate. And in background, metformin or basal insulin or both. So this will be a new opener, because whenever I see young type 2 people, 10, 12, 14, 16, then people say no injection, no insulin. So I think this would be a very good alternative. And now a word about adolescent and young population with SGLT2. Type 1, we have a trials. There is a trial known as the big trial, and it was 2015 this trial came, and this showed a significant reduction in HbA1c. There was a weight loss, change in insulin dose 8.8%, no change in hypoglycemia or severe hypoglycemia, no difference in diabetic ketoacidosis. So this was type 1 with SGLT2. Another trial was empagliflozin, and this trial also, so this is a busy slide, up to 0.35, it was a 4-week trial. This also showed a reduction. And so in this trial, then this is another trial in children and young people, a common age group, phase 3 trial. And in this 10 to 24 years of children, the 72 participants, dapagliflozin for 24 weeks on top of insulin and metformin, and it was 5 countries. And A1C reduction was noted up to 0.25, not much. This is again when to use recommendations for SGLT2 versus SGLT2, but one thing for sure, whenever there is proteinuria, whenever there is renal impairment, go for SGLT2. And oral semaglutide can be used across EGFR without dose adjustment. But benefits are not seen. What are the side effects of these molecules? Genital infections, amputation, not a very common thing. It has been highlighted in with volume depletion is a problem with SGLT2 inhibitors. Fractures, there are some studies with dapagliflozin, not many. Diabetic ketoacidosis is known with SGLT2, especially when patients are in infection. Urinary tract infections is another thing which is frequently seen with SGLT2. GI intolerance is seen with GLP-1. Gallbladder and pancreatitis is seen with GLP-1. So if you use two things together, there is significant reduction in HbA1c, non-significant. The weight reduction is also much, non-significant reduction. I think you can skip this. Long-term liraglutide is approved in type 2 diabetes in 10 years and above. So this is the standard guideline. Oral semaglutide and dulaglutide. Dulaglutide is available in injectable weekly. Have anybody used dulaglutide? Good. Good. Dulaglutide above 18 years and above. And SGLT2 are approved to use it type 2 DM 18 years and above. So this is the status as yet. So as yet you can use the liraglutide 10 years and above. And finally, I am sharing my thought. Both the molecules are very good. Actually, I am overwhelmed with SGLT2 because whenever now you write a prescription in type 2 diabetes, always give a thought, are you providing any benefit other than controlling blood sugar? Are you protecting kidney? Are you protecting heart? Are you taking care of weight? Are you taking care of glycemic variability? So many questions that you have to answer. But persistent glycosuria may have some effect in growth. I don't know. I don't know. SGLT2 inhibitor were once approved by European Union for adult type 1 diabetes patients with BMI more than 25, but anticipating risk of BK approval was removed because they found a risk. So now this approval is removed. Semaglutide oral can be used in young type 2 diabetes. One thing, type 1 diabetes, like you have follow up 20 years, 30 years. Now my eldest type 1 is 57, 60, 65, so long. So for elder type 1, if you use SGLT2, my understanding is they will have probably benefits in terms of cardiovascular benefits, renal benefits. And finally, impact of regular, this was I think Dr. Ganguly presented, he's sitting here. The impact of regular education support program on patient with type 1 diabetes. We had a paper in RSSDI, I think all of you know RSSDI. It was a oral paper presented by Dr. Ganguly by our group, and he was given first prize, and he has not yet given any party on that. That's why I'm showing it. But the purpose is, the crux is education. Until unless patient understand, nothing can be done. Thank you so much, everyone.
So I think this talk was, many of you will think that we are not using them, but in future we are seeing a lot of type 2 diabetes. We will need to think about these agents. They will become relevant in how to go forward. So Dr. Rishi, if you have to choose one of those, which one would you say would be the better in adolescents?
I think the data is more supportive of GLP-1 and all. So it is undisputed. One thing I would like to say, which is Anurag's data also, and the overall understanding, if whenever you get younger type 2 diabetic, like 14 years, 15 years, be very, very aggressive. Within first year, if they don't lose good amount of weight, they will lose their beta cell. So that should be the directive. So it should be very aggressive in reducing weight, sticking to lifestyle, and going ahead for a very nice control. And these two molecules, at least GLP-1, they do wonders.
So I think the key message is hit early, hit hard. That is very true for adolescents. Chetan study shows that they will lose their beta cell very quickly. If you don't treat it early, there will be a problem. I thank, and any inputs from sirs?
Thank you, Dr. Rishi. That was a very comprehensive talk. Actually, type 2 diabetes in the pediatric age group is very aggressive and rapid loss of beta cells. And the only drugs that are approved are metformin, insulin, and of course, now GLP-1. So you have to hit hard, and with the oral GLP coming in, probably things will become easier for the treatment if they are not going to use basic instruments.
And I think thank you, doctor. Basic thing is that you have highlighted the use of the cardioprotective and renoprotective agents. And from type 1 diabetes, or as the age advances, it is not the glycemic control which matters a lot. Now the focus is on organ protection. And these two molecules which Dr. Rishi has just talked, they are the molecules of future. They are the way of hope to all the diabetic patients. And as he has rightly said, that if we are prescribing treatment for diabetes, we must know that we are not just treating the hyperglycemia, because other factors and prevention of the disease is much more important rather than just trying to control glycemia.
Thank you, Dr. Agarwal. I now request Dr. Mahesh to kindly give memento of appreciation, Dr. Rishi. Dr. Rishi. Dr. Mahesh, please. I'll request Dr. Santosh to kindly give a moment of appreciation to Dr. Bhaskar Ganguly. And I'll request Dr. Pragya to give a moment of appreciation to Dr. Agrawal. And this would mark the end of our session on diabetes. And we will moving forward to pituitary. And we are joined already by Dr. Ved Bhushan Arya, who is an eminent pediatric endocrinologist in UK. Dr. Ved was doing his PG along with me when I was at AIMS. So we had the opportunity to work together, and then he went to UK. Sorry, Dr. Ved, for keeping you waiting for a long time. We were getting a bit late on that. And hopefully your wait will be worth it, and we will get a lot of knowledge coming from you from that perspective. So Dr. Ved has been involved in multiple research projects. His initial interest was towards hyperinsulinism to begin with. He worked in Great Ormond Street Hospital in London, and now he is in King's College London, and his work now is more towards neuroendocrinology. So I actually asked the ministry to talk about hyperinsulinism to begin with, but then he said, no, already Pratik is talking, so let me talk about something very interesting, and he'll be talking about hypothalamic amenorrhea. Now, most of us don't think too much about it. We just say, okay, patient is lean, not doing well, he is stressed, all those things, athletic, amenorrhea, hypothalamic. But Dr. Ved will really put a lot of light on that. So over to you, Dr. Ved, to start off your talk and make us aware about this topic.
Thank you, Anurag. I'm going to share my slide. Can you hear me okay?
Yeah, I can hear you. Yeah, we can see your slide now. Yeah, please go ahead.
Excellent, thank you. Okay, so yeah, please let me know if my signal drops off and you can't hear me clearly. So firstly, I would like to thank Anurag and the rest of the organizing committee for inviting me to talk in this very interesting meeting. Secondly, what I would like to say is it's a big topic. I would try to cover as much as I can in next 20-25 minutes, but it's not possible to cover everything. So if there are any questions after that, I'll try my best to answer them. Okay, so my talk is on functional hypothalamic amenorrhea. So most of you would know it's a condition which is characterized by irregular or absent menses due to suppression of HPO axis. The condition is termed functional because there is no anatomic or organic disease in these individuals, and the immediate cause of the anovulation is a functional reduction in GnRH drive, which manifests as reduced LH frequency. Hence, LH and FSH levels are insufficient in these individuals to maintain full folliculogenesis, and hence ovulation is affected. If the causal behavior factor is corrected, then it will restore the ovulatory ovarian function. And studies have shown that if an exogenous GnRH or gonadotrophins are given, this will restore folliculogenesis in these patients. It's depending on where one practices, it's a quite common cause of secondary amenorrhea in young premenopausal women and adolescents, and this results in severe hypoestrogenism. According to American Society of Reproductive Medicine, it can be responsible for up to 35% of patients presenting with secondary amenorrhea. As Anurag mentioned, this is typically occurs in a setting of low body weight, such as eating disorder like anorexia nervosa, individuals who do a lot of exercise, who are under a lot of stress emotionally, or a combination of these factors. Energy deficiency from either a frank deficit in caloric intake or relative to excessive exercise leads to certain hormone adaptations in these individuals, which try to optimize the energy availability and prioritize this for essential body function. So reproduction is not considered an essential if there's lack of a deficit in caloric intake. So these individuals will typically present with amenorrhea of 6-month duration or longer. However, one need to be aware that the presentation can vary from subclinical menstrual dysfunction, such as shortened luteal phase or anovulatory cycles, to frank oligoamenorrhea. And in adolescence, this condition may be difficult to distinguish because of immaturity of the HPO axis during the early post-menarcheal years. So there is, sorry, it's a busy slide. As we would know, there are lots of potential etiologies of amenorrhea. And functional hypothalamic amenorrhea, this is a diagnosis of exclusion. So one must consider a broad differential diagnosis in these individuals to make certain that all the underlying etiologies that may be manifesting as amenorrhea have been excluded. So the process by which GnRH is suppressed in these patients is multifactorial, as there are many inhibitory and stimulatory neuromodulatory signals that impair GnRH pulsatility. This is a schematic representation of neural interactions between metabolic and reproductive functions, depicting likely sites of action of various hormones to control the release of GnRH. As you can see in the center, the kisspeptin plays a central role and has been implicated as a common intermediary signal modulating the GnRH activity, acting downstream of many of these neuromodulatory systems. Studies in rodents have demonstrated reduced kisspeptin secretion in conditions of energy deficit. And this is mediated by a reduction in levels of certain hormones like leptin, insulin, insulin-like growth factor, as well as increases in certain hormones such as cortisol, ghrelin, and adiponectin. They may also be these individuals may also be genetically predisposed to develop FHA. In one study, which was a smaller study, and the results have not been replicated in larger studies, and there was more. So individuals with FHA had the heterozygous mutations in certain genes of HPA axis were more identified as compared to healthy controls, suggesting that these individuals were at increased vulnerability to develop hypothalamic amenorrhea. So how does one evaluate a patient of suspected FHA? In these patients, so these are some of the recommendations from Endocrine Society. It is recommended to take a detailed history regarding their diet, exercise pattern, attitudes such as perfectionism, high need for social approval, their ambitions, sleep patterns, any stress in their lives, any fractures or substance abuse. So it is recommended to exclude pregnancy and perform a full physical examination, including a gynecological examination, to evaluate the possibility of any organic etiology of amenorrhea. In terms of initial investigations, these individuals should have basic workup to ensure there's no underlying chronic illness. So it is recommended to do blood count, renal profile, liver profile, inflammatory markers, blood glucose, and beta HCG. And in terms of endocrine evaluation, these patients should have thyroid function, prolactin, gonadotrophins, estradiol, anti-Mullerian hormone. And in those individuals with presence of clinical hyperandrogenism, they should have testosterone, DHEAS, and morning 17-OHP level checked. If there is a history of headache, vision change, any lateralizing clinical signs, any abnormal laboratory tests suggesting pituitary deficiency or excess, it is recommended to have a brain MRI, including pituitary cuts with contrast. So now, what's the fuss about, like, why we are worried about this condition? In addition to obviously the periods are not regular, what's the risk to the health of these individuals? So the main concern has been on the bones. So this is a study from like nearly 20 years ago, looking at the bone mineral density of these patients and comparing it with healthy controls. So as you can see, the bone mineral density Z scores at lumbar spine, hip, and femoral neck was reduced in adolescents with anorexia nervosa as compared to those with healthy controls. And this is likely driven by a number of factors, which I'll be addressing in some of my next slides. So in addition to studying the bone mineral density by Dexa, studies have also been done using high resolution peripheral quantitative CT to look at the cortical and trabecular volumetric bone density, geometry of the bone, the microarchitecture, as well as the estimates of bone strength in anorexia nervosa. And as you can see from this table, so these individuals will have a reduction in the cortical part of the bone, reduction in the cortical thickness, increased cortical porosity, increase in trabecular area of the bone, as well as a decrease in the strength estimates of the bone. So similar studies have also been done at the bone, the weight-bearing side. So this more recent publication is looking at the similar parameters at distal tibia, which again shows very similar changes in the architecture of the bones. So this particular study also tried to address what is driving these changes, and as part of their study, they measured marrow adipose tissue by magnetic resonance spectroscopy, and what they found was that adolescents with anorexia nervosa had high level of marrow adipose tissue as compared to controls, and this indicated that there is an increased differentiation of the common mesenchymal progenitor stem cells towards the adipocyte line as compared to the osteoblastic line, and hence they have got low bone mineral strength and density. So a high marrow adipose tissue is related to lower bone strength estimate in young women with this condition, as can be seen by this regression association between the marrow adipose tissue and the bone stiffness. So in terms of how these changes, which I've just mentioned, how this translates to routine clinical presentation. So these changes translate to a higher fracture risk in adolescents and young women with anorexia nervosa as compared to controls. So this is a study which was a large study looking at more than 2,000 individuals with anorexia nervosa from Denmark. So for every patient with anorexia nervosa, they had enrolled 3 controls, and they looked at the fracture risk before the diagnosis of anorexia nervosa and after the diagnosis of anorexia nervosa. And as you can see from the top row, there was an increased risk of fracture after the diagnosis of anorexia nervosa. And this increased risk persisted more than 10 years after the diagnosis. So there's clearly a risk to the bone strength in these individuals. So now coming to what are the determinants of bone outcome in these patients. So this is related with changes in body composition in these individuals, alterations in their HPO axis, alteration in their growth hormone axis, hypothalamic pituitary adrenal axis, and also changes in the appetite regulating hormones, as well as changes in adipokine. So I'll try to address these one by one in the next few slides. So in a compensatory increase in cortisol concentration occurs in energy deficient states such as anorexia nervosa or exercise-induced amenorrhea. And in these individuals, higher cortisol concentrations are associated with lower extremity lean mass, as you can see from the figure on the right. And if there is lower lean mass, that's an independent predictor of bone mineral density at almost every side, consistent with the pull of muscle on the bone being osteogenic. So another study has tried to look at the presence of cold activated brown adipose tissue in these individuals. So the picture on the left is of a healthy control, and the picture on the right is of a patient with anorexia nervosa. And this is a PET FDG image showing presence of brown adipose tissue in the supraclavicular, axillary, and neck region of healthy control, which is missing in the patient with anorexia nervosa. And regression analysis of brown adipose tissue with lumbar spine BMD showed that there's a positive correlation. So if the brown adipose tissue is less, so the lumbar spine bone mineral density will also be less. And young women with brown adipose tissue have higher BMD. So this suggests that the brown adipose tissue may be involved in the regulation of stem cell differentiation into the bone lineage at the expense of adipogenesis. So now moving on to the HPO axis, how does the suppression of HPO axis affect the bone strength? So this the osteoblastic lineage cell is a site of action of estrogen. So if there's a low estrogen, the osteoblastic lineage cells produce high levels of interleukin-7, which causes differentiation of, which causes proliferation of T cells, and also leads to these T cells producing rank ligand as well as TNF cytokine. These TNF cytokines also act on the osteoblastic lineage cells, increasing the production of rank ligand from these osteoblastic lineage cells. And this causes proliferation and differentiation of osteoclastic lineage cell, causing more bone resorption as compared to bone formation. The panel on the right is the other hypothetical model, which suggests or which postulates that if there is low level of estrogen, there will be low production of Fas ligand from the progenitor osteoclastic cell lineage. And because osteoclasts express the Fas protein, so if there is a less expression of Fas-L, so these osteoclasts will have a longer lifespan and causing more bone resorption as compared to formation. Moving on to hypothalamic pituitary growth hormone axis. So in studies, it's been well established that an energy deficient state results in a state of growth hormone resistance. So these individuals have higher levels of growth hormone and lower levels of IGF-1 levels. So this hepatic resistance to growth hormone is likely mediated due to downregulation of growth hormone receptor in end organs, as well as elevated levels of FGF-1 concentrations. So while higher levels of growth hormone concentrations are associated with higher levels of bone turnover markers in healthy normal controls, in healthy normal weight controls, this association is not evident in anorexia nervosa individuals, indicating a resistance to growth hormone at the level of bone as well as liver. So as you can see, the p-values in AN patients is not significant as compared to a healthy control. So people have tried to look at other ways to see how the hypothalamic pituitary growth hormone axis interferes with the bone strength. So there, some groups have tried giving supraphysiological doses of recombinant human growth hormone, and this led to no increase in IGF-1 concentrations or concentration of bone formation markers in women with AN, further providing evidence of hepatic and skeletal resistance to growth hormone. Whereas when groups have tried giving recombinant human IGF-1 to these individuals, this was noted to be associated with increase in the level of bone formation markers. So clearly showing that these individuals are resistant to growth hormone. So moving on to the hypothalamic pituitary adrenal axis. So one of the well-established neuroendocrine adaptation of functional hypothalamic amenorrhea is an overactivation of the hypothalamic pituitary adrenal axis. So these individuals have higher levels of cortisol and ACTH. And these relatively higher levels of cortisol may have immediate as well as long-term effects on bone health through various mechanisms, such as reduced osteoblastic activity, increased osteoclastic activity, inhibition of calcium absorption from the gut. Also, high levels of cortisol cause reduced secretion of growth hormone and IGF-1. So again, here, as you can see, the higher cortisol levels on the y-axis are inversely correlated with markers of bone formation on the x-axis. So these low levels of bone formation markers clearly contributes to the low bone mineral density through suppression of bone formation. So moving on to the how the appetite regulating hormones are affected in these patients and how they contribute to low bone mass. So it's well established that adolescents and young women with FHA have lower levels of leptin, insulin, and oxytocin, and they also have higher levels of ghrelin, adiponectin, and PYY. And many of these hormone alterations have been associated with suppression of HPO axis and consequently leads to low bone mass. So not only there are indirect effects of these appetite regulating hormones, some of these hormones have direct effects as well. So for example, leptin is well known to be osteoanabolic and anti-resorptive. PYY is in studies have been shown to inhibit osteoblastic activity. Similarly, oxytocin is bone anabolic. So all these changes in appetite regulating hormones in these individuals impact the bone health. So now moving on to how these individuals need to be managed. So the first line of management of FHA is lifestyle intervention, aiming to normalize their HPO axis function and resumption of menses. So the approach in these individuals have to be multidisciplinary, involving, in addition to a physician, a dietitian, psychologist, and making sure there is an engagement of the parents as well as their coach or the trainer if the patient is an hyper exerciser. The condition is generally reversible and resolves after restoration of energy balance and resolution of their underlying emotional stress. A dietary evaluation and counseling is important to optimize caloric intake in these individuals, and also to ensure the optimizing their intake of micronutrients such as calcium and vitamin D. I cannot overemphasize the role of a psychological support to treat the underlying stress and ensuring a behavioral change in these individuals. There has been some debate over whether a critical increase in weight is required for menses to resume. One study, based on one study, a recommendation was that the goal weight should be at least 2 kilograms higher than the weight at which the menstruation was lost. And be aware that it can take 6 to 12 months or even longer of being at a healthy weight before menses resume in these individuals. Another study suggested that about 50% of women are expected to resume their menstrual cycles when they are at or above a BMI of 19, along with the presence of at least more than 23% body fat. There is significant variability in the set point of menstrual recovery from individual to individual, thus establishing goal weights can be challenging. And if a woman or an adolescent continues to be amenorrheic despite being at a healthy weight for a prolonged period, it is important to consider other causes of amenorrhea, such as polycystic ovarian syndrome, or there could be presence of emotional stress, although the weight might have recovered. Now, coming specifically to how the management of low bone mineral density in these individuals, again, as I said previously, the most important strategies to improve bone mineral density in these individuals is normalization of their menstrual function and recovery of weight. It is important to supplement vitamin D to ensure their levels are above at least 30 nanograms per mil, and also to ensure that they are taking adequate calcium in their diet. Clinicians should obtain a baseline bone mineral density measurement for any adolescent or a young woman with 6 or more months of amenorrhea. And this may need to be done even earlier if there's a history of severe nutritional deficiency or there is skeletal fragility. Although estrogen deficiency is an important determinant of low bone mineral density in individuals with FHA, many studies have shown a lack of protective effect of combined oral contraceptive pills on bone. And a possible reason for the lack of efficacy of oral estrogen is that this causes suppression of IGF-1, which is a key osteoanabolic hormones. So oral contraceptive, oral estrogens are, they undergo hepatic first pass metabolism, which causes the suppression of IGF-1 from liver. In contrast, transdermal estrogen replacement, if given in replacement doses, is not IGF-1 suppressive, and randomized clinical trials over 12 or 18 months have shown that this leads to improvement in their hip and spine BMD-Z scores in adolescents with anorexia nervosa. So this is a recommendation from the Endocrine Society clinical practice guideline. So they suggest a short-term use of transdermal estradiol therapy with cyclic oral progesterones in adolescents and women who have not had a return of their menstruation after a reasonable trial of nutritional, psychological, and modified exercise intervention. So few studies have also evaluated use of anti-resorptive medications such as bisphosphonates or denosumab in FHA. Results so far have been mixed, and the numbers treated with these medications have been very, very small. So the recommendation is to not use these medications, and one also need to be aware that these medications, they have a very long half-life, and these women, they have lots of reproductive years ahead of them. Some trials have tried using leptin in these individuals. These two trials of leptin as compared to placebo demonstrated an improvement in menstrual function, as well as increases in the level of IGF-1 and markers of bone formation with leptin. However, the problem with the medication is that it led to subjective reduction in their appetite, as well as a significant reduction in their body weight and fat mass. So that's the downside of leptin for treatment for these individuals. So to summarize, so functional hypothalamic amenorrhea is a form of chronic anovulation, not due to any identifiable causes, and often associated with stress, weight loss, excessive exercise, or a combination of these factors. Investigations should include assessment to exclude all the underlying systemic and endocrinological etiologies which can cause amenorrhea, as this is a diagnosis of exclusion, and these individuals require a multidisciplinary approach, including the support of dietetics and psychologists, and medical complications in FHA include bone loss and infertility, which I haven't addressed, and appropriate therapies are under debate and investigation. Thank you.
Thanks a lot, Dr. Very wonderfully summarized such a complicated topic. So big applause from our side. I think this is a topic which is very relevant. We tend to see less in terms of anorexia nervosa and feeding disorder. We see a lot of secondary causes like celiac disease, malabsorption, other settings, where the physiological perspective behaves similarly. But now we are also seeing more of these girls coming in that perspective, and that's relevant. So what is your suggestion with regards to when should we consider estrogen replacement? Suppose everything has been done, it is failing, and yet they're not often getting the weight in a normal becomes difficult, but you're losing bone. Do you think estrogen at some point of time will be of some sense?
That's that's what I've tried to summarize in my talk. So if you are considering supplementing estrogen, giving oral estrogen is not the way forward. So you have to give it transdermally, and you have to be aware that giving estrogen is just you're only treating the HPO axis, because there are lots of other endocrine abnormalities in these patients, like high levels of cortisol, growth hormone resistance, and so you may not be able to have a full recovery of their bone health. But obviously, the first intervention is trying to have a weight gain, and give it a period of time to see if the recovery happens, because in studies it's well known that you have to be at a good weight for sometimes even up to 12 months or longer before the menses will resume.
I think that's a very, very valid point. Your point about 2 kilograms above the pre-stabilized weight was a very important parameter that we can track as a goal in that. Dr. Subrato from Kolkata. Dr. Subrato, you have a very intriguing question. We were discussing about this issue yesterday night, so you can share your thoughts on this.
Dr. Arya, I was listening very intently to this extraordinary presentation, and it just so happens I have a child with anorexia nervosa whose pre-morbid weight was 48 kilos. There was some body image issues, so she went into bulimic episodes for 2 months. She lost about 12 to 13 kilograms of weight, became extraordinarily sick, and but since then she's been on psychotherapy, she's been on dietary support, and she claims now she's trying to eat as much as she can. Now there are two challenges. Now 6 months down the line, her weight is still about 38 kilos, and her ideal body weight is 43, and her pre-morbid weight was 48, which is excessive. So when you say this 2 kilo over, in this instance, will it be 45 kilos? That's one question. Second question is trying this estrogen progesterone, but you just now said transdermal is the only way to go. But if we can we jumpstart the the, what do you call that, the cycles by using this combination?
No, thank you. It's a very interesting question. I think I missed the second question. So maybe let me answer the first one, and then maybe you'll have to repeat the end part of the second one. So in this case, I think one would expect that once she reaches maybe a couple of kilogram or at weight which is expected for her age and height, then she would probably resume. I wouldn't say that you have to aim for, again, 48 kilo if she was already overweight to start with. So again, the set point for individuals are very different. So some individuals will recover at a lower weight, some individuals will recover at a higher weight. One need to be aware of that, and you would need to give a reasonable time on that weight before you say, oh, I need to do another intervention, or why the recovery is not happening. I hope I was able to answer the question.
Very quickly is, why doesn't oral estrogen help? Because it will improve, the secondary sexual characters, it will improve the body image, self-esteem, and definitely, reduce a lot of her angst right now, because she's estrogen deprived. Estradiol is only 16 with a regression of secondary sexual characters.
Okay, no, okay, so now I got you. So to be honest, lots of endocrinologists use oral estrogens for this kind of a situation. But what I was trying to say is, because when you're giving oral estrogens, because of the hepatic first pass metabolism, these individuals' IGF-1 levels will drop. So that has got an osteoanabolic effect. So it's not the effect in terms of effect on the bone. Oral estrogens are not good as compared to a transdermal estrogens. That is what I was trying to highlight. But a lot of practitioners use oral estrogens, and that's why when I put the society guideline, that's what they said, that try not to use oral estrogens.
Thank you. Thank you for your input.
So I think this was a wonderful talk, and the research area is really excellent, and it gives us insight about how when a body is less in energy, it is going into a shell. It is trying to stop thyroid, stop reproduction, stop growth, and maybe have some stress hormone coming in. That's what is happening. So unless we correct that sort of a scenario, we are not going to go out. So ultimately, the correction of the basic etiology is what we are looking at. So I think it was a wonderful talk. Once again, very well appreciated by the audience here. So I think we'll have a big round of applause again for Dr. Ved, and hopefully next time we'll be able to have you here in India, and we'd love to have you here. Thanks, Dr. Ved. Thank you.
No, thank you very much. Thank you again for this invitation, and yeah, lovely to see you, Anurag. Okay.
Thank you. Long time. Yeah. Okay. Thank you, Ved. So now we'll be moving forward towards the last session. So we have one change which has been done. The bonate session now will happen in the morning. Morning we're starting dot at 8 o'clock. So you are all here, staying here. We start at 8 o'clock directly. We'll have a session by Dr. Hemchand to start off. He'll talk about growth hormone therapy. Then we'll have a PCOS session. And then again, he will have the third session. So we'll have continued, because bonate was very important. But because of the flight delay, we could not have that bonate session, unfortunately. So now we are moving towards the last session, and this is going to be entirely clinical in that perspective. And this session is going to focus about what we've done this time. We've got 3 grand rounds. So rather than having theoretical discussions, we are talking about 3 particular areas using cases. So they will all use cases alone. And from there, we will try to go forward and discuss the common conditions. So in this regards, our first case, basically, first scenario today is about pituitary. And for this, we have got a panel of experts. We have got Dr. Subrata. Dr. Subrata, please join the dais. We have got Dr. Rishi, Dr. Hemchand Prasad. Dr. Subrata and Dr. Rishi has already been introduced. Dr. Hemchand also doesn't need any introduction. He is a pillar in south of India with regards to the pediatric endocrinology, and he has been always part of our programs right from 2012, I believe. So he's been coming, I think this is your 5th or 6th time to Kanpur. And I think so what the consistent feature of ours is that if you have one, they tend to come. So we always want to be associated with people again and again. And Dr. Neha is the fourth expert. And what the program will be, there will be a dialogue basically between our fellow, Dr. Sayan, and the panel of experts who will put their inputs. I'll chip in a few details here and there, and we'll go forward from there. So pituitary is definitely considered the most important gland as far as body is concerned. And we know that it is a major gland in that perspective, and that really needs to be understood. And we'll use this gland on using three group of disorders: multiple pituitary hormone deficiency, hyperprolactinemia, and AVP disorder. So we'll use, I think, 20 cases quickly to go through and see how we manage and assess. So you've seen a lot of cases of pituitary in the session, so it will be easy to go from there. So we talk about the HPT axis. Now, what's interesting in HPT axis is all the hormones of the anterior pituitary are stimulated by the hypothalamic hormone, except for prolactin. So we've got GHRH, which stimulates growth hormone, TRH, which stimulates TSH, ACTH stimulates CRF, stimulates ACTH, and GnRH, the only inhibitory factor is dopamine. Now, why is that? Because body doesn't want to lactate all the time. So you have an inhibitory pathway. When you want, you switch it off. So this is very, very relevant, because if you have a lesion at the hypothalamic level, your prolactin level will go up. If you have a pituitary lesion, your prolactin will go down. So prolactin is a marker of site of a hypothalamic pituitary damage, which we saw in many of our cases as well in that regard. The second thing to remember out here, very importantly in that perspective, is that if you have radiation damage, the first hormone to be damaged on radiation is growth hormone. The second hormone is going to be LH and FSH, will go a bit later. ACTH is also going to be affected in a significant fashion. So growth hormone is first, followed by LH and FSH, then ACTH and TSH. So first hormone to knock down with radiation is growth hormone. Then you will have hypothalamic involvement causing precocious puberty, then delayed puberty, then ACTH deficiency. However, if you have an immunological cause like infundibulitis, the first hormone to go will be ACTH. So there is a difference in terms of the pathology, which will tell you which hormone is affected in that regard. Now, assessment basically, if you have 2 or more anterior pituitary hormone deficiency, this will call as MPHD. So growth hormone levels less, FT4 low with a TSH less than 20. This is I've told 20 times, I think, but never forget FT4 low, TSH less than 20. That is central. It's not that TSH 10 to 20 becomes primary. Prolactin, of course, ACTH stimulated, cortisol less than 550, low levels, and of course, DI is a different ballgame. So if you have DI in a pituitary case, it is not pituitary, it is hypothalamic. So if you have DI, if you have high prolactin, that is hypothalamic. If you have low prolactin, if you have no DI, if you have early chiasmal involvement, that's pituitary. So this is just a background, and we'll so there are various genes involved, and we've been discussing about cases about septo-optic dysplasia and involvement of pituitary specific phenotypes in that perspective. We'll ask this question to Dr. Rishi, I believe. That will be his area of interest on that in that regard. So we'll start with the first case, Simon.
So we have a 12-year-old boy who presented to us with lethargy, had low free T4 levels and a low TSH for the same.
Yeah.
Had a low cortisol along with a low ACTH, so looks like a multiple pituitary hormone deficiency in this case. Had a low LH-FSH, so complete multiple pituitary hormone deficiency at this stage. So how do we differentiate a pituitary from a hypothalamic lesion?
So Dr. Rishi, I think answer is already given by Dr. Anurag in his talk, but in introductory talk, when he was saying a minute back, he was saying that to differentiate whether diabetes insipidus is there or not, or what is the prolactin level. These two things will differentiate whether it is hypothalamic or not. Because the prolactin is low, it's doing more in favor of pituitary, but prolactin is borderline 50, and it goes more in favor of our.
So in this case, the prolactin was on the lower side. It suggested more of a other scenario. So the key message, Dr. Rishi, I think you already said that very important again, that if you have central hypothyroidism, look at MPHD. What else, Dr. Rishi? I think this is the message you give. Low prolactin suggests a pituitary cause.
Prolactin measurement is very important, and low prolactin is
not of very significant. It has a value.
So this is classical of Sheehan syndrome. We say zero prolactin, that sort of a thing. A similar scenario relevant for pediatric practice.
So moving forward to the second case, this is a 1 week old boy presenting with seizures. So at the time of seizures, there is hypoglycemia with ketotic hypoglycemia, but a very low cortisol for the same and a very low growth hormone. So looks like a multiple pituitary hormone deficiency confirmed clinically by a micropenis of length 1.8 centimeter. Sir,
so clearly this is a multiple pituitary hormone deficiency because all the axes are involved. And when you have this particular scenario where clearly cortisol division, growth hormone, they tend to have severe hypoglycemia and seizure. Now the eye sign is basically nystagmus, and septo-optic dysplasia is classic. And in fact, the important thing to remember is to diagnose growth hormone deficiency as per the latest GHR guidelines in 2019. Any level less than 7 is considered. But I have a question for you, Anurag, since you're the author of this very succinct random model. Is the classic teaching was the hypothalamic versus pituitary is, suppose you take hypothalamic and the pituitary is destroyed, your TSH will be basically unreported. Whereas the hypothalamic, the TSH will be very much more. So what we were taught those days, I mean, when I was in the States, we had TRH available and we used to use TRH and then show that if you have no rise in TSH, then it is pituitary because it's basically a guard protein. So what are your comments on that?
Yes, I think that's a very important question. Now, if you look at patient with Sheehan syndrome, Dr. Rishi has got a large number of them. The TSH is never zero. Sheehan is one whose whole pituitary is necrosed, and prolactin levels are zero, but TSH will never be zero. The reason for that is bioinactive TSH. So in hypothalamic, you will have a slightly higher TSH, which is very clear because there the TSH is not glycosylated. So the chance of having is more with hypothalamic, but it can still happen with pituitary because never you will have a zero TSH in most cases. So yes, very importantly, higher levels are just hypothalamic. But if you want one test, like if I say phosphorus is a test to distinguish between hypoparathyroidism and vitamin D, similarly prolactin is a test. But yes, TSH there will be a variation, but both of them will have bioinactive TSH. It may be low, normal, or even slightly high. So Dr. Rishi, your comments on Sheehan with the same, because Sheehan is pretty much very much pituitary necrosis.
Not only I was just sharing my experience with school working with Professor. In 90s, pediatric there used to be sample of TRX, WHO. So these two TRX TSH stimulation tests that get used to differentiate what is the level of disease. That is Sheehan's again
zero TSH, but TSH zero is not very common. TSH will be 1, 2, 3, 4, something like that.
Yeah, it is basically
inappropriately low for the.
So I think the inappropriate word is very important for low T4. The TSH should for primary should be very high. If TSH is below normal, it most likely TSH should be 30, 40, 50, 60, something like that. I mean, if you understand with my language.
Yeah. So the figure of 20 that I'm talking about has come from studies which have looked into both secondary and tertiary hypothyroidism, and they found that.
Did they do TRH stimulation?
Yes, they did. Yes, they did. And they did the imaging actually. So if you have, they also had the imaging. So somebody had an MRI lesion, somebody had a pituitary lesion. So they knew very well where they were in terms of that. And both of them had a higher than normal TSH also in a few cases. So this is an interesting finding in that regard.
I think from TRH stimulation test is replaced by imaging.
Yes, now MRI is so easily available, you will know what you're dealing with usually. So now I think this was very clear. Dr. Subrato said that roving nystagmus, the eyes will keep on roving. That is what you should look at. So nystagmus and blindness, Hessig mutation. So Dr. Subrato, I think hypoglycemia
absolutely
with microphone.
In fact, the general message is that's the other thing is you don't have to wait for oxology because growth hormone deficiency pans out later on and then they become smaller. So So you have a baby who's pretty well grown. I have one such patient with midline defect. That was the other thing, midline defect. And the eyes were not growing, all the numbers were low. And I started them on supplemental hormones, including growth hormone.
So always look at the eyes, always look at the craniofacial, midfacial, and that will give you the clue.
And midline defects are very common, and if you do an MRI, you might get septal.
PSIS, yeah.
Septum pellucidum either absent.
Thank you, sir. Moving forward to the next case. Now we have a 17-year-old girl who was a follow-up case of multiple pituitary hormone deficiency on growth hormone and thyroxine replacement. As the child came late, he was first initiated on growth hormone. Now, main concern was delayed puberty, started on estradiol. Had complaints of headache and lethargy. And when a cortisol level was done, it came out to be low, 74 nanomoles per liter. On MRI, we found an enlarged pituitary. So can a multiple pituitary hormone deficiency have enlarged pituitary, sir?
Or is it a tumor which was missed for a long time?
Yeah, I think what is really interesting is to see that the multiple pituitary hormone deficiencies evolve over time. So it starts off with one hormone, and on follow-up, you pick up more and more hormonal deficiencies on follow-up. And the clue, the presence of enlarged pituitary gland is an important clue to the underlying genetic diagnosis. If you see, a lot of data is available from various Indian centers who have documented the presence of mutations in the PROP and PIT as important causes of congenital hypopituitarism, and GH1 and GHR, which are responsible mutations in isolated growth hormone deficiency. The presence of enlarged pituitary gland is an important clue for the diagnosis of PROP1, and hypoplastic pituitary is an important clue for the diagnosis of PIT1. And remember, our country, the mutations behave so funnily, and in fact, there's a lot of reports in Western India where they have displayed precocious puberty associated with PIT1. So I think the important message from this case is the enlarged pituitary gland is not a sign of a tumor, but it is a message to you to think in terms of a PROP1 mutation as an underlying cause for the hypopituitarism. And in this diagram, especially with the advent of the growth hormone, thyroxine, and the estrogen therapy, which has probably triggered the onset of adrenal insufficiency. So identify them early before the onset of symptoms. Periodic screening is mandatory. This is the message from the case.
I think that was very nicely put. So basically, these are causes when you have congenital NPHD, don't get stopped there. There will be some causes, and now we've got NGS available. Whether it changes management is a different thing altogether, but ultimately you know more about the case. It's pituitary morphology. MRI will give you a lot of picture in that regards.
A 17-year-old girl, again, presenting with lethargy, had weakness, amenorrhea. Also along with that, had visual complaints, undetectable LH and FSH, but with a prolactin that is 60 at present. Low cortisol, low free T4 for the same. So what do you think, Dr. Neha, about this case?
So as we can see from the biochemistry here, that this is the case of multiple pituitary hormone deficiency. So we have hypogonadotrophic hypogonadism, we have low cortisol, and we have low thyroxine level as well. So as Sir has previously pointed out that now imaging is easily available, so every case with multiple pituitary hormone deficiency should be subjected to a MRI scan with pituitary protocol. So it is important to write MRI pituitary protocol whenever we are sending a child for regular MRI.
So what do you expect based upon these findings, whether it is hypothalamic or pituitary?
So since we have a prolactin level of 60, so based on this prolactin, one would estimate that it is likely a hypothalamic cause and not a pituitary. But when MRI was done, what we find here is so you can see the white arrow placed on the MRI imaging, which is showing a thick stalk-like image. So a sagittal section is a better section to pinpoint the stalk thickening. But here also you can see slight stalk thickening. So an adolescent girl with hypogonadotrophic hypogonadism with stalk thickening, one should always think of a autoimmune etiology behind it.
And would they have DI?
With stalk thickening, there is an increased possibility of DI in picture. So one needs to monitor the electrolytes and urine output and intake chart should be.
So this is the classically first reported as differential of Sheehan in pregnant women. So what they found was Sheehan causes complete necrosis, no DI. Then they found some of these ladies had DI also. Then they realized it was actually an autoimmune process which caused that. But now we see this also in adolescents. So stalk thickening is a big message. You see big stock if you see here. And Sayan did a wonderful presentation on pituitary imaging in the on-site course. This is very, very thick. Dr. Rishi.
Small comment about CAHs, we are talking once we diagnose the patient CAHs, and eventually that patient conceived. And then we realize it's not CAHs, it's autoimmune hepatitis.
Yes. And that this can change over time. That is another scenario.
Why it is not prolactin tumor?
Okay. The level of prolactin is not high for that. That is the first message there. So for a prolactin producing tumor to cause MPHD, it will be a big lesion. So that big lesion with prolactin will be very high. Neha was asking why didn't we think of a diluted sample? So this, your point is true, whether it is a hook effect. But if you look at this MRI, this is not like a, this, you're thinking more like a macroadenoma. This looks actually like a thickened stalk. And when we looked on the other image, you got a better picture. But your point is valid. And we said that if your prolactin is not that high and you have got a large lesion, think of a hook effect. That is very, very valid point. But the overall picture was different in this scenario. So Neha, what are the messages?
We should always consider radio diagnosis of the cellular region in all the cases of multiple pituitary hormone deficiency, and especially in a female patient, a young adolescent, and autoimmune etiology should be kept in mind.
Thank you, Dr. Neha. Moving forward to the next case, we have a 15-year-old girl presenting to us with headache. Now, this was low grade, but suddenly increased. And thereafter, the girl went into shock. Sodium was low, potassium was normal in this case, and cortisol and free T4 also came out to be low. So what can be the cause of this sudden increase in headache and thereafter going into shock with isolated hyponatremia?
And another finding was there was also ophthalmoplegia. So there was ophthalmoplegia. So I think now we are closer to the diagnosis.
That points out very clearly. This goes more in favor of any headache with shock. And here, what you're saying that potential is normal. So that is again a picture point. And then all these hormones, multiple deficiencies, sudden onset, ophthalmoplegia, will merge from the pituitary. So what you have to do, one thing, give fluids, and steroids. Then whatever you want to do, and find out the reason why.
So I think this is a very important message that pituitary apoplexy is an emergency. There is an adenoma which suddenly bleeds because of whatever reason. It swells up, and when it swells up, normally pituitary enlarges in the superior direction. But if you suddenly increase, you break the bone boundary, go into the cavernous sinus, cause third, fourth, sixth palsy, and that's why you will have features of hormone deficiency along with pressure effect. And that is why ophthalmoplegia with shock, headache, first thing pituitary apoplexy and steroids become very important in this setting, and that becomes relevant. So Dr. Rishi, key messages from that point?
I think I like one thing actually when you were introducing me to this one thing about my introduction is that I'm a storyteller. And I've learned a lot from my patient. But very recently, a patient, just 8 days back, a pituitary macroadenoma, Amenorrhea, 20 milligram, and then suddenly she came after 5-6 years. What's the particular? I was looking at the Dexa Gussa Matuna, and I diagnosed my because of financial reasons or lack of awareness, whatever she did not learn. I was upset because macroprolactinema is totally treatable disease. We got MRI and everything there, and it was disappeared. It was autoinfarction.
And the other point also is that don't start.
So moral of the story is never get angry on patients. So that is another part of the story.
And don't start at a high dose cabergoline. If you start high dose in the immediate phase, you will cause this apoplexy. So this is something which also we have to do. Yeah, I know. So this will happen. Yeah.
In fact, it makes it better to start with bromocriptine in these cases.
Yeah. If there's a very large tumor.
Moving forward to the next case, we have a 16-year-old girl presenting to us with delayed puberty, height of 144 centimeter, undetectable gonadotropins. Prolactin came out to be slightly high at 32, but again with a low cortisol. So, Dr. Subrata, what do you think of this case?
Short stature, low LHF.
This looks like hypothalamic cause, central cause for delayed puberty. Cortisol is low. Lactin is detectable and reasonable. So it's not high. It's not causing the low LH episode. So essentially, you have low gonadotropins, low cortisol, and you're short stature. Because at 12 years, you should be 150 centimeters.
Yeah.
You should triple your birth weight, birth height at 12 years. So this is MPH.
And this is the MRI.
Okay, so what is it? Looks like some vascular cyst.
Yeah, so this is enhancing.
Yeah.
And so every cyst should not enhance. So we discussed this in detail. So this is a congenital MKG due to rat case cyst. So I think this is the.
So basically, this is say sometimes even congenital defects can evolve over time. It may manifest much later.
Yeah.
So did you have a growth hormone stimulation test done on this show?
Yeah, the workup was done. She had all the deficiencies and all the factors. So this was basically a multiple pituitary hormone deficiency. Now, management, of course, is growth hormone, thyroxine, cortisol. The cortisol requirement and thyroid requirement is lower compared to a primary adrenal and a primary thyroid deficiency in central. And if required, ABP is given. But once you start treatment, if you start growth hormone, you expect cortisol inactivation to happen. So you may precipitate adrenal insufficiency. You may worsen thyroid deficiency because it may unmask hypothyroidism. That is important. Very importantly, when you start thyroxine, you may also precipitate adrenal insufficiency. And once you start, unmasking of DI may also happen if you start cortisol. This we discussed that if a patient with MPAP on steroids suddenly develops DI, that is because of cortisol. You are unmasking that. And if you give estradiol, your IGF-1, this is what Ved was talking about. If you give oral estradiol, you will cause growth hormone resistance and your TBG will go up, so you will unmask hypothyroidism. So one treatment may affect the other. This you need to be aware of.
But I think underscoring the most important thing, which I think you may have in one of the subsequent cases, is if it's MPH, do not start thyroxine supplements before you start it, because that's a disaster. The patient might go into shock.
That's the biggest message.
So moving forward to the next case, we have a 16-year-old girl diagnosed as a case of multiple pituitary hormone deficiency, received growth hormone, thyroxine, estrogen, now complains of lethargy and weakness. And we had a morning cortisol of 156 and a synactin stimulation test of 620. But the girl presented with fever, shock, and a low sodium. So can a low sodium present with a stimulated cortisol level that is more than normal?
I think this is the beauty that is highlighted in this case. What we have to remember from this child is, remember the drugs this child is on. The child is on growth hormone, child is on thyroxine. These are the two drugs which can precipitate or underlie cortisol deficiency or increase the requirement of cortisol requirement. Secondly, look at the third drug this girl has been started on, estrogen. Estrogen has an important effect on the cortisol binding hemoglobin production. It increases the production of CBG and causes a false elevation in the levels of both basal as well as stimulated cortisol. So what happens? Your biochemical tests are fooling you. Despite having a cortisol deficiency, all the biochemical tests are fooling you as if there is no cortisol deficiency in this time. So this is a situation where you should rely on a clinical and history rather than going into the factor of looking into numbers. I think the message from this case is estrogen can cause a false elevation in CBG and a false normal level and can fool us as if there is no cortisol deficiency or underlying activity deficiency, and we should immediately start this treatment of cortisol.
I think that's a very big message, and clinical pointers of central adrenal insufficiency, weakness, lethargy, all those things are very difficult to pick up. So very important message there.
Moving forward to the next case, we have now a 4-year-old boy with multiple pituitary hormone deficiency on thyroxine, now started on growth hormone at 25 micrograms, has free T4, which is very low at present. So can there be any cause of the same?
So this case of a 4-year-old boy with MPHD who is already receiving thyroxine supplementation again reinforces the physiology evolving around the anterior pituitary hormones, which tells us that when a child is on growth hormone supplementation, the thyroid metabolism is increased. So that unmasks the thyroid deficiency, and that is leading to a low free thyroxine level, even though the child is on hormone supplementation. So the message from this case is that growth hormone therapy unmasks the hypothyroidism, and that should be considered while replacing the thyroxine in this case.
So always remember the interaction. These three hormones can cause havoc here and there. And the primary point, low FT4, TSH below 20, start cortisol, look at cortisol before you treat. Second scenario, very common, hyperprolactinemia. So basically hyperprolactinemia, most commonly we think is because of pituitary tumor. There the levels are usually more than 200. That's what we're talking about, that, Dr. Sanjay. You can have a stalk compression because of an infundibular lesion. You can have a germinoma. The levels typically are less than 100. You can have a hypothalamic lesion, radiotherapy, again less than 100. So prolactin levels are very important indicators. Very importantly, pregnancy can cause hyperprolactinemia. The most common cause of secondary amenorrhea, the most common cause of galactorrhea would be pregnancy. So I think this is something you should always remember. And we'll discuss that. Drugs can of course cause up to 200. So levosulfide, domperidone, antipsychotics. Often these drugs will cause very high levels we see very commonly. Hypothyroidism up to 100 and liver disease, renal failure up to 30. Not really high in that perspective. We've already discussed two analytical errors in the afternoon session. The effect of macroprolactin, where there is no prolactin and you say it is high, do a pegylated study. And hook effect, where you have a very high prolactin and you say no prolactin, do a dilution study. So this we already discussed in the lab today. Very important issue of what Dr. Sanjay was talking about, prolactinoma versus non-functional adenoma. Non-functional prolactin will be less than 100. Size will be usually big and your symptoms will be much more. So if you have isolated prolactin symptoms, small lesion prolactin very high, that is more like a prolactinoma in that scenario. So if your level is less than 100 and the size becomes 10 to 20, it should be 200 to 1000, and more than 20 would be more than 1000. This is a slight correlation between the size of pituitary lesion and the level of prolactin. So you should then consider that in that scenario, and larger lesions with lower level. Now this is what the question was: cystic lesion, undifferentiated lesion, hook effect, and of course non-functional lesion. This is what you need to look at.
Now we had a 14-year-old boy who presented to us with gynecomastia, had breast stage 2, TV of 12 ml, pubic hair of 3, but had a LH which was 1.8 and a testosterone of 120. So correlating with the pubic hair and testicular volume staging. But can a prolactin of 120 not cause hypogonadism in this case? The MRI also came out to be normal. So Dr. Rishi, a prolactin of 120 not causing hypogonadism.
Two comments. The prolactin per se can give gynecomastia. So that is also important. And there is some contradiction when this goes, because what prolactin does, it suppresses GnRH. So because of this, there should be, we expect to be low LH, FSH or testosterone, which we are not seeing here. There is some mismatch. There is a contradiction.
So immunoactivity and bioactivity are not matching. That's what we are looking at. So that of course could be the macroprolactin which we discussed, and pegylated study will help in that scenario. So again, if you have high prolactin, no symptoms, think of macroprolactin. This is a message again to highlight this. Direct effect of prolactin on GnRH. Direct. GnRH pulse frequency becomes less.
This regulation, the lab people do regulation.
They can do, yeah. So it's like a chemical.
I try to understand regulation. So they attach some protein and then do it. It's like that, but are the lab people are doing it? That's my question.
Routine labs will not do it. You will have to ask SRL, especially you have to talk to specific labs. But this is a very rare scenario. We need to be aware of it.
No, but I think it is very important to do pegylation. About 5-6 years ago, we were not doing it in Apollo. And then I brought it to the notice, and one of the adult enrolls, who is a master in 53, we have to speak, and now we're getting the pegylation done. There is a very good lab, outstanding lab, Rohan Trivedi. It has, all the people from Bengal will know. And they've been doing pegylation for the last 10 years. So the important thing is, it is a facility. It is very important to distinguish, especially in the high levels of prolactin, and as to what the significance.
We won't discuss that. That is up to the lab. Yeah, carry forward.
So moving forward to the next case, we have a 13-year-old girl presenting with headache and visual complaints.
Dada, headache and visual complaints, prolactin of 60.
Prolactin 60 is not good enough.
So
unless it is the hook effect that you were talking about.
So this is the MRI. Labeled as a pituitary mass. This we discussed. We got the case also in the on-site course. Similar case.
Visual complaints are there.
Visual complaints are there. And this is the pituitary. It looks big, but it doesn't look monstrous.
Did you do it? I mean, there was no, I'm very poor at MRI. So, was there any circumscribed tumor-like thing, or to the whole?
It was a diffuse enlargement. But it was coming very close to the chiasma. If you had looked at those sections, you will see very close to chiasma, but it is a whole pituitary which is enlarged.
So is it compressing the stalk and producing?
It is just abutting.
Abutting.
And then, so this is not a focal lesion, it's a diffuse lesion.
But this is a completely enlarged. So maybe there is some other component of the pituitary gland which is hypertrophic. Like for instance, a thyroid.
So yeah, so uncontrolled hyperthyroidism. We said 50 to 100, and this is the absolutely right diagnosis. And we had the girl, and this girl was seen by an endocrinologist who had advised for surgery, IGF-1, a lot of other things had already been done. And she came, I think, in this spirit, the pituitary is already shrunk. So this is an important message that you may have a thyroid hyperplasia, which can cause a mimic like a mass lesion.
So there's another thing. When you, this looks like one of those chrysalis of pupa or something. But oftentimes, when you have this crucible-like cellular in children who are precocious puberty, you will see a bump like this, and the pituitary mass is increased, and that's different. That's normal.
Yeah, that's the same. This is the same thing. If you look in the sagittal coronal section, you will see the same sort of a thing. It was not looking like a lesion; it was like just a bump which was there.
Exactly.
I think it's small point. Never drive a car from right. We have a left-sided driving, so never drive a car from the right side. So whenever you see risk protected, before ordering anything, just look at that. Yes. Just look at that.
I think this is
the basic theoretical stuff.
I think that's a very important message.
Moving forward to the next case. Now we had a 16-year-old girl presenting with galactoria. So we clinically expected the prolactin to be very high, but it came out to be 34, only 34 in this case. The girl also had headache and vomiting. Now on MRI, we saw this lesion. So what can be the cause of this discorrelation between the clinical parameters and the biochemical parameters?
Thank you. I think it has been very beautifully mentioned that in the case of the tumor of macroprolactinoma, as the size of the tumor increases, the level of the prolactin has to go up. Here there is a total discordance between the level of the prolactin and the size of the tumor on the pituitary gland. So I think this is a clear case for us to look into what is really preventing this child from mounting a level of high prolactin. Is there a cystic or an undifferentiated lesion? Or is there a non-functional lesion that is compressing the chiasma and causing this sort of a picture? Or most likely, what is the case is the case of a hook effect. As described in literature, you would expect a serial increase in the level of the hormone with an increase in the size of the lesion. But when there is a hooking down of the level, as shown beautifully in this graph, you have this sort of a picture that you have a falsely low prolactin level and a size of the tumor which is producing a lot of prolactin. This is because the antigen levels overwhelm the antibody levels and cause a false decrease in the antigen-antibody complexes which are not picked up. So the solution for this is to run the sample again in dilution. The concentration of the antigen is brought down.
when you run it in dilution. So this synchrony between the antigen levels and the antibody levels are brought down when you run in dilution. And when a repeat assessment with dilution was done, I think the level was picked up and it was found to be high. I think this case highlights the importance of being a husband and wife relationship between the endocrinology department and the biochemistry department.
Where there should be harmony.
Moving forward to the next case, we had a 17-year-old girl with amenorrhea for 3 months. Breast 4, pubic hair 4, undetectable gonadotropins. Prolactin came out to be 500. So clinically correlating with the level of prolactin with undetectable gonadotropins.
So Neha. Yes.
So going back to the first slide which Anurag sir has already discussed, the most common cause of amenorrhea in a girl is pregnancy. So we have high prolactin levels, low gonadotropins. Next we are looking on the estrogen which is high, which again reinforces pregnancy as the cause of this biochemical picture. So best is to do a HCG level in urine or in blood, and HCG was done here which was quite high, which confirms the diagnosis of pregnancy. Always rule out pregnancy in such a scenario.
So that's what Ved was also talking about. Even if you have hypothalamic amenorrhea, do a HCG. That is a very relevant message. The big message is that HCG before MRI in a high prolactin. We have seen, even the fellows saw one case and the prolactin was high and then pregnancy was diagnosed later on. So this is a different scenario.
Moving forward to the next case, we have a 14-year-old boy presenting to us with headache. Again, a prolactin that is mildly raised at 80, and this is what the MRI shows us. So, Dr. Rishi, please enlighten us on this case.
Is it a functional, non-functional? That question basically.
As I shared with you, 80 is probably the reason with the level of stock, and it will give us any tumor. It may be most likely non-functional category.
So it's a large lesion and you have got not enough prolactin. If you are much in doubt, you can think of doing a dilution study. But if I go back, this clearly looks like there is a peripheral rim of tissue, which is already there, which suggests that this is not a pituitary lesion. It is coming above, below. That is what it is. So this is most likely a cranium. It is very important to differentiate. If it is a prolactinoma, you give cabergoline will respond. But if it is a cranium, you will need a much more robust surgical approach.
Protective values are also important.
Yes.
The tumor that you mentioned, my understanding was more than 100 is tumor, but you categorically said more than 200. But there are number of verses. Some is more than 200.
Yeah.
Or here it is classically less than 100.
So this is very classical. We'll finally quickly go through the AVP pathway. We all know that if you have a lesion in the hypothalamic axis, you will have diabetes insipidus, in which you have dilute urine and concentrated blood. You can have congenital lesions, but mostly it is acquired. Acquired DI is a hallmark of a pathology. You may miss germinoma, you may miss other conditions, so this is important. Nephrogenic DI is usually congenital, presenting at 6 months to 12 months of age with dehydration, failure to thrive, developmental delay. That is what is common. Evaluation of polyuria we discussed in detail. If you have polyuria and you have excluded common things, do a water deprivation test. A urinary osmolality less than 300 DI, do a AVP response. 300 to more than 800 rules out DI, and then you can carry forward in terms of evaluation. This was discussed in much detail yesterday. Very importantly, central DI, your work doesn't finish. Do MRI diagnosis and follow up, because you may pick up lesions later on as well. So now we'll quickly go forward.
This is a 10-year-old girl with a diagnosis of craniopharyngioma, had neurosurgery, went into polyuria at 5 ml per kg per hour, was given vasopressin to check this polyuria, went into seizures with a sodium of 128. Sir, to correct this DI, the patient was given vasopressin, but is it possible to go into 128 with the same dose of vasopressin?
Basically, if you see the cycle, initially there is transient DI, then there is SIDH, and then there is permanent DI. So the triple phase. So this transient DI, there is no need to start really intervening. Just fluids is good enough. Monitoring is important, And I think when they will slip from GI to SIDH, you will have to, it's like timing the market. You cannot do that. So you just watch carefully, let the SIDH express itself, and then you manage it by restricting fluids and other things. So the important message in this case is it's very dynamic, and I think Neha is an expert on that, and she should have been given the question. She must have managed by in 3 months about 500 of these. So I would like her comment.
Not exactly 500, but 5 such cases, and all the 5 cases we have seen that the time point. The studying in book the triple phase response is quite easy, but when we see on the picture, we cannot comment when the DI will change into SIADH, and that is very crucial for the patient. And neurosurgeons who have spent hours in the surgery, they will not like if you mismanage their patient. So it is better that we observe, wait and watch for the polyuria to settle down, and if there is hyponatremia which is causing signs symptoms, then only we should poke our fingers, otherwise just wait, watch and take the vaccine in such cases.
Now, on follow-up, this child has now developed hyponatremia, lethargy, and weakness. So suddenly his DI is gone. So what do you think, Dr. Subrata, is happening?
Yeah, this is actually a very important concept that DI is masked by cortisol deficiency. In fact, there was this one case which, with your kind permission, we'll talk about a 12-year-old girl who presented with severe hyponatremia, like a SIADH, cranioparathyroidism. And well, even before I got there, the adult intensivist had given 3% saline, this, that, and all. So the moment I saw that, I basically stopped everything. I sent off the labs, and assuming this to be an MPHD, started cortisol first. The thyroid report came just like that, and that was low. Cortisol just like that, it was low. So I started cortisol, and guess what? The DI was unmasked, and then from a sodium of 110, it swung. It was swinging. I mean, with somebody on 3% saline, stop that. And that is a very important message that cortisol deficiency can unmask, can conceal, mask DI. And once you do the replacement, DI comes out.
So as I said, if your calcitriol requirement comes down in hypoparathyroidism, insulin requirement comes down in diabetes, blood pressure requirement comes down in hypertension, and your AVP comes down in this thing, think of cortisol. So think thyroid to think cortisol. These are the 4 basic situations you have to think.
So now a 3-month-old girl with dehydration and duffy skin. Hypernatremia in this case with a low urine osmolarity. Concentrated blood, dilute urine. Advised a water deprivation test in this case, went into seizures, thereafter found to have intraventricular hemorrhage. So Dr. Himchand, do you agree with this line of management?
I think the writing is on the wall. When you have a concentrated blood and such an inappropriately dilute urine, I think the writing of diabetes insipidus is written in the face of this blood. I think water deprivation test was like pushing her osmolarity further and pushing her into these complications. So I think it is very.
So this was like a suicidal move, basically.
Homicide.
Homicidal. Not suicidal, this was homicidal.
And guess what? In the renal algorithms, they have, unless the sodium is more than 150, we will do a water deprivation. But it's clear 145 and above, and a serum osmolality of more than 300, you do not do a water deprivation.
I reviewed the case report in which they said we did a water deprivation with a sodium of 170. So that is like, no, this is a true case which was sent for report also, like they reported also. And so, and then patient developed seizure. So this is from that report, not from our place.
And they published it also to show. This is like a series on rhabdomyolysis in the management of type 1 diabetes DKA. If you poorly manage it, if they have hypophosphatemia, which is too long, they'll get rhabdomyolysis. But guess what? We had 5 cases of rhabdomyolysis to that institution. We're going to give a talk very shortly.
Moving forward to the next case, this is a 12-year-old boy with central DI for 2 years. A normal MRI at baseline, started on vasopressin, DDAVP, had seizures, headache, a sodium of 142 in this case. So what do you think of this case, Dr. Neha? Why did the child suddenly go into seizures?
This concept has already been described in the initial slide, in which Anurag sir has clearly pointed out that even in a case of central VI, if you have a normal imaging at the baseline, it should be periodically monitored, which is 6 monthly for the initial 2 years, and then depending upon the finding, it can be monitored subsequently. So this case had a normal MRI at diagnosis, or 6 monthly routine monitoring should have been done in this case, otherwise the lesion was missed.
Thank you, Dr. Neha. Moving forward to the final case from DI. It was a 3-year-old boy presenting with polyuria, had a high sodium, again a low osmolality, but in this case had rash. So what would be the diagnostic test to diagnose this clinically, Dr. Subroto?
Clinically?
No, radiologically. Simple radiology.
Simple radiology, take an X-ray of the skull, lateral, and you will see little holes in it, and that will be suggestive of LCH. Now the nomenclature has changed, and localized histiocytosis, diffuse, etc. But yes, that. And
so of course, so it's 2 to 5 years. Always think of histiocytosis. Now he was planned for chemotherapy. Advised hydration. So you're giving fluid on one hand, AVP on the other. The child will have a lot of problems. So how do you manage in this scenario? There will be fluid overload which may happen. So what is the best way to manage in this scenario?
I think you can give an empty infusion because you can regulate that. Yeah. And that too, see, during chemotherapy, what these guys do, they do this hydration, pre-hydration, and they pour liters of fluids. Now, the other way of looking at it is, since anyway this patient has PI,
you stop everything.
No, उसको पानी दो, क्या होता है? The sodium will slowly settle down. Because if you don't give water or give less water, sodium goes up. If you give more water, the kidneys are working because it's central. So get rid of the water, and you will have so without doing anything hectic, just monitoring the fluid balance and the amount of fluid ins and outs. You don't output ins and outs. You keep monitoring.
So again, LCH very important, 2 to 5 years, and then skeletal survey crucial. Low dose DDAP with required in that chemotherapy. Final section on SIADH. Remember, SIADH is opposite of DI. You have concentrated urine and a dilute serum. So your serum, basically what you're looking at is serum osmolality less than 275, urinary osmolality more than 100, but you have to exclude adrenal, renal, thyroid, and liver abnormality. This is a diagnosis of exclusion, and you have to exclude hypovolemia because hypovolemia shifts the curve towards the left side, and no diuretic use and no response to saline. So SIADH is every euvolemic hyponatremia is not SIADH is the key message.
We had a 14-year-old boy with drowsiness, euvolemic, a sodium which is 100 and a urine osmolality which is 300. So diagnosed as a case of SIADH right away and advised fluid restriction. So do you agree with the line of management, Rishi sir?
I think again what Dr. Anurag has mentioned, we have to rule out adrenal deficiency, we have to rule out hypothyroidism, diuretic use, and any fluid deficiency. When we have done all this, then I think we can get it. Then we have to find out what is the cause, whether it is central or some lesion in the lung or something. So once we diagnose, then we have to look at the cause.
So there was multiple pituitary hormone deficiency. So very much you have to exclude deficiencies before you diagnose SIADH.
So we had an 11-year-old boy with traumatic brain injury, admitted in the ICU, improved with management, but had seizures again on day 2 with a sodium of 125. Now, they were the ICU team called us with a referral that how can they differentiate between SIADH and cerebral salt wasting in this case. So how do we proceed in this case, Dr. Hemchand?
Very good. I think this is a classical case of hyponatremia in a sick child with neurological problems. Remember the 3 musketeers: SIADH, cerebral salt wasting, and DI inappropriately managed. Because it was not inappropriately managed, the 2 differences coming to our mind with SIADH and cerebral salt wasting.
SAADH salt wasting, the important differentiating tool is clinically look at the volume status. In a child with SAADH, you don't have any signs of dehydration. It's a state of euvolemic state, where salt wasting, there is pouring out of sodium and water from the kidneys, so the children are usually dehydrated. I think that is a very important differentiating point. And second important differentiating point clinically is look at the urine path. If there is pouring out of urine, it supports the diagnosis of cerebral salt wasting. If the urine output is on the lower side, think in terms of SAADH. Of course, biochemical parameters like urine, sodium, etc. will be an important tool. The icing to the cake would be the uric acid level. Uric acid is one important metabolite which gives you an indirect reflection of the volume status of the child. So when you have a child with very low uric acid levels, that supports the diagnosis of SAADH. The important message from this case is uric acid. Uric acid low suggests a diagnosis of SAADH. So the SAADH, the important thing is prevent it, anticipate situations where they are likely to occur, prevent it, and if it has occurred, use judicious fluid management and prevent it from progressing.
You will say. So I put two important comments which I want to share. One is I have a normograph which I think we have. Yes, Hopworth, which I want to. I'm sure you have it. I can send it to you. You can please share it with them.
Yeah.
It helps from an endocrine perspective because I just use the normogram and suddenly I know where I stand. That is one. Second is in water balance. It's always intake output before anything because you have to be compulsive about it because you want to see how much. Like in CSW, tons of urine being passed, whereas in SIDH, it's not. Don't look at serum sodium, the urine sodium, they'll be both high in both the cases. But having said that, the osmolality can help you a little bit, but ultimately it will take output, and just by judicious fluid management, you can overcome. And the second point is that unfortunately, cases that way, you'll have a sodium of 118, 120 with lots of urine coming out. You keep giving saline, and then a point comes whether to how much fluids to give, and those are some challenges which, in fact, Neha must be facing right now because she encounters cerebral salt wasting a lot, and sometimes you're just chasing your tail because you are giving more salt, more fluid, and still the sodium is not coming. It's the challenge.
In fact, I'm not an expert in managing such cases, but from my experience in the last 15 days, there was an adult case with traumatic brain injury, and we had to give nearly 11 liters of fluid in 24 hours. So that was a surprising point for me, how much fluid to give. But because the intensivists have been managing such cases, so they have told me that they have gone up to like 11, 12 liters in a day to change the sodium value. So they can do that.
I think this is finally the last case which separates us from dinner. So Dr. Sanjay, you will ask in the dinner only now.
So this is the last case for Dr. Neha. This was a 13-year-old girl with a diagnosis of tubercular meningitis presenting with drowsiness, low sodium, high urine osmolarity. So a low sodium with a high urine osmolarity, but the referring doctor already excluded cortisol and thyroid hormone deficiency, was diagnosed as a case of SIDH, but here also treated with tolvaptan. So what do you think of this case with a child being treated with tolvaptan?
As we can see, this is the case of a tubercular meningitis. So this child has a background diagnosis which could be responsible for the sodium-related disorder. So jumping onto tolvaptan was not a right choice. We should have first managed the intake-output fluid in this case. And as usually explained in the algorithm of sodium management here, we can go step by step depending on whether the sodium disorder is an acute or chronic and whether it is symptomatic or asymptomatic. And accordingly, we can follow the algorithm given on the screen.
So I think again, baptans in acute situation is not a very good drug. Only in adults, chronic, you can use it, not at all in adolescents because it's because rapid rise. So this is a very major issue in terms of that. So I think this was a marathon session, but we covered in nearly 3 big aspects of pituitary. A big hand of applause to all the panelists and experts who were there, Dr. Hemchand, Dr. Subrato, Dr. Rishi, and Dr. Neha. And I'll invite Dr. Mahesh to kindly give a memento to Dr. Hemchand.
And the person who has to be congratulated is Anurag. He is standing on his feet, not just for today, from 8 a.m. or 8:30 a.m. for the last 3 days, and he is still fresh as a daisy. So, what is the secret of this? That he must mantra, he must share with us.
She is having 4 surgeries continuously.
Okay, and she's coming tomorrow, right?
She's coming tomorrow. She has a session tomorrow. So it's been a long day for both. So, but it was a wonderful day and glad to have everybody. All of you must be tired. So, just before we stop, we'd like to honor Dr. Hemchand, who has come all the way from Chennai, and he has been a real gem for our programs. And we will have the bone age tomorrow. So, 2 of his wonderful sessions. So, if you want to listen, you have to wake up at 8 o'clock. Come directly at 8 o'clock. The breakfast will be served a bit early. We have told them to serve breakfast early because a lot of people are going at 10 o'clock. So that is another issue. So we want at least the first 2 sessions to be held in a proper fashion, including the ovaries and these 2 sessions, because these will be quite relevant. I thank all of you, and we all welcome you for dinner. And thank you.